together. So come here, come close to the LED screen, come close to the stage. This is where we are going to be. And then there's some music that Ron has for us. We're just going to test it. It's
Recording in
session,
progress.
But I want to see who has more right knees than left knees or more left knees than right knees. So Ron, just give us something. Give us, maybe not the Anguka Nayo, let's do like the old school one first. Angie and Phil, I see you're seated. If I knew your mother tongue, I would speak it. Madam Aswila, I see you're seated. The problem is, join me here. Come join me here. Everybody, we are doing a recap session, but it won't sound like recap because, of course, I'm going to ask you a question. Welcome. Thank you for caring about time and being here on time. We are so glad to see you. It's slightly warmer today than yesterday, right? That is an answer to prayer. Whew. Yeah, circle, just a nice circle. Yeah, so Phil, go stand by Miriam. Miriam is, oh, no, she's moving. Go stand, yes, thank you. Yes, I want to separate you from your, So we're gonna, this is going to be fun. Yeah, Esther, go elsewhere. Hi, Esther. In case you don't know what Lydia's duplicate looks like, meet Esther. And there's another Esther there, I see. Hi. Okay. So good morning. I'm going to pass the mic, and you're going to answer two things. First, my name is Ruth Pearl Nganga. I'm a part of a choir, and I'm from Kenya. So you'll say, my name is Angie.
My title? Is that what I'm doing?
Country title,
I'm from the United States. I work with Mary sometimes. I'm a consultant. Yes. Okay. Not too much information. I'm from the U.S.
Yes, that's enough. And then the third, so this is the third thing. And so I want you to pay attention to the third thing. Yesterday you gave me your CVs. Don't listen. I'm not asking CV. What from yesterday have you talked to someone else about?
What?
Yes. So what happened, something that you had yesterday. Now, if you were not here yesterday, then you tell us, that person who invited you, what did they tell you to come? And it needs to be in one bullet point. The second one, I'll stop you, because we only have 25 minutes, okay? So Angie will call on somebody. So I'll call on Angie. Angie calls on somebody. That person calls on the other. So we need to do it like popcorn, very quick. My name is Ruth Pearl. I'm from Kenya. Yesterday, I couldn't stop thinking about the story of the patient provider. Something like that. You hear? So that goes quickly.
Okay. Start.
Yes.
My name is Angie.
Don't call on Phil.
I'm from the United States. I could stop thinking about the product and service presentation. And I'm calling on Grace.
Yay. Okay.
Faith. Sorry. I don't know names. I thought it was your name. So.
This is how we're getting to know people's names. No, quick.
Good morning. My name is Faith. I couldn't stop thinking about the quote that you have to be a little more kinder than is necessary.
Absolutely. Next.
I am calling on Agnes.
Good morning, everyone. I am Agnes. I remember about Dr. Peter Lackman's presentation on kindness and how as a leader you should come up.
Volume up, please.
Volume up.
Not you, them, sound. I'm not hearing.
Oh, all right. That as a leader you should take front when things are not running well, and your team should take the front when things are being celebrated.
Wow.
I call upon Dr. Beatrice.
Yeah.
Good morning. I'm Dr. Beatrice from Kenya, ENT surgeon, and yesterday I learned that, and that's what I do every time, I smile to my patients.
Hey.
I call upon Olatuji.
I couldn't stop thinking about, that is what you're answering.
Good morning.
Good morning.
I'm Dr. Lan Raju from Nigeria,
Yesterday, I learned so much about the Philippines incident reporting, so I couldn't stop talking about how to improve our own quality incident reporting in Nigeria. So I'll call upon...
This is how we clap over here.
I'll call upon Dr. Mattis.
Doctor?
Mattis.
Ah. I was like, Mati. I was looking for the S.
Good morning, everyone. My name is Damilola. I'm from Nigeria. I couldn't stop thinking about the mango moments, how every little act of kindness builds up.
Yes.
I'll
Okay, pause. We are struggling to hear each other as sound. I don't want to have to say that again. Kindly help us. Thanks. So, you're calling on?
BC, Dr. BC Ogudbasha.
Why are you calling on BC? We already know you know BC.
Morning, everybody. My name is BC. I'm from Nigeria. Yesterday, I couldn't stop thinking about the important role of leadership in all we're doing. I'm calling on Mary.
Good morning. My name is Mary, and I live here in Kenya. Yesterday, I couldn't stop thinking about the importance of listening and Dr. Lockman's story that if you have a sick neonate and you haven't listened to the mother, you haven't got it right. And I shared that with my husband.
Good morning. I'm Alphonse Chandika from Tanzania. I couldn't stop thinking about injecting the DNA to medical students and on service training about patient safety and the quality of care. Thank you.
Hand over the mic. You don't have to know the name.
Good morning. My name is Modoni. Like Angela, I was really thinking about the product and the service and how the service part has to be underscored by kindness all through.
Yeah.
Good morning. Good morning. My name is Aswila. I couldn't stop thinking about his story and her story. And it seems at times we overlooked that, and I even shared it with my husband. Thank you very much.
I like people who share with the people in their houses.
Good morning. I am Winnie Karuga from Kenya. I couldn't stop thinking about kindness as a glue for cooperation. I pass it to...
Good morning. I'm Grace from Kenya. Yesterday, I learned about kindness, just what she's highlighted. One of the things that I was reflecting on was how do we put the DNA from the first entry as a medical student before you just get to, to work? How do we insert kindness? And I shared with my colleagues at the table before we left.
Oh. Good morning. My name is Maureen from South Africa. The one word that caught me is being present. Thank you.
Good morning. My name is Caroline Kendi from Kenya. I couldn't stop thinking about Dr. Peter Lackman's conversation about patient story. How do we let them tell the story?
So let's pause for a moment. I don't know if there are people online. John, are they answering the question? Their names in the chat. Please make sure the chat is enabled. Their name and what they couldn't stop thinking about from yesterday. Keep going.
Good morning. I'm Salome Rajab from Kenya. What I couldn't stop thinking about is how to involve the leadership to buy in, so that we can continue with this journey of patient safety. Thank you.
Good morning. My name is Lillian from Kenya. What I could not stop thinking about is the incorporation of quality in the training institution. Thank you.
Now is the sequence and series.
It's okay.
Thank you very much. My name is Dr. Mugisha Antionza Nkoronko from Tanzania. I didn't stop thinking on how to engage the community, the citizen, into the concept of population health and to see it that it's a reality. I pass as I got it.
Habari ya asubuhi. My name is Bernard Omondi from Nairobi, Kenya. I couldn't stop thinking about Dr. Olatunji's conversation about M&M. He talked about mortality and morbidity review, and that's one area that I'm struggling with. So I can't wait to have a moment to just share with him. Thank you.
Look for him over tea break. Let's go to Phil.
Good morning. My name is Philip Donaldson. I'm from the United States, and I couldn't stop thinking about how the patient experience can have an impact on how people feel about healthcare broadly, and that's why it's so important to treat people as people and not just as a statistic or another appointment.
Good morning. My name is Lydia from Nairobi, Kenya. Yesterday, I think following session 3, I couldn't stop thinking about to what extent do we blame the healthcare worker for mistakes, and how can we address that? Culture of patient safety. Yeah. And
okay. Good morning. My name is Yobit. I work for Ministry of Health Ethiopia as patient safety coordinator. I just remember yesterday's presentation is about being present for the patient. Thank you.
Good morning. My name is Gerald from Kenya. I remember yesterday about Ubuntu. Ubuntu. We have because.
Morning, I'm Dr. Kanji from Kenya. I couldn't stop thinking about how much our medical students, our nursing students are missing these wonderful concepts about quality. Thank you.
Good morning. I'm Brian Otieno from Kijabe, Kenya. One thing that moved me was that healthcare is about storytelling. So we need to be listening, observing, to have those storytelling skills. Then I also loved that it came out from this forum that there is a desire to take quality health, the QI, beyond the walls of the hospital, to the communities. Thank you.
Good morning, colleagues. I'm Dr. Tenza from South Africa. I couldn't stop thinking about the gaps in training for quality. More especially, it took me to think about why do we circle for non-formal training, like not pushing for degrees, masters, PhDs, formal qualifications that are focused on quality and safety in Africa.
Okay, good morning, everyone. So my name is Cynthia, and what I learned from yesterday is the word being intentional. That word, I've carried it since the beginning of the year, and it made me even happy because I heard it also yesterday, that we all need to be intentional in terms of handling our patients and in whatever we do. Thank you.
And now we get to hear from the online people. Don't worry, I'll come back to this mic as well. John from Kenya, I couldn't stop thinking about mango moments symbolizing kindness. We see you. Dr. Omotayo, I couldn't stop thinking, so John, you need to scroll so that I can actually read it. I couldn't stop thinking about the fact that we hide the story of our patients from them, despite the fact that they told us the story. We end up hiding it from them. That's an interesting one. Okay, I see Anne saying, kindness and presence concepts were my takeaways. Felicia saying, I couldn't stop thinking about incorporation of patient safety. I couldn't stop thinking, okay. Incorporation of patient safety incidents as a module for training health personnel. If this is voiced out, it will make a huge difference in patient safety. We are reading you online. Let's hear from more of the people in the room. Go ahead.
Good morning. My name is Dr. Victoria from Kenya. I couldn't stop thinking about the Tanzania incident reporting system of no name, no blame, and no shame.
Did you? Where's Mr. Tanzania? We are glad you're here. You see? Thank you. Go ahead, Dr.
Good morning. My name is Oduoro Otieno from Kisumu, Kenya. I couldn't stop thinking about the fact that our healthcare organizations are not ready for the students. When Peter's faculty sat and said, we give them a little bit of these things, but when they come to the institutions, you people are not ready for them. I think that is my aha moment from
Wow.
yesterday.
Yeah,
Thank you.
maybe we shouldn't be blaming the institutions.
we shouldn't be
maybe we
blaming the
blame
faculty.
ourselves in the hospitals
But the
too.
healthcare institutions
we
are
share,
not
okay,
ready for the
but we are
students.
going back to Tanzania.
Okay.
No blame. Peter, do you want to go next?
Exactly that, actually.
No, then pass it on. Don't repeat.
Yeah.
Hello, guys. My name is John Moniki. I'm a student from the University of Nairobi. I'm really glad that you are making effort to help us. Thank you.
Okay. So, pause. We are obviously not going to get to everybody. But I think we are getting it. That we did catch a fire. That coal did warm up. I hope you're feeling the excitement. There is something we can do with this information, with this knowledge. There's a change, a next step we can take. Now, Ron, I need you to give me the music. You need to drop that bit. I'm ready. Are you? No. It's a video. He's going to show it to us. It's a video. We need to see the video. Yeah, because we are going to practice. There's going to be a moment when we will really show our real styles. Now, me, I have 2 left feet, but I'm unashamed. I feel it. So will you join me in feeling it? Ron, I'm waiting for you. It's on it? It's audio, no video. I need video. Find me a video. You sent me videos yesterday. Show me video. So do the YouTubes first. I want, in the meanwhile, as Ron is figuring it out, by the way, Ron is this fabulous comms officer at Acquire. We need to just do this for him. He's outdone himself. Is there something some lesson, something you're thinking about that you haven't heard mentioned? Because we are obviously not going to get through the 100 people in the room, but I want to make sure we hear every thought. So something that you thought about and you haven't heard mentioned. Okay. Okay. Oh, there's a mic there. Go ahead.
I'm Manyu Simon from Vihiga County. Yesterday, as we were talking about the incident, I was really reflecting about this healthcare worker also who go through a lot. And I was looking at it like their voice. How are they heard? How can they be reported? How can they get the feedback? Because most of the time, we might report, but we don't get any
So
reply.
the feedback loop is the
Yes.
issue. If you go ahead and you're really good at reporting, but the system doesn't come back to tell you
Yes.
what happened.
Yes.
Guys, are these things we need a foreigner to come and help us solve? You know, sometimes I just wonder, surely, these intelligent people in this room, now, we've had our moment. I think this is we've recapped, right? Over to you, Ron. I said, this is the practice session. So I want to make sure that you are ready. Please don't. Yes. This in Tarab, usually walk back to your seat like this. Please walk back to your seat like this. Yeah. We can walk back to our seats in the Tarab fashion. Today there will be some music and some dancing. That's good. I think we can stop there. We can stop there. Now I will ask the planning committee to come and join me. And we'll take a few minutes from the next session. Join me over here. Tenza, why are you sitting? Join me over here. So if you're in the planning committee, Odwar, Faith, Dami, come. Mutanda. So are you. If you see Tenza, she's one of the most complimentary people, so you can guess what she just said to me. Where is the planning committee? I saw Mutanda, Bernard, and Lavinia. Yes. Lavender, sorry. Okay. So, this planning committee is going to answer the why. You see, they've spent 2 months meeting every single Monday, doing all this work to plan our being here. They've put all their thoughts, their good ideas into this program. And I told them I would give them 30 seconds, okay, maybe a minute, to tell us why. Why are they in QI? Why are they working in patient safety? What's their backstory? What's their why? And please don't give me something that I will find on your CV. Give me something I can only find in your heart. I'll start off with Lydia. Mary, are you not part of this planning committee? Oh. Oh, okay, fine. Okay, then let me offer whoever wants to go first. Okay, whoever wants to go first. Wow, Angie, I don't know why you're not here, Angie. Okay. Oh, is Rhoda here? Rhoda, why are you not here? I didn't see your face. Your why? Go ahead.
My why is that behind all of these conversations.
So, no. My name is Faith Lele.
Oh, sorry.
I am Kijabe. Okay.
Retake. My name is Faith Lele. I work in Kijabe. My why is behind each of these conversations is a patient. In the last 4 years, 4 of my relatives have had a patient safety event, even as a doctor. So it doesn't. We are all affected. There's a patient behind each of these conversations.
Wow.
No. They are refusing.
Report them to me.
Good morning, everyone. My name is Oluwadamilola Matsi. I'm from Nigeria. I'm the executive manager for the Society for Quality in Healthcare in Nigeria. For me, I feel like we can't blame people for what they don't know. And as the conversations have shown, from medical school, we're not really taught about quality. We don't know a lot about quality until we get into the hospitals. So for me, my why really is getting people to know, training people, getting people to know everyone. Quality is everyone's business, from the security guard to the cleaners, to the doctors, the nurses. All of us are responsible for the quality that our patients experience. So that is my why, getting the message out there, getting all of us to understand that having that one patient have a good experience is all our responsibility.
Good morning. Yeah, my name is Peter Mtanda.
Is it me or is it the sound? Okay, keep going.
Can you hear me? Maybe it's me. Yeah, so my name is Peter Mtanda. So for me, it's I have so many whys, but I think the one that really sticks out is when I was working somewhere in a maternity theater, and then I was assisting doctors conducting some surgery. Then it was like an elective cesarean section. I think it was on a Saturday morning. So this patient, he was not a patient. This woman died on the couch on the operating table. It was my first time to be in such a situation. And the surgeon and the anesthetist disappeared. And everyone disappeared from the unit. So I was left alone with a body in theater, waiting to break the news to the relatives. So it was a very long story. Of course, when everything was done, we realized so many mistakes that were made by the whole team that resulted into that mortality. Yeah, it's always still very fresh in my mind. Yeah.
Thank you, Peter. Wow. Okay. Give it to Mary.
I got introduced to quality in healthcare as a young student in class 8. I had spent 2 years on crutches and was having my 3rd knee operation. I had scars on each knee. And I had nightmares that they'd operate on the wrong leg. And so I fought the pre-anesthetic until they started scrubbing the knee they were going to operate on, and it was the wrong knee. and I yelled, and they weren't used to people who were pre-anesthetized yelling. And then they were like passing the chart around. Is that a left? Is that a right? Which one are they? And I'm like, it shouldn't be like that. That's my why.
Wow. And you got surgery on the right knee? Because
I
you
got
yelled.
surgery on the right knee because I, as a 12-year-old, said, don't do it wrong.
Good morning, colleagues. I'm Dr. Tenza from South Africa. My why is around advocacy for quality, because all healthcare providers are working towards giving good care to the patients, but nobody faces it that it is not care if it's not quality and if it's not safe. And somebody has to advocate for that. And most importantly, there are people in the communities whom we stand as advocates for them based on the knowledge that we already know, whom they cannot be able to ask more because they don't know better. So somebody like me and you, we've got to stand at the gap and push the message and empower.
Good morning. My name is Odoro Tieno. I live and work in Kenya, Kisumu, Kenya. I work for Systems Evaluation, a health system business consultancy. So my why goes back. As a young clinician getting into practice, I got into a practice at the level whereby the service that I was offering had just been proven from research. You know, when you come from research into now implementation. And the service that we were providing was a surgical service. And the surgeons in the house know that as opposed to physicians, the surgical service gives you your outcomes almost instantly. When the patient comes back for the review, you get to see the work of your hands. So providing male circumcision, medical male circumcision to clients, you'd always see when this client comes back on the 7th day, what you actually did. That was the beauty of it. You see? You would actually see what you actually did 7 days ago.
Whether your cut was good.
Whether your cut was good, whether you placed wrong stitches, and by that time, the clinical evidence said that, okay, do 8 to 12 stitches. So you'd see who did 8 stitches, who did 12 stitches, and who did 3, some did 4, and you'd see the outcomes. So I was like, wow, this information is already available. But us guys, we are not looking at it, okay? So my why really now started building up. There's that knowledge, the clinical sciences knowledge available, but we are not translating this into practice. So my why is, how do we get the knowledge in clinical science into practice? And getting this into practice, how do I ensure now at my level I'm feeling like, yes, I may get this into practice in my small corner, but I want this to be the practice everywhere in every healthcare setup across the place. So that is my why. Thank you.
Okay.
Good morning. My name is Bernard Omondi. I'm a quality champion at Metropolitan Hospital. My why is personal, and I'll pose it to you like this. Pretend for a minute that you're in charge of healthcare in this country, and then you fall sick, and you say, take me for treatment to South Africa, take me for treatment to London. You are responsible for healthcare here, but you don't want to use that service. So ask yourself the same question. You're in charge of quality at this hospital and that hospital. Then something happens to you and you say, take me somewhere else. Aren't you proud of what you're doing in that institution, such that you'd say, if something were to happen to me, I know what I've put in place there and I'll benefit from it. So I asked myself that question, and it is my why. Thank you.
Hi, my name is... Hello? Can you hear me? Hi, my name is Angie Donaldson, I'm from the United States, and I'm really happy to be here. I have two whys. I have a research and evaluation background in community and economic development, and I see the work you're doing here as pretty amazing, not just informing healthcare, but the way community and economic development works in other contexts. I work on the US-Mexico border, and I see a lot of parallels with the work you're doing in building a whole system, really, to support this amazing work here in Africa. The second why I have is my grandfather died of medical error. So he was on a hospital for 3 months, and he didn't receive the kind of care he should have received. And I'm not a doctor, so I didn't know that. But my sister-in-law's father found out and was able to intervene, but he intervened too late after there was sepsis. And so that is also very personal to me, the work you're doing in quality in healthcare.
Good morning. My name is Lydia. I work for Kenyatta National Hospital as the Director of Healthcare Quality, and I'm glad to be here. So my why comes from my background is in obstetrics and gynae, so that times we'd get into the labor ward and whatever is happening today seems like it could have also happened yesterday, and the capacity for us to learn in terms of how can we reflect as a system. So when I was thrown to support hospital-wide quality and safety, my why has been, are we seeing what is happening? Are we thinking about it? And are we learning? And are we being vulnerable enough to learn that this is our state? So my why is if that could be different, if we could reflect more, meaning truly knowing this is what the patient is experiencing, this is what we are doing with regard to this standard procedure, because there are many things that happen all the time. When I come with an acute abdomen, it is an acute abdomen, and the approaches to it, it's possible that if we reflect on why we failed yesterday's acute abdomen, tomorrow we'll do better. So my why is the health system reflecting, and what is my contribution? What is my contribution? Yeah, that's my why.
Good morning. My name is Rhoda Kalondu. I work at Kenyatta National Hospital in the patient safety unit, and 2 other units that I support. My why, I don't know. I don't know my why. One day I'll meet Simon Sinek and ask him, why did you bring this concept? Because I think it's a question we get asked every time. I've not yet figured it out. I know there's a why. Maybe when I'm 60, 70 there, I will figure out what I'm supposed to be doing and why I'm doing it. But right now, what I can say for a fact is that every day that I wake up, I want the healthcare system to be different, to be pleasurable, to be enjoyable, to be safe for the patients, and any patient who comes in, especially in public sector, I'm not talking about private sector, I work in public sector and I get so much joy working in public sector, especially in public sector, that they leave there with a smile. That's a fact. Now for the why, I'm yet to figure it out.
I love Rhoda, and I'm grateful for her, because you see, it is important to keep questioning your why. It probably changes from day to day, but being very clear why we are doing it is so important. And I'm grateful for the planning committee, each and every one of them. Amos, I hope you're going to give us a nice photo together. And I hope you've heard their stories, because these people took time out of their day-to-day lives to come and plan and think and offer their capacity to us. All of them have very busy full-time jobs, and I don't think the word thank you is enough. I hope that their whys will thank them. I don't think the word thank you from a choir will ever be enough. But I hope you hear their stories. I hope you reach out to them, because they are the real experts when you need help. I hope you don't worry or wonder about a problem you're having in your institution without remembering that there were people who share your whys. because I bet you your why is echoed somewhere on this queue. So please join me in doing that thank you to everybody from the planning committee. There is one more, Dr. Elom Ochi from Ghana, but I think it's a bit early in his day to wake him up and he's virtual. But Elom, we are saying thank you to you as well. Okay. Did you get the photo? Okay. And Dr. Lachman, forgive me, I've taken 11 of your minutes. Thank you, everybody. Thank you very much. So, obviously, I think we figured out by now, of the three in Akwai, I'm the one who didn't study medicine. So, I'm newer to the concepts than most. And I remember when I first started reading and Mary would try and tell me about them, I was like, what is this difference? What is quality assurance? What is quality improvement? And then when we started meeting Dr. Lachman, we started hearing co-production. And then I became comfortable in my not knowing because I realized we are many who don't know. So hopefully, this next session will allow us to clarify what is this journey from QA to QI to co-production. What does it look like? That's what this next session is about. So I want to invite Dr. Faith Lele and Dr. Mati Ajayi from Nigeria to come. They are leading the session with Dr. Lachman. They have a great session prepared for us. Whether you're online, whether you're in the room, they have thought about you. And by the end of the session, I hope you'll have a couple of tools, a couple of resources that you can go, because we are still learning, go and look at, go and subscribe to, go and follow, because we are still learning. Okay, over to you.
Thank you, Ruth Paul. Morning, everyone, again. For the third time, my name remains Faith Lele, and I still work for Kijabe Hospital. We hope we will have a nice 90 minutes or less. Ruth Paul, how many? 90 minutes. I'll give you 10 minutes extra. Okay, sawa. I'd let my co-facilitator introduce herself.
Like she said, you won't have to worry about it. My name is Oluwadamilola Matsi. I heard Ruth Paul say something about Ajayi.
I'm sorry.
So I'm Dr. Oluwadamilola Matsi. I'm from Nigeria. I'm the executive manager for the Society for Quality in Healthcare in Nigeria. So this session is from QA to QI to co-production, and it's going to be a really great session. We'd like it to be interactive at one point, so please stay with us.
Turn to your table, and I'd like you to discuss, is there a difference between quality assurance and quality improvement? And if there is, what is the difference? We have 5 minutes for that.
Okay, so discussion time is over. It's time to get feedback. I have some people really smiling at me here.
Good morning. In our group, we have discussed the difference between QA and QI, and we have seen QA, it's about standards, certificates, accreditation, whereby the QI is about the process, the change. What is that we are doing to make the change? Thank you.
Thank you very much.
Thank you. So we've discussed and we've said quality assurance looks into compliance and standards. Have we met them? But now when it comes to quality improvement, it looks into the systems and processes, trying to bridge the gap. Where are we? Where should we be? And how do we begin? And also just to add, quality assurance is more also of policing. It is full of, you can feel some force in it. Thank you.
One more.
Good morning, everyone. For us, we discussed that quality assurance is more of conformance to standards and regulations. However, quality improvement involves stakeholders, involves discussion. It is, you focus on specific projects and processes where you have chances of improving on them and also working together as a team. Thank you.
Thank you very much.
Dami, there's one burning hand there.
Oh, fantastic.
Good morning. For our team, we practically related the 2 or 3 components together. One,
someone would run the other direction. But in 2019, under the mentorship of Dr. Lydia, we then restarted the quality department. And for a year, we even removed the idea of assessment and reviews and going, because the connotation of assurance, actually the team was quality, QMAT, quality management assurance team. The idea of quality and assurance had a very negative connotation to it. And then we moved towards the quality improvement. But now as we focus the discussion on co-production, one other brief story, and this I encounter a lot with my patients, is even when you ask them, what is your opinion on this? Do we frequently get an opinion from patients for, you're the doctor, you know what needs to be done? Am I the only one who gets that response from patients? If you've gotten that response from patients, do I have company? That you're the doctor, you're the one who knows. But how do we still get to hear their voice and include them in our processes, Dami?
Yes, my story is about how a while ago, when I was still in hospital practice, when I was quality manager in a hospital in Lagos, we kind of stumbled on co-production. So we had patients who had hypertension, who had diabetes. We kept looking at their figures, right? We knew that the doctors were seeing them, were giving them their medications, they were coming to clinic, but for some reason the numbers were not going down like we expected. Thankfully, they had a patient advocate, and we started talking. And then we realized that what we're missing was that we're not talking to the patients themselves. So we realized that some of them didn't know why they were taking the medications. They didn't realize that, with hypertension and diabetes, it's kind of lifelong. You have to continue taking the medications. Some of them will travel and not come for their hospital appointments. So we got to the point where we needed to start speaking to the patients. So if you missed your appointment, we'll talk to you, find out what you need. If you need a 3-month appointment, if you're not going to be in town. Some people go away for up to 3 to 4 months. So we needed to plan for them. So that's how we stumbled on co-production. We started talking to the patients individually and started planning for their care. But again, now to take us to co-production proper, we have Dr. Peter Lackman here with us. So please welcome him.
So we co-produced this. Oh, you've got yours. Welcome, everyone. Morning. We co-produced this session together, and we're going to have a bit of fun today. So firstly, a number of thank yous. You can see I've been standing there. I want to thank Ron and his team over there. Give them a big round of applause. Without them, you wouldn't see me doing this today. Secondly, you wonder why I'm here, the why I'm here. Well, so I met Lydia at WHO at one of the many meetings we go to. And then I met Mary at ISQA last year. Where's Mary gone? She's there. Where are you, Mary? You're not at your table, at the back. She asked very difficult questions in the session, asking probing questions. And where's Rhoda? Hello, Rhoda. I met Rhoda a few years ago. She was one of the first LEAP fellows that we had at ISQA. And so when they asked me to be on the board of Acquire, I get lots of requests. I couldn't say no. So I ended up on Acquire board, and here I am. So I want to thank the organizing team for the conference. Give them another round of applause. And I want to thank the three founders of Acquire. Give them a very big round of applause. Otherwise, I wouldn't be here. And just tell everyone, the last time I was in Nairobi, 6 weeks ago I was. So it's 2 times in 6 weeks. But before that was 1986 or 87. You know, it was a time in South Africa where time of change was coming, and I worked in child protection, and we had set up an advocate group called RAPCAN. It was, I didn't realize it then, it was quite revolutionary. It was in enabling children who were abused to be empowered. I was sitting on the homeless children's project, the Homestead. I was the president of the board. And RAPCAN was with ISQAN was quite important, and we were working, and we got invited to come to Nairobi to teach. And we went to the poorest areas of Nairobi. What's the big areas where poor people live? Huh? Kibera. We went to Kibera to look at the projects there, and then we taught at Kenyatta University, and came with my colleague Shifra Jacobson. And that was 40 years ago. So I was very welcome to come back. So that's why I'm here. And what I'm going to talk about today in the next 20 minutes or so is learning to dance. Okay. Learning to dance together. Now, this I showed you yesterday. I'm showing it to you again today because I left out the dash. So those who want to apply, you have to remember to put another link, because the link was wrong yesterday. So take a quick photo if you're interested, because the link yesterday was wrong. So I'm showing it to you today again. It's open today. Okay, let's get going, because we've got an early morning. Okay, photo's done. So the quality journey is quality 1, quality 2, and quality 3. So I'm going to go to this quite quickly because you learned a bit about it yesterday. Quality 1.0 is establishing thresholds, evaluation, certification, and guidelines. And here on the one side you see ISO, you know ISO, for laboratories, and ISQA where I used to work as CEO. And there you see all the African accreditation bodies, Nigeria, Botswana, Ethiopia. Where's from Ethiopia? Where are you? Yeah. So I had a bit of a hand in that one, mixing in that one too. Because I used to work with a health service executive in Ethiopia, and they wanted accreditation standards. So a big round of applause to them. They have just got their standards done. Okay, so right there. But you can see all of these things, these are standards. That's quality 1.0. Do we meet the standard? That's not enough. That's the beginning. You must remember, that's quality assurance. Do we meet a standard? So you've got to go to quality 2.0, where you improve processes of healthcare. So there you see the big names. At the top, the Americans, to Stewart and Deming and Duran, who lived in America but is Romanian. Duran Trilogy, I'll show you. The Japanese for Lean Six Sigma. And then the management, and there's Don Berwick, who helped translate that into healthcare, okay? So here we improve, and this is what we've been doing for the last 30 years. But it's not enough. It's not enough. It still doesn't change. You heard yesterday, it's not enough. So we have to do more. But what is it? I'm just going to show 2 slides. The Duran Trilogy, you have to plan, you have to measure, control, you have to improve. That's the basis of quality improvement. Plan, control, improve. The improvement is applying all the stuff you know, model for improvement, Lean Six Sigma. I don't mind which one you use, but that's the method you use. That's the Duran Trilogy. And that is a measurement, which is a run chart, or SPC chart, you could call it, in the Duran Trilogy. And this is what you do every day in your clinical practice. And then we use systems thinking. And Deming called it profound knowledge. So systems thinking is where do we work? How does our team work? How does our organization work? How's it working? What's the variation? Why is it good some days and not good other days? That's because of the belief system of people. The most important one, Deming said, which is the most important? And he said, well, variation is the most important, but people cause variation. So you have to understand the attitudes of the belief systems of people. If you don't, go back home. That's where it starts. And then, of course, you have to have a method, which he called knowledge, which is the theory of change. And why he called it profound, because just like religion, you're never going to know the real answer, because you're dealing with people. So that's profound knowledge. Normally, we spend days teaching this in quality improvement. This is quality 2.0. So Paul Batalden, who could have been on the previous slide, but he's not, came up with this concept of quality 3.0. Sorry, Letitia, I put your name in twice. I was doing it too fast. So there, who's taking a picture, I have to correct that. You can see Paul Batalden, Boel Anderson. There's Irene. I read papers from her, and then Letitia Rispel, not Lila Letitia. I was writing this very small. And this is where you get ownership of health, kinship, integrity. So this is co-production. I'll correct that slide for you before you go. Okay. So co-production of health. What does ownership of health mean? Not management of disease. It's a difference. It always surprises me we call healthcare healthcare when it's not healthcare, it's disease management care. I'm a pediatrician. I used to work first in community In the community, what is the most important thing for a child? Vaccination. In South Africa, many years ago, when we worked in the community, we used Gobi FFF. People forget about Gobi FFF. Growth monitoring, oral rehydration, breastfeeding, immunization, female education, family planning. Okay, that's forgotten now, but that's all prevention. About health. We used to teach villagers to do this. Keep your baby safe. It's not disease management. That's health management. That's co-production. So co-production of health, you spoke to yesterday about kinship, the Ubuntu, value-creating architecture on the values you hold. Here's a definition from Paul Batalden. It's where everyone works together to improve the health of people, not manage disease, but improve the health of people. So that's what we're going to talk about today. Okay? Paul wrote this paper in 2018, and we wrote our next paper in 2021 together, and it's been my privilege of my life. So I met Paul in 2005 when I was at IHI. And now I'm working with him on the latest thinking in co-production. So, what does this mean? We still need standards and certification to the standards. That you need. So the Ethiopians, they're starting their journey with their accreditation. But now why it's important, I'm picking up on the Ethiopians, because when we met with them in 2018 or 19, we said to them, with them, that you cannot afford in a country, in a poor country, it was poor resource country, rich in people. Remember, resource poor, everyone says resource poor, but I say there are people rich. They're people rich, can't import accreditors, charging lots of money. You have to do it yourself, and it has to be as good. And I'm speaking there as ISQA, saying, I accredit all the big ones, but I want you also accredit a local one, as good as, if not better, than the ones that come from outside, because they understand the context. So that's so important. So we still need that. We still need improvement methodology, and as I said, I don't mind if you use Lean or Model for Improvement, Six Sigma, because you just need a method. Deming said, by what theory, by what method? So you need a method. But we need to focus on new areas, and we need to co-produce solutions. So this is what the talk's about. So I showed you this yesterday. Paul and I came up with this with Chris van Hecht. We said person-centered care is everywhere, and is now person-centered and kin-centered. I learned that in South Africa with disabled children with cerebral palsy. They used to come from a village in a rural area. We used to work up the coast, what was then called Transkei, Eastern Cape. And we used to go to these villages, and there was a child with cerebral palsy. So we had a disabled child, a disabled family, a disabled community. Because if the child wasn't with cerebral palsy, they weren't putting those resources into that child, they were putting it into other things. So that's the kinship. So we weren't treating a child, we were treating a community. That's what we talk about kin-centered. Often doctors just treat the disease. Okay, so that's where kin-centered comes in. And Paul and I spoke a lot about what that word should be at the bottom. And then you need to have the values I spoke about yesterday of kindness, respect, and holistic, integrated, and co-production, and partnership and co-production. And then you need leadership and resilience. So I'm going to reflect on that, and transparency. So this is the new model that we think the future will hold. It takes time for models to get in, but people are starting to talk about the model, and we're testing it out. But you need values, and yesterday I spent a lot of time on values, so I'm just reminding you, you need vision, respect, courage to be different, compassion and kindness, and expectations. And for leadership, I mentioned this yesterday, you need to be just. You need to be informed. You need to be flexible. You need to have a reporting culture. And you need to have a learning culture. This is from James Reason. I mentioned this yesterday. As a leader, it's a culture of safety. That's very, very important. It's while you're co-producing. Now, what is co-production about? It's about power. When you are a patient, just think, how many of you have been a patient? Hands up. How many of you have lost power as soon as that name is given to you, patient? You walk through the door, and now you're a patient. I was listening quite interestedly in that, what Mary's story about her knee. It was about power. The power of the healthcare system and the power of the patient. Does the patient have the power to say, stop the line? I have a similar story. It's not the why, I've got lots of stories, but when I was, I'd just come back from IHI, so I knew all about quality improvement, and I was the quality improvement person at the Royal Free in Katana, and I had a hernia op. And so, firstly, the surgeon didn't wash his hands before he examined me. So what did I do? I didn't say anything. I was observing. I was lying on the bed and I didn't see him wash. So maybe he did it outside. But he didn't wash his hand in front of me, so I couldn't be sure, but I thought, okay, he should know what he's doing. But on the day of surgery, there I am, fasting from 10 p.m. I'm 7 a.m. And first the medical students comes, can we examine? Yes. Then the anesthetist comes, has a look, yes. And then I wait, and I wait, and I wait. Then at 12 o'clock, I'm still waiting. I'm getting hungry. And I go, when am I going to be? Because it was a very quick op. And they said, oh, we had an emergency. So I said, okay. I said, well, I've got a consultant meeting downstairs. Can I go downstairs to the meeting? I won't eat, I won't drink, and I'll come back. So I go to my meeting with all the consultants, because it was a quality meeting, and I come back, 2 o'clock, still waiting. So now I'm there as a patient, see, with no power. Then I thought, okay, now I'm going to exert my power. So I said, could I speak to the surgeon? They said, he's busy with, he's too busy. So I said, no, I want to speak to them. So they send out the registrar. And then I'm on my phone, and I say to the registrar, what's the problem? So he says, oh, sorry, we had a vascular aneurysm. We had to do urgently. I said, really? He says, yes, but we had 3 vascular aneurysms. And we can do you at 4 o'clock. So I said, no, no, no. I said, I'm canceling my operation. Why? Because at 4 o'clock you'll be tired. After 3 vascular aneurysms, we've got a surgeon in the room, they'll know this. You'll be tired, you'll want to go home, you want to go have coffee and supper, so you'll do me quickly. And anyway, I don't want to stay in hospital tonight, it was a day case. And I phoned up, and I know there's MRSA here, so I want to be in, out. I'm cancelling my operation. And the nurses all started clapping. They said, no one's ever done that before. I said, yes, because I know what the risk is. So I exerted my power. But the average patient doesn't know that. The average patient doesn't know that I'm privileged. I know how to do it. So co-production is about us sharing power. Very important lesson. And what is power? So this is Varian power. At the bottom, care is done to me. You fix people. That's what most people do in healthcare. We coerce people. You must take, and if they don't take, they are unproductive. They say, his mother used to come and say, I didn't take the medication. I said, why? She says, well, I read all the things. Oh, bad mother. I read all the side effects. We tell people you must take this child, and mothers has no choice. They don't adhere to medication. They don't turn up to clinic. We exert in power. So what we do, we educate them. So then we climb in the ladder, and the patient says, oh, they're doing care for me. So we engage with them. So we inform them, maybe teach them. We consult them, what you want, and so on. Engagement. Care is done for me. But if you really want co-production, you have to give up more power. Teach people in equal context. So now people online, and everyone here, I'm just going to pause for 2 seconds. Online, please write in the chat where you think you are on the ladder. And in the room, quickly speak to each other and think where you are on the ladder of co-production. Okay? If anyone is at the top, put your hands up because I want you to find out how you got there. Okay? So I'd like to think. So this is a quick 2-minute thing, okay? Just to get them involved, okay. Where do you think you are on the ladder? Okay, they're going to write on the chat. Please, people online, where do you think you're on the ladder? So they need to see the ladder again, please. Quickly go back to the ladder to show them the ladder again. Yeah, Ron, thanks. You're doing a great job there. So yesterday I told you I have prostate cancer. And I said to my consultant, I'm not interested in long life. I'm interested in quality of life. My doctor was on consultation, but she quickly jumped to co-production. You can see. So come talk. You have to talk. You don't have to talk. Where do you think you are? And then I'm going to choose 1 or 2 tables. Okay, Faith is going to come round. Yeah. Okay, put the ladder back up.
Yeah, thank you very much. I think myself, I'm in the yellow zone, the second phase, yellow zone. And
oh, there you are.
Yeah, yellow zone, where I consulting.
Where are you? You're a surgeon. Where are you?
Yeah, yellow zone, consultation, informing, probably engaging.
Yeah, probably engaging.
I'm on my way to co-designing and co-production.
Okay, he's on his journey. Who's next? Okay.
I'm also on the same opinion of the yellow zone. And why haven't achieved on the upper one? Because it involves another system, not I alone, to involve other stakeholders to come something like a policy so that can inform all of us at the community level, facility, then downwards also, so that we come together with other stakeholders.
Okay, another story. Yeah.
Yes, I think from from the service angle, as a business-to-business practice, when we meet healthcare organization leaders, the board leaders, we as the service provider, we don't have the powers. The board still has the power, so we still have to co-produce. So in consulting practice, so we still have to, we have no way out of it. We just have to co-produce with them. The board has to see the sense. They have to buy in. You have to carry them around and move with them. By the time they're still not feeling the oomph of the ideas, they'll not buy in and they'll not move with you. They'll not consent to it.
It's great. So I just want to change the question slightly. How many of you in your improvement projects are at co-production and co-design? And how many of you mainly are working in doing it with people, saying, we have a high infection rate, we need to improve it, rather than, what are the problems here? What do we need to improve to the staff? That's a different one. Think about it. Think very carefully about that. All the improvers in the room. How many of you are engaging rather than co-producing your improvement projects? So it's another question. Here we have a question. And I can tell you that because in Maputo, where I'm going next week, I think I haven't told you this one. In Maputo, in Jose Macama Hospital, we said to the MOH, what do you want us to do? They said, we want them to work across the country, decreasing infections. I said, we don't work that way. What we do is you bring the clinical teams, and I say, what do you want to improve? Because I can work with anything. And so I had 18 teams, 18 hospitals, each doing something different in the collaborative. And Jose Macama, the patients were dying within 24 hours. 24 hours. And you know in Africa, I went to look at the hospital, 75 beds, 2 nurses. Yeah, so what we had to think, 25 beds, 2 nurses. So what we did is we taught them new ways, but they chose that matter to them. So they also was co-producing, whereas the MOH wanted me to engage them. Can you see the difference? So clinical, this applies for clinical and for improvement. Okay, another one over here.
Yes, just to answer the first question, we are everywhere near there. The blue part, we are not yet there. Most departments, and I guess it depends with the specialty, are still at green, coercing. And so if a mother comes with a baby and we are insisting we must do this without explaining, we are still there, that we want to do it by force, without engaging them and without involving them. And then some departments are at engaging and consulting. For co-design and co-production, we've tried a bit, but in the surveys. So for the patient experience survey like this year, we got 5 patients to just give us their inputs and to look at the tool, design some questions, give us their thought process. And also for the trainings, we are having patients coming in and do a session. In all the trainings that we're doing, we're having patients come in and do a session that they teach the healthcare providers about what they would want to see. So we're not yet there, but...
You're on your way, you're on your way. Okay, I just got to go to co-produce with Pearl. What they're saying online, let's see. Quickly, because we've got to let them, because then I've got to switch.
Someone on online duty today, her name is Musel, so let me hand over that microphone to her.
So we can see, well, I can see from here, education, engagement, they're all in the middle, they're all right in the middle.
As she gets to Museo, one more burning one here.
Yeah, could just say, yeah.
Okay. So the online community is saying most of them are in the informing stage or informative session. Others are saying they're in the education There's one in particular, Dorcas Mutandi, who's saying that they're informing with instances of going back to educating. More of informing and engagement and consultation. There's Colleen Araka who's saying it's between educating and engagement, which means it's depending on the episode of care. And then there is one who's Yvonne Pedroso. She says they are in the co-design stage.
So Yvonne
Pedroso, yes.
Thanks very much. I've had to move on, but Yvonne, while we're moving on, I want you to write in the chat what you're doing so we can learn from you, Yvonne.
Yeah.
Okay, one last one.
All right.
One more.
Yeah, one more. So we have an Ivy Karanja who's on coercion and education. There's another one, actually, Aniedi on engagement and co-design.
Often, so we've got all the ones in co-design online. Please write more in the chat so we learn from you. Okay.
All right, thank you.
Thanks a lot there.
I want to speak to the second question you asked, how many of us are in co-production with our projects? Yeah, I remember there was this time we were working on patient engagement, in the patient experience in labor and delivery, and we designed a questionnaire that speaks basically without the voices of the women, wanting to find out, how were you attended to, were you abused, did any nurse, and all of that. And we were getting everything good. And then we said, no, I don't think this is, can we hear from them? So we had to add a line. From when you walked into the hospital to when you give birth, was there anything you don't like about our services? Put into consideration the attendants, the cleaners, the security, and we marveled. Initially, we were focusing on the nurses and the doctors, but the problem was with the securities and the attendants when we eventually get to hear from them.
Yeah.
Thank you.
That's fantastic. Okay, so I now have to move on because we have to get on to some funds part. Okay. So this is all about power. This comes from Helen Bevan, about new power and old power. Old power is held by few people, doctors. It's like currency. Few people have money. New power is like currents. Held by few, held by many. Old power is pushed down, new power pulled in. Old power is commanded, new power is shared. Old power is about transactions. New power is about relationships. So it's all about the old power versus the new power. And for co-production, we have to have new power. That is the trick, new power. We can talk about it later. And here is how it works in shared decision making for maternity. Anyone work in maternity with mothers? Yeah, good. So most of my work now in Mozambique is now they've said we want to work on maternal death. You know, maternal death in Africa is very high. I mean, one mother dying is high. 2 mother dying is a tragedy. 3 is a disaster. But in Africa, in many countries, you've done great work. I've seen the numbers going down, but it's still very high. So most of my work in Mozambique is with teams trying to decrease maternal death. And that's their choice. That's what they've chosen. And so, but this is shared decision making for a mother giving birth. The mother comes in, she's pregnant, and you co-assess together what you're going to do over the 9 months. Not this is what we're going to do, but what would you like to happen for the birth of your baby? So you co-assess together, then you co-design together, you co-decide what the options are, then you co-design how is it going to happen in the future, when we have to see when you can come, where we can go, and then you co-deliver together. This comes from Glenn Elwyn. It's called shared decision making. And people say there's not enough time for it. You invest it in your first interview, then everything speeds up. Because soon the mother's self-managing and not coming. And I could apply this to any clinical situation. Co-designing together with the person we call a patient. Because now it's not a transaction, it's a relationship. So this is a very important way of shared decision making for safety. So this comes from a friend of mine, Annette Nielsen. So we presented this in Utrecht at the IHI conference recently. And in Sweden, this is what they've developed. And she doesn't know I'm using it, but she'll be happy I'm spreading it. It's this what matters to you concept. So it's asking this question in that co-design. The first question in the co-design is what matters to you? How would you like your baby to be born? How would you like to come to clinic? How often do you need to come to clinic? Not you have to come, but what matters to you? And then they develop a contract. Now you must say, oh, that's upper income country stuff. But you can do this here. It's not a big asking people, what matters to you? And I'm talking as a pediatrician particularly. What matters to a mother is a healthy baby, a healthy child. And as for she speaks to the obstetrician, what matters to the mother is the good experience of childbirth. Good experience of childbirth. That's what matters. And that's been treated with the values, respect, kindness. That's what they remember forever. All of you have heard children, all the women in the room. I'm a man, so I wouldn't know better. But the women who've got children, you remember the childbirth, whether it was good or bad. Huh? How you were treated, how you were spoken to, whether you co-designed. You all remember that. What if it was co-designed with you? And so this is really, really good. And you can see how this fits in with the whole story of co-production. So, we have taken this whole concept and put it into what Chris calls a house office. So the back office is the hospital administration, the clinic administration, the government administration. And they are really interested in what we're interested in getting that moment of truth. The moment of truth is when quality is achieved. I used to do clinics and I used to come up and say, wow, what a clinic. Because I had so many moments of truth with the people I was privileged to serve. Because I'm just a servant, I'm not a doctor. I'm a servant. I serve the people who need care. And I'd come up and say, wow, that was a great clinic, because we hit that sweet spot. And the clinicians will now they all think, did I have that? Where the person we call patient, Paul calls them people we formerly called patients. Just like you remember Prince, the artist formerly known as Prince? Huh? You remember him? Because all you're going to dance soon. So the artist formerly known as Prince, he changed his name because the record company, so he said, I'm the artist formerly known as Prince. So the people formerly known as patients meet the people formerly known as healthcare workers, doctors, nurses. They come together and have a relationship for the moment of truth. And what they need is the internal and external context. They need values. They're the values. They need pathways. That's the quality 1.0. How am I doing for time? Okay. They need safety. They need all the different. There's a model for the model. They need person-centered care. And they need self-evaluation. So here, quality 1.0. There, quality 3.0, self-evaluation. This is the House of Trust. Just published. People are now getting excited about that. So you can take your picture, you'll get the slides anyway, so the corrected slides. But now we have to move on. So here are all these concepts. What do we have to do with these concepts, okay? I showed you some yesterday, showed you today. Well, it's all about Ubuntu. Those from South Africa know Ubuntu. Ubuntu saw people through the dark years in South Africa, the Ubuntu. I am because we are. That's the moment of truth, remember. I am a doctor because we are together. What matters to you? Here I am the doctor. I ask the question, what matters with you? What is wrong? I can dance. It's the waltz. I'm not going to ask her to do the waltz with me. No, 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 no. She doesn't know the steps of the waltz. She's the patient. She says, stop the music. That's not the right example. Please start again. I only know how to cha-cha. Do you know how to cha-cha-cha? Oh, God. Who can cha-cha-cha? So here's, that's not the right question. This is the right question. This is my dance.
Come fly with me, let's fly away.
See, the question's different.
If you can use
that's
some
what the patient wants.
booze, there's a bar in far Bombay. Come fly with me, let's fly away.
Okay, so now we're going to dance.
Come fly with me, let's float down.
And we're going to fly away.
In Llama Land, there's
okay,
a
can stop the
one-man
music.
band and he'll toot his flute
Okay,
for
can you see what I'm talking about?
Come.
Doctors have a dance step. The patient knows one step, their dance step. The doctor or nurse has to know a lot of dance steps. Depends on what the patient is. The patient comes in and says, dance with me. So I went online and looked at the dancers here in Kenya. Oh yeah, the doctors in Kenya, nurses, you've got a big problem. Look at all these dancers you've got to know. So we're going to test out how many dancers you have. I saw you had a practice session, and Ron has been very good. Oh, more dancers. Now, ChatGPT gave me these 12 dancers, but they missed out one. Ron found another one. So, so we're going to dance together. So you're going to get up and dance now. And this is over to Ron and the team, because you're going to start dancing and get moving. Okay. I saw you move some good hip moves. We've got 3 dancers. Ron, you're going to lead. No, where's Ruth Paul? Ruth Paul, come on. This is your part.
I'm sorry. How is this my part? This is dummy and face part. Let's all do this wrong.
We're going to do some
dances. In fact,
dances
it's actually
here.
Ron's part. So this is not us on stage. This is all of us up.
So you're all going to get up.
Quite the music, Ron.
We're first going to do my beggar, my beggar.
Hey.
Who knows my beggar, my beggar? Any experts on my beggar, my beggar?
Yeah, you can already see the movement, or is it there?
Oh, look. Yeah. Come forward.
No. Please look. You can see her. Look.
Where's she? Where's my beggar, my beggar? Come here, my beggar, my beggar.
Ron, where are we with the music?
Ron, music, my beggar, my beggar. You want to see my beggar, my beggar?
I need to see some shoulders moving, please. I'm sorry, there's no movement here.
Okay.
where you need to be looking. Camera work. Is the camera following me? Because I'm identifying the real dancers in the room. So follow me, cameraman. Keep going, Ron.
Do you still want my back and my
Okay. I cannot see myself. Show us the people doing the job, please, on the screen. Thank you. I'm sorry, cameraman, where are you? What are we seeing? John, what is happening? This will not work if you're not coordinating with us. I'm here. Are you here? Because I can see both cameras pointed at me and I can't see myself. Okay, so let's do the next one, Ron, but the camera is down. You're being the weak link. So follow me now here. So let's do the next song.
Umeyatafuta umeshayapata, sasa walialia.
Let's go this way. Keep going, Ron.
Sasa walialia.
These people are the ones to show us how it's done. You see this lady Bavaria? Slow down. You see how tense they are moving? I need to see her also. I don't know what she's
Wakufuma tumefuma, wakukosa umekosa, wakufuma tumefuma, wakukosa umekosa.
Now Ron, I need a Sadakta for the next one. Because we are going to Anguka Nayo. I'm looking for the Gen Z in the room for Anguka Nayo. Who's going to Anguka Nayo? I'm looking for the Gen Z in the room because we are about to Anguka Nayo.
They're just going to start it. Okay.
I don't know how to Anguka
We
Nayo,
have
but
one
I'm
more.
sure somebody here does. Ron, hit that beat.
What up, please?
I'm waiting for the music.
Etoshaskia kikingia ni kublast huko anga bado nachukuliwa madam, so anguka nao itabaki meflow na vibe. Anguka nao koko single for now. Mdagris mteja patika
Anguka nayo
nice sita ndo taniwai nikupini location na nikofana na hii sukate call niko chomba ya ji mimi najua
if you have the need for this.
acha nikushow kwanza form ya didon nishashika poa na twende chini kwa chini akiwa adi na mini sasa tunasikiza Shin City tuna feel free teka video na post pale NGC kurapsi ni talent G anguka nao anguka nao check it anguka nao twende down low now stand up to your feet mikono juu alafu click tuliza pesa alafu one leg anguka nao one leg anguka nao anguka nao anguka nao anguka nayo
anguka nayo kama uko na new catch anguka nayo kona pati na magwash anguka nayo round 2 kwa hii bash anguka nayo pati anguka nayo anguka nayo anguka nayo anguka nayo
Let's Kenya with some awareness of the dances. Back to you.
Yeah, so okay.
Thank you, Bro.
So I noticed.
Thank you.
Okay. I noticed some very good hip moves, some very good shoulder moves, some not so good hip moves, some no moves. Okay, can you see what I'm getting here on the metaphor of the dance? We as clinicians in co-production need to learn the dance of the patient. We as improvers need to learn the dance of the teams that we want to improve, to co-produce. And that means we have to be flexible, adaptable, and to change all the time. So if you go in the next slide, let's see, the next slide I think is the end slide. Now it's not working. Oh, yeah. So let's go to the end slide and see what it is. Yeah, that's the end slide, my details. Okay. So now we're going to have fireside chat and questions and answers. But the message to you about co-production is first, it's in the head. You have to understand that the person who you've seen is not a patient. They're not a patient. They're a person, like you or me. They have children. They have a husband, a wife. They have sadness and happiness. They so happen to have a medical condition. A patient is a medical condition. Take away the person. Co-production is about putting the people back into the patient. And that means giving up power. So here in Africa, one of the things I just want to end up with complimenting Acquire again, because it's a bottom-up movement, born in Africa, and that's the most important thing, and spreading across Africa. Because I really believe that we have to have African solutions for African challenges. I don't call them problems, just call them challenges. And you can produce together. Here we sit in Nigeria, there's Ethiopia, there's Kenya, there's Malawi, there's Tanzania, there's Ghana, I just can go on, South Africa. You don't need UK and America. You've got the power to co-produce. So let's go on to the fireside chat. Thanks very much.
Okay, so we're going to our fireside chats now. Do we just stay here or?
What do you think? Should we stay here or go sit up there? You need for the camera on stage. Our co-producer.
That is not co-production.
Okay. Oh, for the online people.
Speaking on behalf of the online world, they are part of this co-production.
Okay. Could you ask the online world, are they happy now?
Are they happy now? I don't know. Can we ask them? Go
Ask
ahead,
them,
Musa.
are they happy?
Tell us on chat, are you happy now?
And also to put where they come, because I only named 6 countries, then there'll be more countries.
Oh yeah, so tell us which country you're from as you tell us you're happy. I hope you've enjoyed our dancing.
Yeah, I hope they did dancing as well at home.
Okay. At home, they're probably at work. Okay, over to you.
All right, thank you very much. So for our fireside chats, we will have 2 questions from here, and then the audience can ask another 2 questions, and then we can take one from the online audience. So first up, thank you very much. That was a fantastic presentation. We had fun. I believe we all did, didn't we? It was a good one, and I'm sure we've all learned how to co-produce. But how does the multidimensional model fit in with the patient contract, and how has it affected the lived experience of people?
Yeah. So, okay, so the key thing about it is that when we thought about the model, we thought first about values. We didn't start off with the 6 domains. We said, what are our values? And so Chris is the Mango Moments person. So he said kindness must be right at the center. And I said, well, what do you need to do to get kindness? And then I said, well, what troubles me in healthcare is the lack of respect for each other and for our patients. And then in integrated care, of course, is normal. And then Paul said, well, we have to co-produce it. So that came to the values. So the values then, the contract at the same time, Paul is working in Sweden, so he's influencing the contract of what matters to you. And it's quite interesting across the world that what matters to you's movement is coming, of asking what matters to the patient. The person, they call it what matters to the patient. I say, no, you must ask two questions. What matters to the healthcare worker? More first before the patient. What matters to the healthcare worker? Most healthcare workers want good care. If you're an obstetrician, you want a baby. If you're a midwife, you want a healthy baby. If you're a pediatrician, you want a healthy child. If you're a physician, you want a healthy patient. If you're a surgeon, you want a successful operation. That's what matters. So if you ask them what matters, then you say, well, are you achieving that? And I say, oh, the administration. Oh, that we have no resources. So I can only speak of my experience really now in Mozambique, where I'm going, is that when we ask them what matters, as soon as you got that, the issue of resources goes away. We say, how can you achieve what matters with the resources you have? And suddenly the inventiveness. So I discovered in Mozambique, you don't throw away things, you fix them. You know, in Europe, your toaster doesn't work, you buy a new toaster. In Mozambique, there's someone who fixes your toaster because you can't afford a new toaster, so you have to buy it. And when you drive from Maputo Airport, all you see is these car fixing firms. They're fixing the cars the whole time because people can't buy new cars if they've got a car, even if they can afford a car. People are fixing the whole time. So they're incredibly resourceful. Those who've done the marshmallow game, who's done the marshmallow game? Where you get people to build a marshmallow tower. In Mozambique, they could get, every team knew how to build with how to build the marshmallow with spaghetti and a marshmallow on top. In Europe, only one or two teams managed to do it because they're resourceful. So the resource is the people. So first you've got to do is empower the people in co-production. What matters to them, what matters to you, they want good care for the people they call patients. What matters to the patients is different. They want good experience, they want to be treated like a person, and that's the contract. And the contract's not necessarily written. It could be a verbal contract. It could be the relationship. So that's the contract. You can make the contract every time you meet a patient. You could ask what matters. So we've designed a form that you can fill out to say, did I manage to do all of this? If anyone is interested, I can give that to them. But the whole thing is you can say, did I get the wow factor? Did I get the wow factor?
Thank you. That's great. So I'm hearing that we are looking at not just what matters to the patient, what matters to the healthcare worker is also very important.
Oh, yes.
And in the mix of all this, the values underscore all this.
Yes, you see, I think we've gone down the wrong road in patient safety. In patient safety, we looked at adverse events, what went wrong. What we're really saying is what goes right most of the time. That's to say, they call it safety 2. I don't like safety 2. I'd say no. It's what we should ask every day. What have we done well? What have we done well? So we can do it again. No one fell. There were no line infections. Not how many line infections we have negative. Then we'll have a line infection program. Rather, we'll have a program where we look at what they call the positive deviants. Who in our hospital, in Kenyatta Hospital, because I see Rhoda there, who is doing well? Positive deviance comes from I don't know if it comes from Vietnam, where the villagers, they went to a village and there were some babies with kwashiorkor and marasmus. We had the same in South Africa, and some were not. And so instead of treating the ones with kwashiorkor, which they did do, what they did is they went to the families with the ones without kwashiorkor or marasmus and said, what are you doing? Why are your babies not with marasmus. And what they were doing is they were feeding the babies not the soup. They used to make soup with prawns. They weren't feeding them the soup, they were feeding them the prawns. And they were giving the adults the soup. So the babies were getting the protein, because there's not enough protein. And families with kwashiorkor and marasmus, they were receiving the soup, the positive deviance. So you look for what's going well. But we in quality improvement and patient safety look what's going wrong. Wrong way to go. So I start with the healthcare worker safety, healthcare worker well-being. Happy healthcare workers will give good quality. Unhappy healthcare workers won't have respect, they'll give poor quality. So that's where I start that way. We do it the wrong way.
I think I really like that on positive deviance, what's working well somewhere else. Online audience, please begin typing your questions. We'll see how many of us we can address. I think my question is, we've seen the different models that you've shown us. You've talked about us as healthcare workers sharing power with patients. My question is, when I go back next week, how do I actually start? Like, how do I do it? Because I think we've gotten at least I've gotten the why, but how?
Oh, okay. That's a very difficult one I'll talk from a clinical level. From a clinical level, you start with your next patient. You say, I heard these crazy ideas about shared decision making, it takes too much time. But let me try the idea with one. Just one. Now I'm doing PDSAs. One, let me test it with one. You test it with one, how did it go? Next patient comes in, you'll suddenly feel, I need to do it with the next one. And as you do it, because you'll do the next one, because if you do it for one, you want equity, huh? So your next patient comes, you have to try it out again, but it took too long for the first one, so you're learning, how can I refine it? Because remember, the problem with all of this is that the people we call patients have been taught to dance our tune. We have to teach them that their tune is as good as our tune. So you need to start with the question at the beginning, what matters to you at the beginning? Now remember yesterday I talked about service and product. Well, a patient coming in cardiac arrest, they're not going to have time to, what matters to them is that you do the resuscitation. The mother who comes in and you had co-produced and she needs to have an emergency section, she's not interested in co, she just wants good care. You know what, we decided already what would happen in the co-production, in the emergency. So you talk about these things earlier. You get faster and faster at doing it, but you start with one as a clinician. If you're in a hospital and you're an improvement coach, you start changing the way you do your improvement coaching. So what we do, I run a program called SAFE, and I'll be talking about it for WHO on the patient safety on the 9th of September, watch out. And what we say to clinical teams, what matters to you in your work? What harms do you get? Let's start with those. Then we'll start with the ones I think you should start off with. So on clinical level and improvement level, the same story. But start with one as a doctor. The next patient, I bet you all the doctors and nurses, if you start with the next person you see and say, what matters to you, not what's wrong with you, what matters to you, and how can I help you stay healthy? Two simple questions. It changes the dynamic straight away.
Thank you. Start with the next one. Museo, any online question?
Yes. So we have a question from Khadija Hassan, who is asking, how can you maintain balance between co-production and family decisions?
Co-production?
Family decisions.
Family decisions.
Family decisions, yes.
Yeah, you see, the thing is that it's all about respecting each other. Often we have problems in which decisions about care have to be made by the healthcare provider and in cooperation with the family. And sometimes the family wants to make decisions, particularly of end-of-life care. I think this is a very important thing. In end-of-life care, they want treatments that don't work or don't need. And this is very tricky. It happens quite frequently. But when you go back, if you do a root cause analysis, you'll find that these decisions haven't been discussed early on. Often I found when I was working in neonatal intensive care, parents would say, we want ventilation to go on forever, even when you know it's not going to work. And then you have to sit down with family and have serious discussions, which are very difficult to have. And then take them along on this journey, because you're on this journey together. Parents often used to say, what's going to happen? And I'd say, I've got no idea what's going to happen. I'm just a doctor. You know, if I knew what was happening, I'd be God. You know, that's the only person who'll know what happens. I'm a doctor, but I'm on the journey with you. And I'll always be just and fair and honest. Just, fair and honest. I'll always be open to you. So those are it's a really difficult question you've asked. But if you're honest and open, you'll find that they won't have those conflicts. I see there's a question in the room.
Thank you. Where? Sorry. Oh.
Yeah, we've got one in the front. Yeah.
Thank you very much. Not so much, can I say? Not so much a question, but a way to apply this. And I'm speaking with respect to our patients that discharge against medical advice, because sometimes we do get quite a number, and the ambience is usually not good, because you as the doctor, you don't want them to discharge against medical advice. You have not finished your work. And when they say they want to go, we are not happy. So we don't even believe they have the power to say so. So it's always a negative discussion. You can't come back here, this will happen, that will happen. But with co-production, I now know that it's their story. It's they have part of the power as well. So let's sit down, let's discuss, let it be something positive. It's the patient's body, it's the patient's life. I know this about medicine, but it's their life, it's their experience. So going forward now, it's going to be a positive ambience. Thank you.
Thank you. And I
have a question here.
Can I tell a story from Mozambique quickly on that? One of the projects from the psychiatric hospital was to stop patients absconding. Big problem. They'd walk out the hospital, they've got psychiatric disease. And there's one person who absconded a lot. And then they asked what matters. He used to abscond and go back to his village where he was the shoemaker. So what did they do? They made him the shoemaker for the hospital. And he was repairing all the shoes of all the other people in the hospital. He never ran away again. What matters to him, can you see? I thought it was such a beautiful story from them in Mozambique.
Thank you.
Thanks a lot. I'm Manu Simon from Vihiga. I really have one comment, then a question. Comment that today as I live here, I'm a servant. Very positive servant that just like a priest, he will never call that they were sinners when they come. No, I need to listen. My question really that's bothering when it comes to co-production is the issue that we have clients who comes, they have actually Googled, they have looked at their symptoms, they have looked at, they come with a diagnosis, they come in the facility, they say, now I need these drugs. And sometimes to change their mentality now, during that sharing of the power, informing them, it becomes so difficult to really share with them. And it's now becoming like even we have the medicine or the doctors online. How do we handle that? Because most of the time, again, you get this patient going to the chemist, they get the drugs because they have Googled, they come with now complications which you could avoid. How do we strengthen this and also the issue of the online Googling and getting their own knowledge? Yeah.
You have to be smart. So what I used to do, they used to come in and I'd have, this is before AI, but now with AI it's worse. I used to have my computer open with Dr. Google. They'd come in, they'd sit down, and I would start off and I would say, what did Dr. Google say? Right at the beginning, acknowledging that they've been to Dr. Google, because they've all been to Dr. Google. And I'd say to them, you know, it's Dr. Google is like all the doctors in the street. There's some good ones and there's some not so good ones. My job is to help you find the right Dr. Google. Let's look at the sites that you've looked at, where you got your information from, and then we can see if it's a good Dr. Google or a bad Dr. Google. And so I've respected them because I know they're doing that. And I learned that when I was a medical student. I was telling them the other day, is that when I was in first year medical school, we were worried. We'd go to the hospital and the patients would come for TB treatment. And we'd give them rifampicin, isoniazid, etc. And then where would they go after that? To the Sangoma. One for us was physical healing. The Sangoma was for spiritual healing. So in fourth year medical school, we organized the first Sangoma conference at the medical school. We acknowledged that they were going to Sangoma. I said to them, it was not allowed, it was unheard of in 1977. 1977, yeah, it was 1977. It was unheard of that you acknowledge that there's another school of medicine, that traditional medicine, traditional healers. And in Africa and in Europe it's homeopathy. So you need to acknowledge that they've gone elsewhere. You need to respect their decision to go elsewhere. And then you can have a serious discussion. But if you say that is no good, then you're power. You're disempowering their ability because you know they're going to go. So in Africa, I used to say, you've gone to the Sangoma, what did the Sangoma say? For the spiritual healing, I could only give them the physical healing. I couldn't, as a teaching TB, I had one in which in an upper income country, they went and they changed the name of the child. That would take the disease away by changing the name of the child. I said, well, that's fine. I'm happy with that. You want to change the name of the child? I'm happy with that. I didn't say, are you crazy? The child's still going to have the same disease. You respect them, and then they will listen, and you'll go on the journey together with them. It's how you use your power. That's important. We can talk about it later. I can go on a long time for this.
Thank you. We have one last burning question here. Or two, three.
Thank you very much for the wonderful discussion that's going on. Having you practiced in South Africa and in Europe, probably will be in a position to advise. We are often encountering situations at the clinical area whereby we want to co-produce, yet the ball is returned to our court to decide for them. Our patients want us to decide for them what is best, especially in surgical practice where I am based on. Say, this is a procedure, this is what we can do. Say, you, doctor, knows it all. Please decide for me. What will you be your comment on that? And last is the clinical area average. I see patients 30 to maybe 35 on my clinic, and this starts probably at 9 and it should be ending at around 3:30 during the day. Now, in the process of co-producing in a crowded clinic like that, how to navigate? What are the advices? Because the context in Africa might be different. I go to the hospital, I do not know who will I see today in the clinic. Well, then, even if you give them an appointment, they will not come because of the road issues, rain that has happened, has been raining somewhere, muds and everything. And therefore, I'm going for a day with an open mind, seeing everybody as opposed to other people who consult 2 or 3 patients in a day. Thank you.
Yeah, okay.
Thank you.
So look, it's not about time, it's about mindset. Because once you start thinking co-production, it's not the time it takes, it's about the questions you ask. It's about your relationship. Your relationship changes. So when the patient says, what would you do, doctor? I'll say, it depends. I'm not you, but these are the options, and you choose the options with you. So you're trying to change your wording with the patient. You'll find that initially, as you learn in the steps of the new dance, it'll take longer. But as you become adept with the dance, the patients will start learning this new dance too. And we've got to change really the way the patients dance as well. We've got to say, so one of the projects is about self-management, how we get people to self-manage. And so how do we get them? So what we'll do in a clinic, my clinic in the epilepsy clinic or the diabetes clinic, we used to have them a little questionnaire. What do you want to talk about today outside? So when they came in, I'd say, well, what matters to you? Okay, we've got to finish last question, and then I'll catch you afterwards. But the key thing is changing the mindset. That's the first thing.
The last question.
Yeah.
I apologize. We all know that somebody has to play that lovely role.
That's the last question.
So I'm the last question.
Oh, you're the last question.
For you,
Yeah.
and Faith and Dami, you can come join me here. So we've talked about many things. I want you to maybe list what kind of websites should we be paying attention to? Okay. What kind of resources? Please join us here, because that's the feedback from the microphones. Join us here. So what if I'm new to QA, maybe I'm mid-level, how do I increase my knowledge, increase my exposure? That's the closing question.
Okay, this is quite a difficult one because there isn't much out there. There is some of the theoretical papers. So, good news, my last meeting with Paul, we decided, well, he has this idea, and he said, I can really, I'm turning 83, and one of the last things, one of the things I want to leave a legacy is we're going to have a repository online of all the things on co-production. So one of my jobs is to start developing a website for co-production, which is going to come soon, hopefully soon. I'm not sure how soon. So we're going to start collecting this stuff.
So follow Dr. Lachman.
Yeah, follow up with me in a
There's
few
going
weeks.
to be a soon coming repository of different information. I'm going to ask that question to Dami and Faith too. Because how did you get to know what you are? So after Lachman, I want to know, what did you read? What courses have you done?
Read?
Yeah.
Well, you see, I didn't realize I was co-producing for all the years until I read the articles. Now, what will happen is I've got lots of articles on co-production. So I've got articles of the theory of co-production. But co-production really comes not from healthcare. It comes from social care and political environments. And I'll give my last story. last story. So in 1992, when Mandela was released and so on, and then the ANC said, we now need a new constitution. We co-produce it with the population, and they had people's assemblies around the country. And then they said we need child health policy, so we had co-producing child health policy around the country. So I learned then that in the political and social environment, you can co-produce with the people. So we learned then, and then I discovered that that's what we were doing with the mothers in the village, with Gobi FFF. We were co-producing.
Okay, so are you now going to plug your Oxford handbooks?
Yeah, in the Oxford handbooks, we've got co-production. So the Oxford handbook, I don't want to sell my book, but...
I want you to sell your book. Go
She
ahead.
wants me to sell the books. So if anyone wants the books, come to me for the... they've got the code. But what we did, I wrote 3 books, or edited 3 books, co-produced them with my trainees, because they need chapters. First one's patient safety, second one leadership, and the third one on QI. And the QI one is based on this, quality 1.0, quality 2.0, quality 3.0. So that it shows you the journey that you've got to go through. So the chapters on quality 1.0, the chapters on quality 2.0, but the main theory is that it's about quality 3.0. And so you can,
You're giving me permission to share your discount code.
Yes, I'm giving you permission.
So in today's end of day email, which we'll send to everyone participating online and in person, we will share the discount code. Let's have some clicks for that handbook.
Yeah.
But I want to hear from Dami and Faith, who've done a fantastic job.
Yeah.
Where else should someone new to this look? What courses, what ideas, who should they follow? Where do they start?
Okay, I'll start with my story. When I started...
I don't want a story. I want
quickly. Okay. I joined, before I became the executive manager for SKHN, this was a while ago, I took courses from SKHN.
Okay.
So I don't know about SQ8K. I don't know whether you have courses as well or you have affiliates. So look to your country. You may have a society like ours or SQHK, and then there's IHI. There are other online resources that you can look to.
As well.
ISQA, yes.
And the African Community of Practice that Rhoda and I are a part of have monthly webinars that are a fantastic resource. You can find all of them online.
And ours last week.
Yes. Yes, he was the one doing it last week. We'll plug all of that in the email.
Yeah,
Thank
on
you, Dami.
kindness. I wouldn't mention anything different from what she has, but I will say, if you reflect back on your practice, you will realize you may have been doing it even before you had a name to it.
Yes.
How many of you have been engaging patients in decision making, including their feedback in your change processes? So you may have been doing it before there was the name co-production, but now there's the science and so much language behind it. Yeah.
So basically, reading gives you an opportunity, learning gives you an opportunity to put language to the ideas, beliefs, practices that you probably already have. Final word to you.
Yeah, so what I really like to see that's coming out of this meeting and other meetings is that when I was at ISQA, I was the proprietor of the ISQA Journal, because we owned the journal. And I was with Soji Soji, you know Soji. And
shout out to Soji Soji. He was on Acquire's fast board. Fantastic, fantastic.
So Soji, I said to Soji, you must stand for the ISQA board. So now he's on the ISQA board.
Yes.
And while he's still at IHI, now he's not too big as things.
He's at Gavi now.
Yeah, now he's in government in Ghana. Anyway, so I said, Soji, we looked at the journal and I looked for the papers from Africa. Because when I went to ISQA wasn't interested so much in Africa, and I come from Africa, so I said, I want to do this. So we concentrate on getting people from Africa to join the fellowship, but to get people on the board, that's the important thing. So now Soji's on the board. And I said, we need to publish from Africa where the first author is African. It's not colonial research. from upper income countries, where they come here and research on Africa and they take first authorship. Where the first author is from Africa. And what I'd like to see from all of you is start publishing papers with first author from Africa.
Can we all do this? Because this is commitment. This is commitment.
Yeah. So we set up a program in which we would support authors from Africa to publish. We set up the fellowship with Rhoda. There she is. And when I left ISQA, I said, now I need fellows. So I went to the Patient Safety Movement Foundation. I saw the advert. So we have fellows from Uganda, Nigeria, Kenya, and we're looking for more this year. So the thing is, you have to find African solutions for African challenges and publish. That's very important, to let people know you have the solutions. And you have to adapt all the stuff I've taken. See, a lot of the stuff is done in upper income countries in a different context. You've got to say, how does it work here? How does this co-production work here in Africa? We've got low resources, but we've got people power. Remember, you've got people power.
We've got people power and we've got the solution. So now, I want by show of hands, God willing, we get to have this Quality Improvement Leadership Forum in 2026. How many of us will be amongst those submitting things that we've put out for publishing? I want to see by show of hands. Because we are the writers. We are the ones who are going to document our work. Rhoda, why isn't your hand up? Come on.
So just to say on writing, so to make it a little easier, is that people often want to write in the journals, and the journals turn things down from Africa because the writing's not good. So we have a mentor or coach, and this is something a choir could do, is have a mentorship program so that you get mentored to write your project in the language that you have to publish. And we set up a second journal called ISQA Communications, which takes papers from low and lower middle income countries. So it hasn't got its number, but you can impact factor yet. But the idea is that it can get published very quickly into get publishing, because once you've published one, that's the first PDSA, the second is easier, the third is easier. And people say it's nothing new, but you say it's new in Africa.
And it's just the first step, guys. That's what we talked about. The first step, that first poster, that first thing. Please join me in giving this wonderful session 5 facilitators the applause they deserve. Thank you very, very much.
And let's dance.
Let's dance.
Now, I just want you to say, I want to ask Rupel, who is the dancer of the day?
Today?
Yeah.
Oh, wow.
You
That's
choose
a really
the dancer
good
of the
question.
day.
Is Wambui? Where is Wambui? From Kijabe? Ah. Mary is the dancer of the day. Sorry, remind me your name. Victoria is my dancer of the day. There we go.
Give Victoria a big round of applause.
Okay, so...
And then finally, must thank Ron. Without Ron, nothing would have happened.
Yes.
And his team.
Ron and his team, we all know. Ron knows that we've been thanking him. So I now have taken many of your tea minutes. But because these are healthcare workers, I'm pretty sure you can do tea in like 15 minutes. I have had Lydia say, You know, I know your voice from far. So let's have a negotiation. It is 10:54. So can we be here at 11:15? That's 21 minutes. That's more than enough. The tea is just outside here. 11:15. See you after break.
As you go, I have 2 questions or challenges. The first is, what next thing are you going to do differently? You can discuss that as you're taking tea. And the second, how do you translate the question, what matters to you, from English to your mother tongue, Kenyans to Swahili, if you're going to be speaking to a shosho, how do you ask that question in a way that she understands what you are asking her?
Yeah, and online, please, could you write it in your language into the chat? Thank you. Thanks to my colleagues, yeah.
And if you left your charger, I have a Samsung charger, and I don't mind having an extra one, so I'll just assume it was a gift. Thank you.
It do happen. Really get up.
We have presented with Annette Nielsen from Jonshofen, and we actually did a dance. We started doing dancing. Yeah, we had 2 sessions, yeah, but we'll do it again if they accept for next year, because I'm not going to California.
Is this where you want us?
Yes.
Okay.
This is for half one.
You're clarifying.
Ngiyakuthanda baby angisifela ngawe ngizokunika indandatho zokunika indandatho ngiyakuthanda baby angisifela ngawe ngizokunika indandatho zokunika indandatho ngiyakuthanda baby angisifela ngawe.
Check 1 2.
ngithetha nawe sithi kuwe ngiyakuthanda mna iwe ngiyakuthanda oh yini sithandwa waske wathula wangandihoya ndixelele uba ngiyakuthanda mna iwe ngiyakuthanda ado tanzoto andinawo amazwi anzuthetha nto eninzi kodwa ndifuna ukwazi ndiyakuthanda mna ndiyakuthanda thanda thanda andinawo amazwi andizothetha nto eninzi kodwa ndifuna ukwazi ndiyakuthanda mna iwe ndiyakuthanda amara wenza mangenza sonomulalisa maketa ize iwe baste mara wenza mangenza sonomulalisa maketa baby please iwe mara wenza mangenza sonomulalisa maketa ize iwe baste mara wenza mangenza sonomulalisa maketa get down
Thando lami luzokuvilisa wena sekufika isikhathi sokuthi sibe ngempela uzongithanda noma le nto izophela uzongithanda noma le nto izophela thando lami luzokuvilisa wena sekufika isikhathi sokuthi sibe ngempela uzongithanda noma le nto izophela uzongithanda noma le nto izophela themba lami nakho konke shabalala cela usize nakho konke konakala themba lami nakho konke shabalala cela usize nakho konke konakala themba lami nakho konke shabalala cela usize nakho konke konakala themba lami nakho konke shabalala cela usize nakho konke konakala
andinawo amazwi anzuthetha nto eninzi kodwa ndifuna uwazi ndiyakuthanda mna iwe ndiyakuthanda amara wenza mangenza sonomulalisa maketa ize iwe baste mara wenza mangenza sonomulalisa maketa baby please iwe mara wenza mangenza sonomulalisa maketa ize iwe baste mara wenza mangenza sonomulalisa maketa get down
When we talk about predictions, exam predictions,
don't wanna let go, baby girl. Ngicela sihlale phansi sibonisane. Oh baby ngiyasola ngeke ngiphinde. Mase silwa sona ngeke kulunge. I don't wanna let go, baby girl. Ngicela sihlale phansi sibonisane. Oh baby ngiyasola ngeke ngiphinde. Mase silwa sona ngeke kulunge. I don't wanna let go. Afuna uphilanga phandle kwakho, phandle kwakho, phandle kwakho. I don't wanna let go. Afuna uphilanga phandle kwakho, phandle kwakho, phandle kwakho. I don't wanna let go. Afuna uphilanga phandle kwakho, phandle kwakho, phandle kwakho. I don't wanna let go. Afuna uphilanga phandle kwakho, phandle kwakho, phandle kwakho. I don't wanna let go. Eish, no. Hlezi sixabana njalo. Bey, ayikaso. Cela siyeza izolo. Uthi kusoba ngcono. Baby, wathi ngeke kubeso. Yeah, no. Angeke ngikhona no more. Yaza ngithanda indlela okhuluma ngayo nami. Ngoba angicasoli ngakho vele ngihambe. Bese ngeni ikholi yakho. Vele ngikhohlwe ngijabule. Ngimemeza igama lakho. Cela inkosi ukuthi igcine. Don't wanna let go, baby girl. Ngicela sihlale phansi sibonisane. Oh baby ngiyasola ngeke ngiphinde. Mase silwa sona ngeke kulunge. I don't wanna let go, baby girl. Ngicela sihlale phansi sibonisane. Oh baby ngiyasola ngeke ngiphinde. Mase silwa sona angeke kulunge, angeke kulunge. Afuna uphilanga phandle kwakho, phandle kwakho, phandle kwakho. I don't wanna let go. Afuna uphilanga phandle kwakho, phandle kwakho, phandle kwakho. I don't wanna let go. Afuna uphilanga phandle kwakho, phandle kwakho, phandle kwakho. I don't wanna let go. Afuna uphilanga phandle kwakho, phandle kwakho, phandle kwakho. I don't wanna let go.
Work today is broken. We're all working in too many disconnected apps, and it's killing team productivity. But for
Masoli ayitsho njalo lento sithandwa sam it's nga phandle kwakho.
Okay, ngoba ndi-wrong. Sobona uba uzokwazi ukuzifleha uzenze mhle for i-contest kaMr Soweto namhlanje.
Masoli contest yi-contest.
Okay, ke uyazibona ke pipi.
Okay, Jonga, does wena focus apha ekundenzeni mhle enhloko yami and ndiyakucela man maso.
Why do farmers go for expensive credit? It's because they have to wait longer to get paid. So first of all,
baby wami tingikuchile funa ungizwe ayafana majens ayafana majimbusi abanye basukushila bathi umuhle kodwa ayafana majens ayafana majimbusi bayafana bafila yoma yo nyakjela ayafana majens ayafana majimbusi yoma yo nyakjela ayafana majens ayafana majimbusi ayafana majimbusi namangaze kodyanjani zothutolo ngatorati achikele nje kanjalo zothumuthi amaze afela komangaze nyabona nkolo lalela nana lezinto zakho esizibona imihla yonke bazothi kuwe uyaqho ngabungafuna ukubaqho yebaba hlukile bakho kodwa kulula ukubabona vula amehlo mntana mungadlala bafa baby wami tingikuchile funa ungizwe ayafana majens ayafana majimbusi abanye basukushila bathi umuhle kodwa ayafana. Baby wami tingikuchile funa ungizwe ayafana majens ayafana majimbusi abanye basukushila bathi umuhle kodwa ayafana majens ayafana majimbusi bayafana bafila yoma yo nyakjela ayafana majens ayafana majimbusi yoma yo nyakjela ayafana majens ayafana majimbusi ayafana majimbusi namangaze kodyanjani zothutolo ngatorati achikele nje kanjalo zothumuthi amaze afela komangaze nyabona nkolo lalela nana lezinto zakho esizibona imihla yonke bazothi kuwe uyaqho ngabungafuna ukubaqho yebaba hlukile bakho kodwa kulula ukubabona
So you're kind of waiting for like for you. Wow. Okay. Yeah. So you see, there's a theory of kindness in bodies. Yes. Like every experience. So I'm excited. You are so kind. I don't know that I meet that criteria, but it's called pressure. Okay. So we are giving you how many? So it's I want to talk time. So it's 11:20 now. Yes. Can you give me the mic at 12:30? It's what time now? 11:20. We'll give the mic before that. Good morning to you. How are you? I would like a second mic, if that's possible. How many people here know Professor Bukusi? Know Professor Elizabeth Bukusi? I can see 2 hands. Could I have a second mic? Because I'm about to ask you, why is she fabulous? You know, it's one thing to say someone's bio, and then there's the one, you know, the real life human bio. There you go. I'm coming to you next, Dr. Ratan.
Maybe you can start with him.
No, you go ahead. Why not? Your name and why you think she's fabulous.
My name is Raj. I'm currently head of Gynae at MP Shah. Professor Bukusi, we first met when I was an undergraduate student. And just the way she carries herself and the way she speaks is something that is worth emulating. She's always on time. She has lots of good things to say. And I'm really looking forward to this session.
Exactly. You know, you can read the bio on the screen, but this is a real life bio. Who wants to be number 3?
Yeah, thank you. My name is Stephen Muhudia, and I'm pleased to say that I've known Professor Bukusi for a long time, from our younger days, and she used to challenge my children to do many activities, and the children are now adults. But we have worked with her. She's an obstetrician. Basically, when she used to do obstetrics, I'm a pediatrician, so we work together. But we also share common interest in bioethics. And she's been my mentor in bioethics, and together we work together in the Bioethics Society of Kenya. Thank you.
Thank you. So Tenza, do you want to go? So I only have space for one more. So Lydia, do you have a mic? Okay, I can see.
I have a mic. Professor Bukusi, during her meetings, she's always knitting some things for her mentees who are having babies here and there. And we are together in the investigative committee for organ transplant. So there's a lot of work, but she brings us gifts. Yesterday I was eating groundnuts with my husband, which were given by Professor Bukusi from the work we are doing in looking at organ transplants in Kenya. Great.
So I hope you're getting a sense of the person who embodies the title of this conference. She genuinely co-produces. She is kindness in person. So I am so glad that she's a part of our choir board from the very beginning. Just know Mary Lydia and I would not be here if her words did not speak life into us over and over again. So it's my pleasure to hand over the mic to Professor Elizabeth Bukusi. Let me also give you this one in case you want to move.
Okay. Good morning, everybody. Good morning to those who are online. I believe we have people online. Good morning to everybody who's online. It's a great, great pleasure for me to be here. I also now feel under immense pressure because of the fact that it has been said that I'm kind now. I have to embody that kindness in some way. But it really is a great pleasure to be here this morning. I was hoping and praying that I would be here on time, and I'm glad that I was able to arrive on time. May we have the first slide, please? My challenge this morning is to talk to you about from principle to practice, co-production and community partnerships in health systems. And I hope that something I say in the next few minutes will be helpful for you as you think about health systems within the places that you work in, the quality of care that you give, and perhaps how you can relate kindness to that. Next slide. That one just speaks about who I am and the many different hats that I wear. So we can slide over that one and go to the next slide, where I want us to start talking about kindness. So, in talking about kindness, I'd like to ask the first two people to stand up. Any two people to stand up. Any two. And Ruth Pearl, help me identify who's the first two people to stand up.
There's a number one here.
A number one and number two. Number two. Please come. I want to be kind to you because I want to give you something. You haven't asked for it.
Please
You haven't
note it
asked
was
for
men.
it.
It was men. It was not the women.
But I want to give you a book that I hope you will find helpful. So you probably were not expecting that someone would be kind to you and would give you something that you hadn't anticipated that you would get. There'll be another opportunity for someone to stand up quickly. But for now, I want to ask you to think about the word kindness. What does kindness mean? What does kindness mean? And I'd like to give you just 2 minutes within the tables that you're seated on. And for those of you who are online, I'd like you to type it in the chat and just say, when you think of the word kindness, what does it mean? So 2 minutes. On your tables, please have a discussion with each other. The person you didn't want to talk to and you didn't know why they sat on your table, tell them what kindness means to you. And those who are online, please type something in the chat so we can ask someone to tell us what you've said. 2 minutes. You've got a minute left. We're down to 30 seconds. All right, your time is up. Let's start with hearing what some people who are online might have said to us. Some people who are online. Ruth Pearl, or someone who's able to access, can we hear what some people online are saying about kindness?
Museo, go right ahead.
Yes. So we have a comment from PHU saying putting yourself in the shoes of a person and understanding their situation and their needs without them asking for it. We also have a comment from Adiola. Kindness is rendering help to someone without the person asking. We have Gladys Mutinda, who says just being good and concerned of other people. We have an interesting one from Oyela Dun, empathy, putting yourself in another person's shoes and addressing a situation in the way you'd have loved it addressed if you were in the same position. I'll pick another random one. Simple. Elizabeth Shonko says, doing to others what you would have them do to you.
Very nice. Thank you so much for the people online, and thank you for raising those concerns. I want one table, and only one table is getting this opportunity. Who wants to tell us what they discussed on their table? Kindness. Any table. One person to volunteer. All right, we have a volunteer right there, please. You can have a mic.
So we've discussed on the table and with Prof here that for kindness, when you see the need of someone and give something out of it without necessarily feeling that they are obligated to give something back. And when the reciprocity happens, which was not expected, that one now comes to gratitude or thankfulness, which we felt is now like the other arm of kindness. Yes.
Thank you very much. So you took it a step ahead. You took it from kindness, you even went to gratitude and reciprocity. Excellent. Let's have the next slide. I want you to talk on your tables again, and those online, you need to chat online. I want you to think about the most recent act of kindness to you as a person. When has someone been kind to you? That's number one. Number two, think about the time you have ever visited a healthcare facility. You might have been the patient, or you might not have been. Maybe you took a patient, or you went to see a patient who was in a healthcare facility. Can you recall an act of kindness? I'll be very generous and give you 3.5 whole minutes for you to talk about this. So, what's the most recent act of kindness you have seen as a person, now that we've said what kindness is? And when you last visited a healthcare facility for any reason, maybe it's because you actually went to work there as well. What act of kindness have you seen? Your 3.5 minutes have started. Please have the conversation, and those online, please engage with us. Please let us know. Type in the chat any answer to any of these two questions. So let's go ahead. Now, some people are looking like the people around me aren't kind. I'm sure there's someone kind around you. You have 1.5 minutes left. We are winding down. All right, thank you very much. Now, let's hear what people have been able to find out. Let's start with our online audience, and let's see whether they've been able to tell us any acts of kindness to them as people, and any memorable act they can remember when visiting a healthcare facility. So, let's hear from the online people first.
Yes, so we have a comment from Yotamo saying, one day I saw an old woman pushing a wheelchair with a patient on it, and a man just came and said, you are alone? And the old woman said yes, and the man just, okay, let me push it and tell me which side you are going. So to me, I saw this man acting kindness to the old woman.
That was indeed a great act of kindness. Thank you. Any more?
There are quite a number, maybe just one last one.
No, give us, we can listen to a couple more, please.
Okay, great. So we have Beatrice on Twitter. She says, my son fried eggs for breakfast as I was busy preparing myself for work today without me asking him to. I recently took my daughter to the nearest primary health care, and the doctor was so kind to me. He let me explain and requested for some tests, which led to the correct diagnosis. My daughter is okay.
I want to borrow that son who fries eggs in the morning. Huh?
Yeah, and I thank him for understanding and being so kind.
Kind doctors. Keep going.
There's another one, a person have been kind to me when I reached the hospital with my daughter without knowing me as the boss of their boss. They received us politely. I think they wanted to write some more, but it just got cut off. And then we have another random one. Elizabeth Mutier, act of kindness. A colleague asked if I was caught up in the mandamanos when they saw me missing at work.
That was kindness, yes. Checking on you, whether you are okay.
Yes. Beiragad said someone got concerned about what I was going through at work and offered to me words of hope and counseling. Then we have Rafiat who's saying being attended to with a welcoming smile, empathy, understanding, and a listening ear to address my concerns. There's another one. My wife complimented a meal I made for her yesterday. That was kind of her because I went through some hurdle getting it done.
Wow! There are some champion men there. Young men who make eggs in the morning, men who make dinner.
Yeah.
I don't know. The guys in the room here don't look like they're making dinner for anybody. Any more?
Yes, the same guy continues. At a clinic once, the matron gave a word of assurance that a procedure will go well. Just the assurance alone was it for me.
That's great. And how often we forget to reassure people even about simple things like that. Excellent. Now let's hear whether there's someone in the room. Thank you so much, those online, for participating. Let's hear if there are people in the room. 3 tables get an opportunity. The mic is ready to go around. This table can't go alone. Yeah, Yani, you are hogging. Let's see. Yeah, I can see one there, and we'll have a third one at the corner. Let's start with, yes, you got the mic first, so go ahead.
Good morning.
Good morning.
Recently took my daughter for an eye checkup, and I interacted with the doctor who didn't know we work in the same place. And after that, he gave me a consultation for free.
Wow, that was kindness. Yes, let's hear on this side.
I think sometime last year, I had a very busy night shift in the labor ward. There was a mother that I really took good care of her in the first stage up to delivery. It was a difficult delivery, but at least the baby scored well. So it was around, I think, 2 a.m. So I went back to my nursing station and kind of started to doze off because I was so tired. So little did I know she came and tapped. I had someone tap my shoulder. Looking up, it was her because she was going to the washrooms, and then she had 2 bananas for me and told me, you can have this one because you were so kind to me. And she had initially lost like 3 babies through it. She had 3 miscarriages, so that was her first baby. So I gladly took those bananas, and at least I felt my strength coming back. So till today, I've never forgotten that patient.
Wow, a banana can be very special. Somebody in the corner there.
I work in Kijab, and ago I saw one security personnel wheel a patient up the ramp to the clinic that is way away from our general outpatient clinic, and I felt that was really kind. It was not the patient's relative, neither was it anybody else, but it was actually a security personnel. Yesterday we got lost in the basement, and one of the staff who works here walked with us and showed us around until we found where the car was parked. So that really came.
Thank you. That was kind. That was kind. That was really kind. So let's go to the next slide and talk about, so what is kindness? And you all talked about it because you know it in some way. Next slide, please. When we talk about kindness, and you've mentioned this so clearly, it's being friendly, generous, considerate. I've heard people say showing empathy and compassion. You've talked about generosity, helpfulness, and concern. And some of you have even mentioned the fact that you don't expect anything back. It's not a quid pro quo, that you're giving in the hope that someone else will do back for you. You are simply giving out of the generosity of a heart. Sometimes kindness can also be directed towards ourselves and towards others. And in fact, sometimes the people we are the unkindest to are ourselves. That sometimes we will be kind to others, but we will be unkind to ourselves. Things that we'll excuse for others, that we'll give space to, we do not necessarily consider or give for ourselves. So keep that at the back of your mind. Kindness is not just towards others, it is also towards ourselves. Now you're probably asking yourself, next slide please, how does this show up in real life? And what does it really have to do with the everyday things that we have to face when we are walking in life, and especially in this particular field of healthcare? Next slide. So let me break it down a little bit more, and then I'll tell you a story, and then see how can we link it to the healthcare facilities and the healthcare space that we work in. I want you to think about generosity, that it's about giving of your time and resources and energy to help others. And those of you in the healthcare field have to some extent already committed to this, because for many of the services you do, nobody can pay you adequately to actually cover your time. If it was to be costed in terms of shillings and cents, then you wouldn't be able to do the job that you do. Because even when you are remunerated, it is not commensurate with the effort that you probably make. Think about it as consideration as well. And I heard the discussions around somebody going to wheel somebody on a wheelchair. The kindness in reassuring someone else that it was going to be okay. So it's being thoughtful. And somebody said right at the beginning, putting yourself in someone else's shoes so that you understand what they feel and what they need so that you can respond to it. It's really about compassion as well. The empathy that we feel, because the people who come into our spaces are often suffering. Their suffering is not always visible, and their suffering comes in many forms. It can be physical, it can be mental, it can be emotional, and often it is also financial, because there is a cost for them. Even if the cost is the fact that they are missing an opportunity for gainful employment, gainful work that contributes to their well-being. So in this space, there is a need for us to be selfless in some way, that we do these acts of kindness without expecting that somebody else would give us something in return. And it requires to some extent that you must be able to have an attitude that really speaks of goodwill, that you want to be positive and you want to be helpful. I want to take you back again to the workspaces, perhaps where you work or an encounter you have had in a facility, where someone has been thoughtful or kind or positive. Measure that up to a place where someone has been rude, someone has been inattentive, you have been ignored, You've been kept in a queue when someone's busy with their phone, and it's very clear to you it's not necessarily a work thing that they're engaging in. Someone has allowed someone to jump a queue that somebody shouldn't really be jumping. Or you've been kept waiting with no explanation and not being told why it is there may be a delay. Many little acts that contribute to causing discomfort within the health space. But you might ask, so what's the point? Does kindness help at all? Let's go to the next slide. There are benefits that come from kindness, because just the act of being kind will really help someone else's day be better. Being given help when you're not expected, even if it's just being pushed on a wheelchair, or being helped and being guided to find your way in a place that you're lost, it makes a positive impact that often has a knock-on effect and is passed on to someone else. In healthcare spaces, people are often stressed. If you measure someone's blood pressure before they come to a healthcare facility and after they reach the healthcare facility, chances are very likely you'll find it different. Just the act of stepping into this up space makes a difference in terms of raising their stress. They don't know what they're going to find. They don't know if what they have right now, it's something simple or it's something complex. And even when you go in for something as simple as a checkup, at the back of your mind you're thinking, what if they do find out something that I have no idea I have, but that is going to make a world of difference to me. So just the act of kindness helps improve, reduce stress, improve people's mood, and we know very well that improved moods and positive outcomes, it boosts people's immune systems. One of the good things about kindness is that it also strengthens relationships. We as humans, just like a lot of nature, we are made for connection. We are made for connectiveness. And even those among us who are the most introverted and want to spend time by themselves, we get to a place where we want to connect. And that's why things like social media become so powerful, because they give people an opportunity to think, I'm connecting with other people. There are people who think like me. There are people who see things the way that I can. There are people all over, everywhere, who in some way are like-minded. For the time that we have here on earth, people are looking for meaning. People are looking for some source of happiness, some positivity. And acts of kindness are those that can lead to feelings of a lot of fulfillment and a lot of joy. Next slide. In my next few minutes, I hope that you'll be able to help you understand how co-production and its relevance to health systems can help us think about how we can bridge the evidence that you already have as quality care specialists, where you know a lot more than I do, and how this can help in the real world setting that we live in the contexts that we work in, where resources are limited, where healthcare staff sometimes are few, where the needs are very great. How can we make a difference in being able to make people kind and to help this be part of what helps inform quality within the healthcare space? Next slide. I'd like to tell you a story as I promised. The story comes from the Bible. It's about the Good Samaritan. Next slide. This is a parable that was told by Jesus as narrated in the Bible. So what is this story about? The story is about a person who travels. Number one, he travels alone on a road that was known to be dangerous. A road that was known that it was very likely you would get attacked. I want you to think about that from the context of the healthcare spaces that you are in. Often people take journeys. Often people make decisions that you're thinking, you know what, that may not be the best space for you in terms of your health. People make choices, people make decisions that will impact their health in one way or another. This man travels, indeed he does get attacked. His belongings, his goods, his transport, everything is taken away from him and is left essentially as good as dead. He's lying on the side of the road. A couple of people pass by him. Now, we are very quick to judge sometimes and think, you know what? The Levite and the priest who passed by him should have known better. These were people who knew the law, who knew about kindness, who knew about caring about the other person. Why did they just pass him by? But I want you to place yourselves in their shoes and think. When you pass a place that is dangerous, that is often known to be a place where harm can happen, what is our reaction? Think about the last time you might have seen someone who had had an accident on the road. Or the last time you might have seen a situation that you as a healthcare personnel recognized was somewhere that needed help. Chances are the majority of us had a very good reason for why we could not stop. We were in a hurry. We were going for an interview. We had a class to teach. Someone else will find them. I hope someone has called an ambulance. We all have very good excuses for why we don't stop, why we are not the person who stops to push that wheelchair, to find out what's happened to that individual who seems to need some act of compassion, some act of care. None of them stopped. They were in a hurry. They didn't want to get defiled. They would not be able to perform their rituals. They were concerned, but you know, it's easier to walk on the other side and keep going. So finally, someone else comes by. In the parable, it is a Samaritan. The Samaritans typically, and the Jews, had a relationship where they essentially avoided each other. They didn't relate to each other. But this person was kind. He stopped. He was at risk as well. Whoever had attacked this person could attack him. But he stops. He stops. He binds the wound of this person. He offers them some of his own food. He lifts them up onto his own donkey and carries them, putting his own life at risk to carry this person to the nearest place where they could get help. But when they get to the place where this person can get help, he doesn't just leave him and say, you know what, I've done my bit. He takes him to the innkeeper, as the story goes, and says, I'm giving you some money. Please take care of him. Bind his wounds. I'm continuing on my journey. And when I come back, if you will have incurred any extra expenses, I will make good whatever you have incurred. He went the extra mile, not just rescuing the individual, but going beyond what we would call the call of duty to be able to help somebody else. Let's pause there for a moment. I'd like you to reflect and reflect to the people on your table. Can you think of an opportunity? Maybe it's not you, but maybe it's somebody else, where you have seen someone go beyond the call of duty in a situation that could have been uncomfortable, but they've put themselves out not only to provide care and step out of their comfort zone, but gone beyond the call of duty to help somebody else. Perhaps even at their own expense, perhaps even at the risk of their own life. I'll give you a couple of minutes to think about it and talk with someone on your table. Your 2 minutes has just started. Those online, feel free to chat and type something. We've got about a minute left. Okay, we can wind it up there. Let's see whether anyone had anything to say online. Our online colleagues, did anyone have anything to say?
Yes. We have Beatrice on Twitter. She's been very active online today. One of our patients was waived, yet didn't have fare home. We had a small fund drive for her, and yes, she had fare home and from the nurses' pockets and enough for supper for that day.
That's a beautiful story. That's a beautiful story. Thank you, Beatrice, for sharing that and for the kindness exhibited by that group of nurses.
And then there's one more from Vivian. Yes, those professionals who died during COVID pandemic, who goes beyond the call on their duties, going beyond their call, that is an act of great humanity, a service worth remembering.
Very true. Those in the front line, especially for epidemics or where there are infectious diseases, knowing that any day you walk into a facility, you're putting your own life at risk. Truly, truly a great kindness. There are some tables that have not had an opportunity for someone to speak. Let's give 2 or 3 tables. There's one table there, the hand is up, another table right there, and one more table can also tell us. So there are 2 that have gone up, one more table has the opportunity. Okay, 3 tables, great. 1, 2, and then 3. Please go ahead.
Yeah, Simon from Kenya. I live closer to the road. This night it was last week, I was called at the midnight. And when I went to look what am I being called for, I met, this is a teenager on the road who is delivering. And when I was called, I knew if you are called, walk out with gloves. So, and I went, delivered this. I mean, the teenager was saying there is something coming out of, and I had to, now it's on the road, I had to deliver this, it was a premature baby.
Oh.
And this was a hard thing. So, and I had to tell her, please, would you mind if you put out your cloth, put the baby between the breasts, and then hold the head of the baby. Please, can we, the next thing is, can we make you clean a bait and thing with all the clothes from the mother? The mother was standing by and I was wondering, what am I really doing? Am I doing my own things? And then the next minute was, drive this baby to, I asked them, where do you want to go? Where do you want to go for the health? They said, I want to go to Naivasha district. Oh, okay, this is where you want to go, okay. I took my car from home, put them in, and I drove them to the hospital. That's the part that I felt like, and then it was the middle of the night.
Thank you for that beautiful story. We have Samaritans among us. Yes, please.
Thank you very much. I don't have a specific story, but it's a kind of practice in our country, most especially when we have pediatric patients. The first thing we think of is we put ourselves in the shoe of the parent. If I were to be parent of this child, what would I have done? So most time we go to the length of contributing money to the child for the care of the child. In fact, I belong to a doctors group such that in different hospitals across the countries, once you see a patient that cannot pay bill, you make a request, then we contribute money. So it's a kind of general practice in our country. Thank you.
Thank you very much. We have one more story at the back. Okay, 2 more, and then we'll be done. Yes.
Well, this was recent when we had the Mandamano, which was on Monday, and I remember that it was not easy to go to work because all the roads had been closed, and we didn't know what to do to get to work. But then now I don't really directly get to touch the patients, but I told myself, for some reason this statement made sense. In a world where you can be anything, be kind. So I just told myself I'll go to work and support where I can. So that day I remember, even I had to call an Uber. The Uber charged me double price. I said it's okay. And so we reached, and of course not many people had reported to work, so I told myself I'm going to give moral support and support where I can. So I remember going around the departments, finding out who is there, who's not there, how can we support, where can we get people to assist where there are no people. These people who have slept at night, they're not able to go home. What do we do about it? So I remember we organized for some breakfast, for some tea, we organized for some lunch, I organized for some dinner, because the people who slept there from night to the day to the following day, because there was no means to go home. And then there's a way I managed to organize to get people from their place who could come for night duty to relieve others, those where we could with an ambulance. And it was a very stressful day. Of course, things happened. The support from there were very many casualties, but the support I gave going there to support, to see what can we do, what can we help, what can we do, that today has made sense. Yes.
Thank you very much for that kindness. Was there one more hand in the table that was ahead, please?
Hello, everyone.
Hello.
My name is Rispa from Nairobi West Hospital. For me, it's about this mother who came at 6 months pregnant, and unfortunately, she also had another girl, 4 years old, newly diagnosed acute myeloid leukemia. It was very tough on her, the fact that she's already pregnant, the risk of maybe miscarriage or even panic that could give her premature labor. Now, in the course of treatment for this girl, at some point she got to a platelet count of 2. So at that point she could no longer get treatment and we had to give urgent platelets. So I took the initiative because we matched the blood group and gave a pharetic platelet to this girl. And till today, she's doing well with her chemotherapy, and it makes me happy until to date.
Thank you very much. There's one more hand I've just seen go up. Let me not deny you the opportunity.
Hello.
Hello.
My name is Marian Jerry from Kiambaa Sub-County. And one of the cultures that we have in one of the facilities in Kiambaa, that is Kihara Sub-County Hospital, CCC department, we started a food basket whereby by the end of the month, the staff, we take food like unga, dry foods, clothing for some of our clients because, lack of food is also a barrier when it comes to adherence to medication. And so for me, I found that working and it has always excited me. And I always hope to spread it out to other facilities. Thank you.
Thank you very much for that generosity. So I see a lot of kindness that's already going around and that is already being practiced. And that is really encouraging. So let's move on a little bit. Next slide. Because the question one may ask is, so what does this have to do with the healthcare and the quality of care? Next slide. And someone may also ask, but why should we even talk about co-production? Why does it matter? Health systems really need to be people-centered. And as I've heard you talk, I'm hearing so much about thinking about people. Whether it is the people who are unwell seeking healthcare or the people who are in those facilities providing the healthcare and thinking about caring for them as well. Because when we include people, then we're actually making it possible for us to have a system that is sustainable and a system that will promote equity. And we must remember that communities give us the context And it depends on what they have in terms of their values that will also lead to the solutions that will help us be able to ensure that we can provide care that is of high quality, but that is meaningful. Allow me for a few minutes to divert and tell you a story, a different story, about something that I was part of. Next slide. This was a real life example that I was engaged in many years ago to really improve adherence to antiretroviral treatment. Next. When I first started working in the field of research, and then later on in the field of HIV care, we came to the field of HIV care because in doing research, and particularly my research has a lot been focused on reproductive health, and of course, as you well know, one of the ways in which HIV is most easily transmitted and has been through sexual intercourse. So we have been interested in doing studies that would help reduce the potential for infection, pre-exposure related studies. But guess what? Many people who came in wanting to be part of our studies would be HIV positive. And for a long time, the question was, what could we do about it? In the early years, we had no treatment. When PEPFAR came on board, we had the opportunity to be able to start a program that would allow us to be able to provide care for those who are coming in for research, but were not eligible and therefore needed to be shunted into care. And the question we asked ourselves is, in order to be able to do this, what do we need to do? And it was clear to us that we needed to be able to have a strong collaboration, to think about how we would build capacity in providing care. We needed to engage the community in order for us to be able to have an improved response. Next. There are two young doctors who were part of starting this particular program, Dr. Jeremy Penna and Dr. Rison Marima, who started the program that we called for many years FACES, the Family AIDS Care and Education Services. Next slide. What was this program? We were working in the area around the lake, initially in Kisumu, then branching into the southern parts of Kisumu, including Suba, the areas that were very hard hit by HIV. And our goal was to be able to provide an opportunity for research that could improve HIV care, but could also prevent HIV, to end up ensuring that we could deliver services that could be accessible to individuals. In that process, we needed to train and capacity build, not just healthcare workers, but students, but also ensure that we could find evidence that would help promote policy and improve programs. And in addition to that, in order to provide services, we needed to ensure that we had appropriate infrastructure. Working with the community, we started to work in terms of ensuring that we could generate funds, we could improve capacity in terms of training, but we could also put in infrastructure. The communities we engaged were not just locally, but even from the universities in the US that we were working with. Next slide. We were able to get philanthropic donors who were willing to provide support to be able to put up healthcare facilities that now belong to the counties, that were able to expand the HIV care that we wanted to provide. Next slide. And then we realized, and for some reason, that slide has decided to go sideways. It's actually supposed to be the other way around. Life happens. It was the family model of care that we were providing. And what did this mean? For every individual that we enrolled, we needed to ensure they could be supported because of the stigma to be able to disclose. Then bring in all their family members to get tested because it was likely there were other individuals who were positive but did not know. And then enroll whoever needed care within the family so that they could come together, provide support for each other, so that we did not have a father coming in on one day, a mother on a second day, and children being brought in on a different day, but everybody could come together. We provided a family-focused way of counseling, providing family appointments, ensuring that there were support groups that could provide support for these individuals, and also in the same way, ensuring that we could provide comprehensive services, including family planning for those who needed to access contraception. One of the challenges we faced, and it's interesting, someone talked about nutritional support. When people had been unwell for a while and could not provide themselves with a livelihood, nutrition became very important. They could not take the antiretroviral treatment when they were hungry or when they hadn't eaten. because of some of the side effects that would then also lead to their not being adherent. Children needed to be engaged. They needed to know that they belonged and they were part of a family and part of a group and they were not alone. Creating children's clubs and adolescents clubs to be able to support them so that they could work together. And we also had to ensure that we could provide case management services for any services that were difficult and hard for the clinicians to work on. Next one. So what did we achieve out of this? In being able to work with the communities and with the local universities and the Ministry of Health, we were able to develop a national mentorship program. We trained trainers who would then in turn train others. We were able to provide ongoing technical support for many years. We expanded the cadre of individuals who could work within this field by training lay support teams, and were able to ensure that there were adequate children's clubs and adult clubs that could really provide care and support. We also developed for clinicians who are working in remote places what we call the Uliza line that continues today, that provided remote clinicians with an opportunity to consult for cases that they found difficult to manage. Next slide. The services have continued beyond even the existence of the program itself. And after 18 years of being funded, because we had to keep recompeting for funding, a different group was funded, but the services have continued even beyond our particular lifestyle. Next. So we made sure that the 3 C's that we focused on, the issue of collaboration and community and building capacity, were able to provide care to very many individuals who remain alive and productive today because we co-created the systems with them that could support them and allow the healthcare systems to support them to continue their lives beyond whatever infection that they might have had. Next slide. Just a picture from the past. In the days when we started working there were no roads, or the roads were not roads that you would have recognized them. And often we had to think about the possibility that you would not get to your destination and carry an extra set of clothing just in case you needed to spend the night out. Next. Let's look at a few core principles before we bring this session to an end. Thinking about partnerships, it's really important that we treat the others as equal and that we all bring to the table a level of honesty and openness. Shared decision-making when it comes to power is critical for us to be able to co-create. And we must learn that our communication needs to be clear. When I've heard your stories, I've heard stories of value, that you value the people you're taking care of, your participants, your patients, and that you're using opportunities that allow you to build on the strengths you already have as a community, whether you're contributing money to pay, whether you're thinking about someone's fare to get them home. But also we need to remember to be very clear that we do not blur any roles that may exist. We must remember that even in our role as healthcare givers and professionals, we have to be careful so that we do not cross boundaries that we should not cross. As we're delivering benefits, remember that you, also as a healthcare worker, need to ensure that you have adequate support within your own network so that you do not end up with burnout. But leadership is key. And I like the story from the colleague who went in to be able to provide support, and her leadership role made sure that the people who did not have supper last night did have supper. Some people were given breakfast, and to figure out how it is that some people could be shipped in or shipped out using an ambulance to ensure that the care continued. Next slide. The World Health Organization talks clearly about the issues of quality of care, making sure that the care is not just effective, but that is safe. And we come back to the same thing over and over again, which is rooted in kindness, being people-centered. We always must place ourselves in the shoes of others if we are going to be able to provide quality care. Next slide. So what should our services in those places that you're working in be? Remember, we started off talking about just waiting times. If you're in a queue waiting, nobody even knows when you're going to be seen. Trying to ensure that we are timely in the provision of our services. Ensuring that we are equitable in the provision of our care. It doesn't matter how your patient is dressed. It doesn't matter their level of education. They should be treated equitably, regardless of who they are. Integrating services. This was one key lesson we learned in the HIV field, that you do not need to treat someone with antiretroviral and then send them to a different clinic to go and look for their family planning commodities or their contraception. Integrate the care. Make sure they can get everything they need in a one-stop shop so that they're not queuing one after the other, or coming back even on a different day. And then making sure that we are efficient so that we do not waste resources and we ensure that these can be used well. As I come close to finishing, I want us to think about the next slide. And I want to give you a pause to think of a moment and say, so how does this all link to kindness? This is your last opportunity, and your last opportunity for somebody to be able to get yet another book. How does this link to kindness? Take 3 minutes in your groups and just talk with the people on your table. How does the quality of healthcare and improving services, how does it ultimately link to kindness? Kindness in me as a person, kindness to myself, and then kindness to those I serve. You've got your 2 minutes starting now. And those in the or joining remotely, please kindly text in your thoughts as well. You're down to a minute. As you wind it up on your table, make sure you know who's going to be your fastest on the feet, because it's going to be the table that has the person who gets up the fastest that's going to have an opportunity for this one. So make sure you've chosen your fleetest person to be ready. But you can't stand up before I say stand. You can't stand up before I say stand. Are we ready? All teams ready? You've done your summary. You've picked your fastest person, your record breaker. Okay, I'm only hearing yes from one side. This side is still very quiet. I think they're still reflecting. I really need people to be, Ruth, Pearl, Mary, I need you guys to be on really keen on who gets up first. Now let me just remind you, rule number 1, the judges are always right. Rule number 2, the judges are always right. Rule number 3, the judges are always right. Rule number 4, if in doubt, refer to rule number 1. Are we ready? Are the judges ready? All right. On my count, at the count of 3, whoever gets up first, that's the person who will speak for their team and the person who will win the last books for their team. Are you ready? Yes. All right, 1 and 2. Shall we disqualify them for standing up? Shall we disqualify them? We disqualify them for standing up? Or we are kind to them and give them another chance?
We be kind to them.
All right, let's try this again on my count. 1, 2, 3. Judges. Who was the first one? Okay. Remember, rule number 1, the judges are always right.
The
Judges?
judges are always right.
Okay. All right, that we've got a winner. All right, let's hear. Let's clap for them. Let's clap. Someone had to win. Someone had to win. All right. Let's hear you.
All right, thank you for the opportunity. We, on this table, feels that that sense of kindness will compel you or will push you to want to offer quality healthcare service to your patient and ensuring that you observe all those dimensions of quality as you offer your services to the patient. Thank you.
Thank you very much. So now this is going to be the real test of kindness because I want you to come and pick. There are 4 books here and you are 6 on that table. Now let's see how kindness matches out here. Please come and pick this. And let's watch how kindness is going to be displayed within this particular table. Now you have to figure out who gets the books and who doesn't. Keep your eyes on that table. Let's see. Let's watch what they're going to do. Let's see whether this is going to be kindness in action. We are watching you. Do you think there was kindness there? So just explain to us how your kindness has been enacted. Go ahead. Give him a mic.
I said in our group, we have 3 Nigerians in this table and 4 countries. So Nigeria decided to have 1 book while we divide the rest among.
Okay, truly kind, truly kind. Thank you very much. Thank you very much. Now, I hope you did have a good discussion, even if we didn't get to hear what you said, but I hope you had a good discussion. Let's just listen to one person from the online audience, because I do not want to forget them. What did they say, if they said anything?
Okay,
Anyone online?
Yes. So we have Dr. Anastasia Mpungu. If you're kind to someone, he or she will be kind to another, and the cycle continues.
That's a lovely way to cap it. If you're kind to someone, they will also likely be kind to someone else and pass it on. So as we finish, next slide. So kindness is really about stepping into someone else's shoe. It's about thinking about the other person. And if we can all get into that space of thinking about the other, then indeed, next slide, we are in the space where we are thinking about co-design. Because we are not just thinking about our needs and what we want, we are thinking about the other people and how we can help make their lives better. Now, if you put that together with all the many good things you already know, not just your training from your medical background, but also the training you have on how to help improve healthcare services, then you will have a win-win situation for everybody, because that kindness will be translated into reality. Thank you very much for your time.
Let's thank Dr. Bakusi. This has been marvelous. Thank you, Elizabeth. I'm going to ask if you and Dr. Lockman will join me on stage for just a couple minutes, because both of you have identified an important practice that we have to learn about as healthcare workers, and that's the practice of reflection. And reflection isn't about memorizing and knowing the right answer. It's about being able to take that time to understand and actually, I don't have a better word than reflect. So, Dr. Lockman, how did you get started with reflection?
Well, growing up in South Africa, you had to reflect every day on what was going on, quite simply. So when you're living in apartheid South Africa, and I grew up, I was fortunate. I lived in a family that was on the other side. But we used to go and reflect every day. So it was part of growing up. When I went to medical school and you went into the hospital, you had to reflect why it was different. So you had to reflect every day. And then when you went to clinical practice, I had to reflect every day for every person I saw.
Elizabeth, how about you?
Stories about why reflection has been an important part of my life. One was my mother. My mother had the fortune of being one of those people who has another child coming as she's breastfeeding one. So we were born in a staircase, 5, 4, 3, 2, 1 kind of thing. So she had a principle where if one had sinned, and all needed to be adequately compensated. One, either because you were the troublemaker, 2, because perhaps you were watching the troublemaker and not stopping them, or 3, where were you when the trouble was happening? But what she would always do is she would tell you, go and pick a stick or whatever that you thought fitted. We had a morning glory tree that grew in the part of the compound we lived in. Go and pick the size of stick that you thought was commensurate with the crime that you had committed, number 1, and please reflect on what you have done as you come back. So that was my first introduction to reflecting on my actions and my thoughts. The second person who taught me how to reflect was my teacher of the English language in primary class 4. In order to improve our writing, she asked us every day to write a sentence. And the sentence needed to be something that you reflected on about your day. And she was also my class teacher, so we couldn't get away from not reflecting. So from class 4, I learned or started journaling, so that every night I would write something about what I thought, even if my thoughts were, I don't like the teacher for making me write this every day. But it made me reflect and think back, and I think that's where my journey of reflection started.
So lots of us didn't have that exposure to reflection because both of you started in childhood. Elizabeth, how do you help healthcare workers who are all mature adults start to understand the benefit and the techniques that make reflection valuable?
I think starting with where you're at is a good one. In the sense that, as the philosophers say, a life that's not reflected on is a life that's not well lived. Because what we tend to do if we don't think about what we're doing is we repeat the same thing over and over and over again, and we get frustrated. And the psychiatrists say that if you really want to get mad, repeat the same thing over and over again and expect different results which won't happen. You'll get frustrated enough. So starting with where you're at, some people are good at reflecting by writing on paper. Some people are good at reflecting by actually typing. And now we have all these tools. These phones that have become part of your life that you never leave behind, or the day you leave it behind, you think you left your heart somewhere else. So some people are good at reflecting by putting in voice notes. Just taking 3 minutes at the end of your day, every day, to say, I will pause, I will think, I will write or text or speak something, is a very good way to start. It doesn't need to be more than 3 minutes. If you find it useful, you will find you yourself increase the time that you do it. But just commitment to 3 minutes every day, I find makes a world of difference for people.
What a great idea of starting small. I'd like to ask for the slide to come up because, Peter, you've really done a lot to help train healthcare workers in reflective practice. And I've learned from you that structuring it can have real benefit. And so perhaps you could comment a little on the Gibbs and the Rolfe structure for reflective practice, because in just a very few moments, you are going to be having a chance to practice in real-time reflection.
So the starting small is a really good idea, but to make it sustainable, you need to put structure in the process. And so I was really surprised that we train doctors and nurses, but we don't train them in how to reflect constructively. And as I say, what Elizabeth was saying is you have to develop the habit. Just like you wake up in the morning and you brush your teeth and they say for 2 minutes, you have to have the habit every day, and soon before you know it, you've got that habit and you're doing it. So we want you to get the habit of reflection. And there are many different tools, and I find these two are very good. The one deals with some feelings. How did I feel about it? They both deal with your feelings. And the Gibbs asks you specific questions, and you can see the 6 specific questions on the Gibbs cycle. It may take, things may take a bit longer, but it's good for circumstances where you, in a circumstance, and you want to know how you felt and what you did about it and how you need to change. The easier one, but actually it's quite difficult too, is just the 3 simple questions, which we're going to ask you to do right now, because you ask, what happened? Simple question. What happened when Elizabeth offered you a book if you stood up? Suddenly what happened is the Ubuntu went out the room and you all became very competitive. And other passions. That's what happened. I was watching that. So suddenly people were, they were like ready to move, huh? And so what happened? And then you ask the question, well, why did that happen? So what? And the next question is, now what? Okay. So I teach young doctors who become consultants. The course has just ended, and the last one I've done, who they've been on there, now they're becoming cardiologists, nephrologists, etc. I start on day 1 of the course and teach them this reflective practice, so that they can, and I say you can use either one of the 2 models, the 6 questions or 3 questions, depending which, and I don't tell them which to use. I said, look, it depends on the circumstances, what happened, and then I will reflect back to them of their reflections. And usually I'm surprised, because once they've got the hang of it, they say to me, this is the best thing of the whole course, because I'm suddenly understanding what it is to be a consultant. So there are 2 things as doctors and nurses we reflect on. One is our interaction with the people we call patients, how we interact with them. So I told you earlier, the wow factor. So I was going through the what, now what, so what. When I did that, I'd say, what happened in the clinic? What do I need to change? Why did it happen that way? And what do I need to change for the next clinic? Now, Maureen's sitting there. It's a PDSA, isn't that? The same thing as a PDSA is that what happened? So what? Now what? That's PDSA. So it's improvement in the reflection straight away. I also was surprised that improvers don't reflect. So I got an idea that quality improvers need to do this after every time they do a quality improvement session, use either one of the models. The Gibbs session allows you to go a little deeper because it's got a bit more about the feelings. What about feelings? How did I feel about it? It asks you more direct questions. So I say you need to use both for different circumstances. But what happens is that you get liberated from the subconscious, which becomes the conscious. So it's what we call tacit knowledge. Under the iceberg, suddenly becomes conscious.
It becomes known.
It becomes known. Your tacit, what's underneath, suddenly becomes known. And once it becomes known, you can fix it. So for example, if you're in a clinical team, so one of my jobs as a pediatrician, can I just give a story? And she asked me why me tell stories, and I'll tell another story. And I've told you the story. They send me a parent group that have very difficult. I used to get the difficult parents. I said, no parent's difficult, you just haven't understood their problem. There's nothing like difficult parents, they're just there for their children. Here's a pediatrician, she knows. I said, what you've got to do is work out what's underneath. And this was a child from a very religious family where epilepsy was a no-no. It was a sign of the devil. And they couldn't speak to anyone about it because there's something wrong. It was one of 7 children. So she already had, the child already had nieces and nephews because the child was 6 and the eldest one was 25. So they had children, so the nieces and nephews, but this one was having fits. And I couldn't work out what the problem was. So I worked with them and I got them to take the medication, I got them in, and then finally one day, as they were leaving, the mother turned to me and said, Doctor, will she ever get married? So what do I say? Because you think the likelihood of the severe epilepsy is no. So I had to be kind of, I'd say, you gave a biblical Solomonic judgment. I said, well, you first have to find a husband before you can get married. So it's neither yes or no, because for every child that's the same. And that took a weight off the mother. A simple question saying, well, it's not something you should worry about. And that was taken to tacit. And when I reflected afterwards what I had done, I realized that as doctors, particularly in the clinic I had with these difficult patients, not so-called difficult, I was the valence, absorbing all their difficulty and lightening their load to get on with their difficult lives. Because they weren't difficult patients or parents, they were parents who had difficult lives.
And parents who have difficult lives, patients who have difficult lives, they come to us. And so now we need to start, I'm going to give you an opportunity to practice some things you've been learning about from Drs. Bokusi and Lachman. I'm going to give everybody 10 minutes to reflect. Time to reflect a little more deeply on that question Elizabeth posed. How does kindness link to quality? I don't want you to talk at your table. I don't want you to pay attention to your background online. I want you to quiet yourself, focus, and reflect. I'm going to time the 10 minutes. Then I'm going to ask for you to write in on the chat box what you're learning if you're online and to share at your tables. It starts now.
Oh, then let's leave the model up.
Please leave.
Yeah.
Please leave that slide up. Thank you.
And it's also important, it's about learning about yourself.
Line, we've opened the breakout rooms so that you can participate as well in small groups of about 4 or 5. So you will have the same experiences we have. Please just join the breakout rooms. There should be a message on your screen.
For those people who are not reflecting, I'm going to encourage you to reflect on why you're not reflecting.
kodwa uthanda bani. Yebo, yebo, ngiyasifela, fela. Yebo, yebo, ngiyasifela, fela. Yebo, yebo, ngiyasifela, fela. Yebo, oh, yebo, ngiyasifela. Ngoba uthando luhle nana, uthando luhle mama sothu. Thanda lo bese kuvela loya kanti babe uthanda bani. Ngaphambi kokuthi ulale sound, phambi kokuthi ubeke ikhanda lakho phansi, ngimina ngihlele kodwa uthanda bani. Ngoba uthando luhle nana, uthando luhle mama sothu. Thanda lo bese kuvela loya kanti babe uthanda bani. Ngaphambi kokuthi ulale sound, phambi kokuthi ubeke ikhanda lakho phansi, ngimina ngihlele kodwa uthanda bani. Yebo. Uyangithanda nami ngiyangithanda, wasilwela imali kina. Ayoyo ngiyakuthanda, ngithi sithanda, wathanda bani. Ayoyo ngiyakuthanda, if uyangithanda nami ngiyangithanda, wasilwela imali kina. Asilwela imali. Ayoyo ngiyakuthanda, ngithi sithanda, my love, love. Ewe nakoranda, unohami na my love, love. Ewe na na, if uyangithanda nami ngiyangithanda, wasilwela imali kina. Asilwela imali. Ayoyo ngiyakuthanda, ngithi sithanda, my love, love. Ewe nakoranda, unohami na my love, love. Ewe na na, if uyangithanda nami ngiyangithanda, wasilwela imali kina. Asilwela imali. Ayoyo ngiyakuthanda, ngithi sithanda. Ta-da, oh, ta-da-do, ta-da-do, go-ba-go-bee. Ta-da-do-do, oh, ta-da-da-da-da-lo, ta-da-da-da-da-lo.
Okay. Now, I want you to share at your tables. You will have 5 minutes. If you're online, I want you to share with the online community. Share your insights from reflection.
Amahlo umuntu wami
Okay, we want to start with sharing a reflection, an aha moment, an insight from our online community. So let's start there, and then we'll hear something that was an insight from the reflection. Museo, are you able to give from our online community, or I'll come back to that with the online community. So let's hear just quick popcorn, something that you gleaned from this reflective practice. Your name?
Beatrice, I'm Beatrice from Kenya. From reflective about kindness, I found out that when you reflect, you actually reduce medical errors, because you reflect and see what happened, why did it happen, so what, and then now you act on it.
What did you learn in your reflection today?
I've learned that it is good to give yourself some time after. You can decide either in the morning or in the evening, but I think most of the time in the evening is better, because after a whole day, then you can sit down and keep quiet and just think about how the day went.
Okay. What did you learn today in your reflection? Give us your name and your moment.
Okay, I'm Chris from Kenya. What I looked at was I used the ROVS model to look at what is the status of the gap that we have identified at the workplace, and then also look at the so what. How do we foster, or what do we come up with to bridge that gap, and then now what steps are you going to take to actually improve on that?
That's what I want to know what you learned today in your reflection.
Kindness, from the talks today, kindness is not one point in the continuum of care, but is a continuous throughout the spectrum of care.
Thank you. Let me look for someone else. What Let me switch mics. Okay, here we're going. What did you learn?
I'm Salome from Mombasa. What I've learned is kindness is not just a one-man show. And when you are showing some act of kindness, you should not expect something in return.
Thank you, Muse. Can you get from the online community? I can't quite read that, but I see. Let me see if I can read one of these from our online community. If you are kind, the person in front of you will come up, will open up. Your calmness, smile, and positive thinking and approaches put him in the open. If it's the health problem, he or she will open their self during the interrogation and physical exam. It's great. And another one on kindness improves the quality of care by increasing patients' absence to treatment, adherence to treatment regime, and instructions. Kindness in itself is a love for humanity and continuing with God's work. Thanks to our online community, I'm going to get one more reflection here on what did you learn in your reflective practice?
More on kindness, that I need to be courage to be kind.
I like that. I need to be carried to be kind. I want to thank all those who responded. You know, I didn't exactly pick them at random. These were all people that were part of the ongoing last 16-week cohort from the C-suite leadership. And we had the opportunity to practice what we're talking about with reflection. And so I hope you're encouraged to see how reflection is a way that we can really learn, not just digest information. And we hope it's something that you'll continue in your ongoing work, because until we unpack what the link is between kindness and quality, we'll be working against all our best options, okay? We can make it easy to do the right thing, and reflection is a tool for that. So with that, I want to close. Our online audience will be rejoining us at 2 o'clock for our session on artificial intelligence and how it functions with us in the quality space. And we'll let you who are here in the room go for lunch. Thanks so much. It's been a great morning. Thanks to our speakers, Dr. Lockman, Dr. Bakusi, and our planning committee.
And those who were here last year know that if you stay till the end of the day, you get some goodies. So looking forward to a lovely afternoon. Enjoy your lunch.
set of speakers, and I'm going to call them up in order. I am taking over the moderator role today for Mike Malongo. And first I want to invite Dr. Rob Coram to the podium. Rob's going to talk a little about the global perspective. I had the privilege of knowing Rob and his wife and his family. He's an internal medicine doctor. He's been the one who introduced me to AI principles. And so with that, I present you one of my teachers and one of his least helpful, least active and adept pupils. Rob, go ahead.
Thank you, thank you. Should I use this one? This one? This one. Good. Hi, everyone. It's so great to be here. Thank you so much for being here and being engaged in this topic. It's one that I feel really passionate about. And my role today is to sort of give a bit of an overview of the generative AI landscape in healthcare. So I'm not really going to talk much about what Penda's doing or even necessarily focus only on Kenya, but take a little bit more of a global view and a global perspective on what's going on. Now let's see if this clicker works. Oh, that worked for a second. There we go. All right. So the first question I want to ask is, like, why now? What's happening in this moment that's making AI in healthcare like such a big hype moment? And I don't know, can we make that screen a bit bigger so we can see? On the left, what you're seeing is the state-of-the-art model performance on a benchmark called MedQA, which is drawn from US medical licensing examination questions. And you can see that just over the last 2-3 years, the performance of these models on those tests has approached very extremely strong levels. So I did well on my USMLE exam, but that's better than what I did, and that's what the best models are now doing. On the right side, we're seeing that little red plus sign in the bottom. That's human physicians. All of those others are how models are performing on very challenging cases. This is from a recent paper just released 2 weeks ago from Microsoft AI's health team. And it really just shows how the performance of these models is just greatly exceeding even pretty experienced expert physicians at diagnostic tasks. And so overall, large language models have really hit a breakthrough over the last couple of years where the performance is just really very strong, and now we're able to start thinking about how it could be applied in healthcare. I want to talk through really 3 main categories of AI that we might start thinking about integrating into our health systems. So first we'll talk about admin and back office. And here we could think of ambient scribes, which I'll talk a little bit more about, claim adjudication, stock management, appointment scheduling. Then we go into the clinician-facing tools, and the most important of those is the clinical decision support tools. And my colleague, Dr. Sarah Kiptanis from Penda, is going to be saying more about what we have going on in that area. But we also have tools that can summarize patient histories and then, of course, do image analysis. And the 2 most important features there are in radiology and pathology. Finally, there's patient-facing tools. So those are tools that patients can use to talk directly to some type of AI tool. Maybe it's for medical advice, maybe it's for a second opinion, and maybe it's to access health education. I want to start by talking about ambient scribes because one of the interesting facts about these tools is that they're set to be the fastest ever adopted technology in healthcare. What is an ambient scribe? Imagine you're having a chat with your doctor like in this picture, and instead of your doctor sitting in front of the computer and tapping away your whole history and physical exam, instead there's a microphone sitting silently and listening. And what that is doing is it's first transcribing your conversation, and then it's turning that into a medical note. So that's what an ambient scribe is for clinicians. So these tools kind of span clinician-facing and administrative. I put them in the administrative bucket because it's something that isn't necessarily making a clinical decision, but it's just helping a clinician work more efficiently. So there's a couple of challenges with this, especially in our setting. So number one, we have what they call long tail languages. So we're not just working in English or Spanish or Mandarin, where a lot of these tools have been tested and really, really well developed. And we also have code switching, which means we don't just have a doctor speaking in English and a patient speaking in English. In a typical consultation room, you may hear multiple languages, easily intermixed, right? I think anyone in this room probably has seen that in our setting. And that's where these tools right now are breaking. And we know that because we've also piloted that at Penda, and they don't really work well enough yet in our setting to be useful. However, that's a technical problem that will probably be solved over the next 1 to 2 years. And so for me, this is a very exciting opportunity. We're going to hear also a bit later from someone with more of an ethics background who I think can also talk to us about what would it mean to get consent for that, and what are the privacy implications of having a microphone basically listening to this conversation. But I will say globally, this is already happening at an extraordinarily fast rate. I want to touch on a couple of other admin use cases. So one is is improving stock management using machine learning models. So being able to predict, what are going to be stock needs of particular drugs or other supplies in your clinic or hospital, and then proactively ordering those things in advance. That's something that we're starting to experiment with at Penda, and many other hospitals around the world are doing. The claim adjudication one is interesting, and we have 2 local examples here in Kenya. We have Mtiba, and then we also have Savannah Informatics, who are starting to pilot using large language models to be able to know, is this a claim that needs to be rejected? Is there a problem with it? Was everything that was done actually justified so that insurance ultimately will pay for it? In other markets, it's a little bit funny because we're starting to see the AI wars, where the insurance companies say, we've used AI to say that this shouldn't be submitted. And then the doctors have to get their AI to say, like, no, here's why it should have been done. And it's like this escalation of the AIs fighting with each other, the same fight that we've had with insurance companies for decades. So that's another area that we're seeing take off. And then you can also imagine using really customized appointment reminders using patient-friendly language. So for a long time, we've been able to do automated patient reminders. You don't need AI for that, but to really put it into a patient-friendly language so that that's taken up more is something that's new. Clinician-facing tools I'm not going to touch on very much because Sarah's going to talk about clinical decision support. The image analysis one is very interesting, and we're seeing a lot of that, especially in radiology. Radiology has been working on machine learning models to understand what's happening, whether it's an ultrasound, a chest x-ray, or a CT scan. That's been happening actually for years. And now it's getting to the point where it's actually very strong. We're starting to see handheld ultrasound devices, so Philips Lumify, Baby Checker, the Butterfly devices, all of those are starting to get to the point where even in the hands of a community health worker who could do those image scans for an antenatal care ultrasound, we might be able to get a very strong quality scan result using the AI analysis of that image. So that's another, I think, very exciting area. And last, I want to talk about patient-facing tools. In some ways, for me, it's the most exciting because I think it's just going to have such a huge impact on how people experience care. But patient-facing tools is like, right now people use Dr. Google. But what if Dr. Google was even a lot better? What if it knew a little bit more about your personal history and it could talk to you exactly in your language and the way you like to be talked to? And we don't necessarily need to wait for big regulatory decisions for that. And why is that the case? Well, we know a lot of people are already using this. All over the world, people are asking ChatGPT, what do I do with these symptoms? So that's kind of moving as fast as patients and the technology want it to. People are using it for second opinions. So I just went to my doctor, this is what they gave me. Does this seem right? People are putting that into ChatGPT and other tools to see if that's actually accurate for them. So they're already using it for second opinions. And then we can also talk about bespoke targeted health education. So us at Penda, we have a tool called Chat na Penda, which is you can chat with us on WhatsApp. We have an AI component for that. You may have heard of Jacaranda's Prompts program, which uses a MedLlama base, that's the Meta Facebook base model, which has been fine-tuned specifically for Swahili and is meant to be deployed for antenatal care programs here in Kenya. And then the WHO also released this, they called it the Sarah Avatar, which was sort of this, an image of someone that you could just talk to through natural voice, and she would respond on a huge variety of health topics. So that's my whirlwind tour of the top 3 areas where we're going to see these technologies coming in. And I just want to touch on risks and guardrails. So number 1, hallucinations and bias are still a problem in these models. Although it's getting better and better and better, it is still an issue, and localizability is also an issue. So whatever works maybe in Silicon Valley may not be appropriate for our healthcare system and even the way we talk about things here in Kenya. So we still need human in the loop. Regarding privacy and consent, I think there's some interesting questions about if you are deploying these tools in your healthcare system, to what extent do you need to disclose to the patient who's using them that an AI may be involved in this process? Do we need to do that for stock ordering? Do we need to do that for summarizing a lab result? I think those are questions that we need to answer as we begin deploying these tools. And then regarding regulation, this is still emerging. So all of our regulators, at least here in Kenya, are still trying to pull together what is the evidence on safety and efficacy of these tools. But also we understand that we really want to make improvements in the healthcare system as quickly as possible. So that's sort of a delicate balance that's going on. And just to end, I want to kind of inspire all of us that I think Africa can really lead in the AI-driven healthcare revolution. And I would challenge all of you who work in health systems to kind of think like, what's one probably low-cost AI tool that I could implement to help solve a workflow pain point in the next quarter? Really kind of give yourself that challenge of what can I do in the next 3 months to start figuring out how these tools can help me. This field is moving really fast, so I think collaboration is really important. Learn from each other, learn from us. I think we're very open to sharing insights. We need to keep advocating with our regulators and the ministries to maintain that very agile ability to experiment while also having strong protective oversight. And my final point is that we need to keep it human. So let's let AI really augment some of the trickiest parts of what we do, those very cognitively demanding tasks, but let's like really keep it human with patients. Thanks.
Thanks, Rob. Let's keep it human. That sounds a lot like what we were talking about in our last session about kindness. Keep it human. I want to ask Sarah and Peter to come on up. Peter Kariuki is a health economist and pharmacist. He's been doing some stuff in this space, and Dr. Sarah Kiptonis and I go way back. We spent a few long nights together in the pediatric ICU at Kajabi. And so I'm going to let them share their story, starting with Peter, of how they're using AI tools on the ground in real life.
Thanks very much. And thank you, Mary, for a very hefty introduction. My name is Peter Ngohio, and a researcher by background right now. Maybe just to show 1 or 2 slides only to help me structure my answer, but I won't take very long. I know there's a clicker somewhere. So I wouldn't try and repeat what Rob has taken us through, but I've, the way I conceptualize is that I found use in AI for applied analytics principally. But I also think that these tools are now helping us to get deeper insight on our data, because I'm really more fixing quantitative data sets at facility level and above. when doing things like cost analysis and so on and so forth. But I think the tools that are coming up now are going to be very useful to even give us not only deeper insight, but also to help us to sort of rapidly understand text-based data. And as you've heard about the transcribing processes and so on and so forth, I think we're getting to the point where it will be very easy and quick for you to do in-depth analysis. You know, you're faced with an 81 variable, 500,000 record data set, and you'll be able to do a complete review and cleaning and analysis in a very short while. An example is we are running a primary healthcare performance monitoring program together with Nakuru County and Trans Nzoia County. We had to do a baseline survey in February and produce findings in March, including qualitative data analysis. So we were lucky enough to be able to use an almost open source, open source tool to organize our qualitative workflow, including transcribing and initial coding. Of course, having to keep the human in the loop for sure to do quality checks and so on and so forth. But we were able to run an entire qualitative analysis and get really good in-depth insights in a very short period of time. Albeit it was pretty much descriptive analysis. We had another challenge recently. About 1 week ago, we were requested to do some bit of work on behalf of the EXA health community, taking data from 12 countries to try and understand the impact that the USG withdrawal and the global fund reductions are going to be having on their service delivery. And it's very easy to do this with support from analytics like Julia's AI, in our case, and so on and so forth. So what I think it's really helping us do, and helping me do particularly, is to make it easier to translate my thoughts in terms of the questions for analysis into the script and the data that requires to do the proper analytical aspects for data. Of course, we have to reduce on the issue about hallucinations and bias. What we tend to do most times is that you reduce, so you can change the temperature settings for your predictions for language models, but you can also focus on reinforcement learning, for instance. So there are other ways in which you can actually reduce the biases that exist. So this is just one example, actually two examples. One, this is my colleague, this is not me. I'm not going to take credit for this. And you probably know Dr. Samakech. Dr. Paul Mwaniki was doing some, for his PhD study at Cambridge Wellcome, was looking at how to read and understand chest x-rays for children based on the PARCH study, to try and see whether there's a way you can teach a convoluted neural network to classify and identify risks early enough based on clinical chest x-rays. It would be interesting to find out what we found in that process. This is an example of what I've just talked about right now that we did last week. I haven't gotten to the point of structuring it to be a flow of sorts, but the advantage I think that I see is that you can actually request using natural language for analytical, you can get the tools to translate natural language tasks to analytical codes, which you can then audit. And as you can see over there's a generation of scripts and codes based on your data that do cleaning and analysis based on requests that you've done, as long as you've sort of learned how to do proper prompt engineering. I think I'll stop there. Thanks.
Sarah, over to you. We'll hear from the perspective of clinicians.
Yes. Good afternoon, everyone. My name is Sarah Kitines. I am a family physician, which is a primary care specialist at Penda Health and the head of quality improvement and innovation at Penda. So I'll talk about, as my slides go up, I'll talk about our journey in clinical decision support.
Okay, hold on.
To just assume clinical decision support is literally that. We're creating a tool or a system that can help our clinicians in the facility, walk through that decision making when they're seeing patients. And over the last 10 years, Penda has adopted clinical decision support tools, and we started up with a simple rubber stamp for urine, like urinalysis, and you would have people our staff fill in the necessary notes there. Then we developed our electronic medical record in 2017, and when we did that, we included templates that would guide our clinicians through comprehensive clinical documentation. So you have a headache, remind them to ask the duration of the headache, ask for critical red flags so that we are capturing all the necessary information in the history and the examination. And then after that, in 2020, we introduced a rule-based clinical decision support. And what that means is that we had, again on our EMR, we basically inbuilt the clinical guidelines that we all have readily available in 200-page PDFs that I know you all reach out to when you need it. But we now integrated those guidelines into the EMR so that those guidelines are accessible to our patients during the point of care. Because many times when you diagnose meningitis, our clinicians, yes, time can remember what they're supposed to give, but maybe 10 hours into your shift, you're highly likely to make errors. And so we had guidelines introduced into our EMR where if someone clicks, for example, meningitis, a pop-up comes in to guide on the treatment. However, as much as that really helped and we had increased adherence to evidence-based guidelines, we went to about 90% guideline adherence, whereas the Kenyan average at the time in 2020 was about 40%. We saw a 50% increase in adherence to clinical guidelines. That was a very useful tool, but we found limitations in that it didn't guide to the diagnosis. So it made the assumption that the clinician reached the correct diagnosis and therefore advised on the treatment. And so when we looked into the opportunities that LLMs have in that they can run in the background and walk alongside the clinician during the clinical decision support system, Rob and I felt like this was going to be a game changer in terms of improving clinical care in our facility. So in 2013, we introduced AI as a clinical decision support tool. We call it AI Consult at Penda, and it basically guides our clinicians through, and I'll just talk through that a little bit more. So basically, we have customized prompts. Peter has mentioned prompt engineering. I learned a lot of what you were saying. The first time I heard about temperature, I was like, temperature? What? Temperature only exists in human beings. It doesn't exist in LLMs, but it does. So we engineered prompts for different key steps in the clinician journey. So when taking history and physical examination, AI is running in the background and just observing and sending de-identified data to the LLM and giving prompts only when necessary. Then also during investigations, that was another point that we felt our clinicians need support in order to make sure they make the right to support making right diagnoses. And then also a diagnostic accuracy where the LLM is prompted to review the comprehensive history, the physical exam, the results of the tests done, and then affirm or guide the clinician to the most diagnostically appropriate diagnosis, and then also the treatment. We have 3 different prompts. We have, and these are kind of like guards. So we have a red alert, which is an intrusive pop-up. So as it's working in the background, if there's anything that is clinically, that is a serious problem that needs immediate attention, we have a pop-up that comes to the clinician. Then we have a yellow, which is more of just continuous guidance for non-life-threatening issues that a clinician can choose to look at. And then the green is kind of a check mark to confirm that they're on the right track. And with all those words, let me show you a video, because that is the easiest way. So I know, Ron, we will be in sync here, because I'll probably ask you you can start playing, and then I'll tell you when to pause. So I'm going to take you through our full journey. This is our EMR, and a fake patient, Dr. KFP, who is a 35-year-old male, and I'm quickly writing his vitals. You'll see 38.7, he has a pulse rate of 137, his blood pressure is there, as you can see, 96 saturation, and then I'm going to add his chief complaints of a cough, and we have an option of saying 2 days and maybe not so severe, a medium cough. The moment I leave the chief vitals and chief complaints, pause there. Can you see that blue thing up there in the corner written AI consult? Yes, you can press play. Thank you. That shows that it's working. Then we get a yellow bell. Our clinicians have the choice of clicking the yellow bell, which says that the elevated pulse rate is a respiratory complaint. Just pause, because it'll finish before I finish. So the elevated pulse rate with a respiratory complaint, while other vitals are stable, the tachycardia warrants further assessment. So it's recreating a red flag on a tachycardia. And then it therefore asks, investigate the cause of the elevated pulse rate. You can press play now. And once they read, they can acknowledge. And so you have that in your back of your mind as you take this history, that this is not just a simple cough, this is someone with tachycardia as well. So I copy-pasted a typical history of someone with chest pain, no night sweats, and add an investigation. So here we'll add, you'll see how I went through those, a full blood count. And you can see, pause there. At that point, because I left the clinical notes bucket, again, it's going to give me feedback on my clinical documentation. Remember, anything that's a yellow bell is the clinician to choose to click on it. So it's just guidance that you're on the right track, but there are a few things that you could possibly improve on. And here it's just giving general feedback on ways to improve the clinical documentation. Press play. And what we tell our clinicians is that when it's yellow, all you have to do is consider what it's telling you, and you can make the necessary changes. For the purpose of this video, I did not go back to make those changes and proceeded to do a routine investigation. Here you'll see me look for full hemogram, and then I was like, is it a full blood count? So I did a full blood count for this patient. And you'll see, again, you have to leave just to show that you've actively exited and completed your investigations. You see it working. I get another yellow bell, and it basically says that the full blood count is reasonable initial investigation to do to rule out the infection and from other hematological causes, given the elevated pulse rate. But it's basically saying, consider doing, you can press play, consider doing a chest x-ray in addition, just because it's someone with cough and tachycardia. And so as a clinician, I would, again, think like, oh, maybe I was just thinking this was routine, I should consider a chest x-ray. For the purpose of this video, I did not again go back to add those changes, and I went straight to the diagnosis. And now, for the purpose of illustration, I'm giving a diagnosis of acute nasopharyngitis, viral. And you'll see again that it'll be running, and I didn't click on that, or I think I did, yes. And it's again corrects that reasoning around, you can just keep playing. just keep playing, around the diagnosis. It's saying it's plausible given the cough, but it does ask that because of the tachycardia, again, rethink this diagnosis, because again, this is the diagnostic reasoning part. Now, something we see a lot of the time, we, in this case, have said, let's call it acute nasopharyngitis viral, and the clinician decides to give amoxicillin, which is an antibiotic. And this is something we see a lot of the time. And as you see it running, you will now get a pop-up, because this is what we consider inappropriate care when you're giving an antibiotic in the case of a viral infection. And so it's actually asking me to take action to discontinue amoxicillin. You'll see, unlike other cases, it popped up. Thank you, Ron. It popped up and prevented me to continue with my workflow. I addressed it. So that was a video that I did for the purpose of showing you the journey. Yellow prompts are not always clicked on, but the red alert, which is where we see highest safety risk, is where there's a pop-up and it forces our clinicians to act on. And that's the demonstration of what we're doing. I could show you more of different ways where we get the green check mark, but time will not allow. So thank you.
Thanks, Sarah. It's fascinating to see how you can use this in the background to help check where a physician needs to rethink. I also want to call next Professor Stephen Mahudia to come and talk, because as much as we've talked about the potential, there are always some issues that are ethical in nature in how we treat our patients as persons and show them full respect. And so Professor Mahudia is a pediatrician. It's funny how many pediatricians show up in the QI space, isn't it? Professor and I did our bioethics training at the same institution, and it's a great pleasure to have you here. I know you've been interested in this space for a while. Go ahead.
Yeah, thank you very much, Dr. Adam, for that introduction, and also for my fellows in the panel who have spoken and have also help to inform us about some of the applications that are already in use in AI at a level that I would not have been able to appreciate. I'm coming to speak from a clinical as well as an ethical point of view. And again, I'm glad that Professor Bukusi was here and she talked to us about reflection. Now, as you all, or rather we would like to say that the ethics is about reflection, and reflection about what is right and what is wrong. So we are here on reflection again. So in ethics and AI, we reflect and say the decisions that we make, the actions that we do, are they right? And if they are right, why are they right? And if they are wrong, why are they wrong? So ethics is reflection. And so I'll briefly, in the short time that we have, I'll briefly just indicate some of the reflective areas that we need to look at when we are thinking about AI in healthcare, and particularly about quality improvement. May I have the next slide, please? Yes, so when we talk about ethical considerations in AI, that is areas where we need to reflect from an ethical point of view in AI, then these are the points that come into mind that are most significant. One is that of dignity of the patient. Dignity of the patient addresses the area of humanity of the patient. The patient, treating the patient as a human being, as a fellow human being, and not a thing, not something that AI is applying and has solutions to, but seeing the patient as a human being that has a history, that has a life, that has certain rights, and that are in need of care that you are giving. We have been, the issue about informed consent has been touched, and I'll talk briefly about that. And also the issues about bias and equity. And here we are talking about bias related to the data which informs the AI, or the data which is used to train the AI, or the data which the AI uses to make its decisions or does its processing. You have heard again about the issues about privacy and confidentiality, which are key issues in healthcare, and accountability and liability, which is a big issue that we need to address with AI. And in terms of dignity of patients, I would like just to narrate 2 or 3 areas which have already been addressed actually with the previous speakers on this panel. And one is that I work in the Nairobi Hospital. It's a big hospital, and one of the complaints that we have had from doctors at the Nairobi Hospital is that when they come into the ward to do their ward rounds, that is to see the patients who are admitted, that the nurses do not have time for them. And to do a ward round, as the clinicians here know, you need a nurse. You need to be with a nurse because you need the nurse to appraise you on about the patient, and in the end, you need the nurse so that you can give them the instructions on the ongoing care of the patient. So when a nurse is not accompanying a doctor, that's a big gap in the area of patient care. And why is that so? It is because the nurses are busy on their computer trying to fill in records, trying to fill in forms, trying to upload information because that is one of the tasks that they have to do. Now, on the other hand, also, we have reports, particularly in many countries, but the documented reports are particularly in the United States, where now from the point of view of patients, one of the main areas where they say that they have many complaints in terms when they assess patient satisfaction is the fact that the patients are saying that when they go to see their doctors, the doctors are so busy looking at the screens and not paying enough attention to themselves. From the speaker that was here, you can see that the solutions are coming to that. And the solutions are coming from AI. And the other example I would want to give again comes from doctors. Many doctors in Kenya and also even in the US currently, they say that a lot of their time they take up in making reports, making patient reports, uploading information into their computers, into the system, in the electronic record systems. And I say these examples because when the time of the nurse is taken up by this task, when the time of the doctor is taken up by this task, what suffers? What suffers is that the patient does not get enough time from the doctor. And this is, next slide, please. This is an important area in ethics because, and particularly about the ethics of care or care ethics. And care ethics emphasizes the value of people's relationship. The fact that healthcare is about people. You are taking care of people. People, it's a person taking care of another person. So there is an aspect of relationship. Respecting dignity of a person requires that you recognize that person, that you look at them, that you listen to them, that they feel that you are listening to them and that you are paying attention to them, and not your other activities like uploading records onto your computer. And so this ethics of care this ethics of care is now being supported by the fact that through artificial intelligence, we can offload the doctor and the nurses from much of the routine tasks that have been very ably explained by my colleagues, and I'll not go into that. So freeing the doctor's time It means that they can now pay attention to that aspect of care that AI cannot do well. AI cannot relate to a patient at the present time, maybe in future. But at the present time, AI cannot relate to a patient. And I think that even until into the far future, human beings will want to prefer to relate to human beings rather than non-humans. And so I give the example of this in terms of that AI in taking up many of the routine tasks, freeing the doctor and the nurses and the other clinical care personnel time. It gives them time now to be able to give patients more time and therefore fulfill the aspect of care ethics. Next slide, please. We have talked, it has been mentioned about informed consent. Informed consent, one, I would just mention about the value of AI in the informed consent process. As you all know, the informed consent process, one of the major areas is giving information to the patient so that they may understand about their illness, about their treatment, and about the consequences of treatment or no treatment, and therefore make an informed decision about giving consent either to treatment or refusing treatment or seeking treatment elsewhere. Now, AI, fortunately, has made communication easier. That information aspect of giving informed consent has been made easier by AI. Why? Because AI is able to, as we have been told, to speak to the patient in the language that they best understand. It will, now because of AI, we should not have a language problem. One of the issues about giving information in informed consent is that we should give it in the language that the patient best understands. And so this is something that in future will no longer be a problem. So we have, it will solve for us the language problem, and again, in terms of communication, it can produce graphics that can help us to explain about the complex issues of medicine. As you know, explaining about a person's illness, the source of the illness, the cause of the illness, all these medical things can be very complicated. But with AI, you will have the graphics, the means, all the means that can help you to give to explain better and to communicate the information better to the patient, including simulations of what, even surgery of what you are going to do, or in terms of illness, what it will do in future to you. These through simulations will be able to explain to the patients better. So the process of getting informed consent will actually be augmented by the use of AI. And now, briefly about bias and equity. As we have heard from my colleagues who understand AI better than I, we say that AI is just as good as the data in which it was based on. And at the present time, the data that the AI uses or that AI has been trained on may leave certain communities out. And therefore, they may make decisions decisions that may carry on that bias, and therefore they may not arrive at the right conclusion. One of the papers that I read gave an example of a triage system which a hospital in the US was using, and that triage system was to identify prioritization of patients for ICU beds, so that when you have limited ICU beds, who do you prioritize? As you know, and particularly this came out, we had this problem during the COVID-19 pandemic, when at times you would have more patients who require intensive care than the beds that you have. What criteria do you use to choose them? Of course, in ethics, we do have some criteria, but AI systems can do that for you. But if it is based on a criteria which is biased, then it may make wrong decisions. For example, this particular example, the AI was trained to indicate severity or to classify severity of illness depending on hospital visits, how many visits to the doctor, and how much money you have spent on healthcare, and other criteria, which if you are a person from a low socioeconomic category, you'd of course not visit hospitals often. Of course, you may find that you are not spending so much money on healthcare, and this system, therefore, in terms of prioritization, was prioritizing those who are wealthy, because the wealthy people tend to go for healthcare checks more often, even for minor illnesses, which poor people don't do. And also, they have a larger budget, and therefore they spend more on healthcare. So this was this biased patients from low socioeconomic areas in being prioritized for ICU beds, because according to that criteria, they would be categorized much lower. Now, so bias is a big problem. Next slide, please. But of great importance is privacy and confidentiality, as we have seen and was just shown by the presentation just before me. A lot of patient information is loaded into these systems. Okay, it's loaded onto these systems, and therefore, and this is medical information is highly sensitive. So privacy and confidentiality are key things in ethics. All of you who are healthcare professionals know that this is a key issue. Confidentiality is key. Now, when you put a lot of data onto systems that may be shared by other entities, by other systems, then there is a risk that there may be a breach on privacy and confidentiality. But so those are areas which are of great concern, because of the fact that sensitive patients' data go into systems which may be available to other systems, which and breach confidentiality. But most importantly is accountability. Who is next slide, please? Next is accountability. Who is responsible if something goes wrong because of the decisions, because you have acted on decisions or on guidance which was provided by AI, or equipment which is using AI does something that is faulty? Who is accountable? Is it the doctor who followed those instructions or used that AI? Is it the AI developer? Is it the AI, the one who manufactured? Where is the responsibility? In regular healthcare, a licensed healthcare professional is accountable for clinical decisions that they make. Now, if your clinical decisions were guided by AI, who will be responsible when something goes wrong? And that is something that we need to address, and it is an ethical issue. There must be very clear guidelines on the responsibility when we are using AI. So I would like to, the next slide please, I would like to conclude by saying that AI must support, not substitute, human relationships. And we say that this is positive because actually AI is freeing the doctor and the nurses and other healthcare professionals so that they have more time to relate and to do that which the AI cannot do. And healing, as we say, requires empathy and trust. And AI lacks moral intuition and will not be able to perform this. AI can reduce cognitive burdens, as we have seen and has been demonstrated by my colleagues. And we say that ethical perspectives and care must be taken into consideration and appropriately managed. When used within a robust safety and governance framework, generative AI can enhance quality of care. Without such a framework, it could pose new risks. And those, from an ethical point of view, it is good for us to think ahead and continue think about the risks which we may face in future. I would like to end my talk there, and we'll be having a panel discussion, so I expect that there may be many questions which we can then address. Thank you.
Professor, it's been interesting from the different ones who responded to see both the potential and the risks. And Professor, come take a seat. We want to include our online audience, and I'd love to start with questions for the panel from our online audience.
Yes.
So, Museo, why don't you start with those questions, and we'll take several from the online audience.
Okay, so we have one question from Florence. My question is the time spent with a patient with, okay, it's not a clear question, but it's the time spent with a patient with all those knowledge.
So the question's about, can I reinterpret that a little bit? Are these online AI tools helping time spent with patients? Sarah, let's hear from you.
Thank you. And that's a very good question and a valid question, a question Rob and I asked even before introducing AI Consult at Penda, and many of our clinicians are concerned about that. So we did actually evaluate, and it takes 2 minutes longer when we have our AI Consult in use versus without, just for the consultation time. Remember, the illustration, the video I gave was to really immerse you into every single step. So I was giving data to and opening every single window. We do not expect our clinicians to open every single yellow bell that pops up, only when they need to. As much as it takes 2 minutes longer, it's 2 minutes that can save a patient's life. It's 2 minutes that can improve the quality of care. And as a statement we say very frequently in Penda, is similar to what Prof. Mohodia has said, is that the AI tool now relieves the doctor of the burden of looking for that PDF document, which they actually do not look for because of time. And therefore allows them to address and be human and be present for the patient before them, so they can do that physical examination, they can address the symptoms of anxiety and concern, and so it's just 2 minutes longer, but 2 minutes that can save a life.
So Sarah, do your clinicians feel that way about it?
So which is now the perceived wait time.
Yes.
Yes. At the very, and you're probably going into the barriers on adoption of the tool. So at the very beginning, there was that concern for like, I feel it's taking longer. One of the key elements around the speed is also the infrastructure backing up the AI consult. So you need, it's not so much AI that's a problem, it is the infrastructure that you have in place. So do you have reliable internet connectivity? Do you have laptops that have good speeds that are able to support the API tool? So AI isn't a problem. And so as long as we made sure that backbone of infrastructure is in place, yes, our clinicians now felt like, okay, there are times it's taking longer, but we had to make it felt like it was taking longer. I feel like I have to get additional feedback, which I was not getting. There's this bell that never existed that now is screaming at me that feels I need to click. And so there was a perceived longer duration than the 2 minutes, but over time, now that we're in almost, gosh, it's a year and a half since adoption, the value that the tool offers, actually now most of our clinicians struggle to work without it. And so there was a perceived length, but the reality, it was just 2 minutes longer. And then there are other factors actually in terms of time that was even their typing speeds. So things around typing speed, how quickly can you engage? So there are other elements which I haven't gotten all into that.
Ready to activate AI across your enterprise now? MuleSoft
in the consultation room. Yeah.
Great. Can we have another question from our online audience?
Yes. So we have Clarice Ambale, and this question goes to Penda. How do you ensure all differential diagnoses are considered by the clinician using AI Consult?
Do you ensure all differential diagnoses
are considered by the clinician using AI Consult?
Right. I think even Prof. Mohodia mentioned it in his slide. Garbage in, garbage out. The AI tool is only as good as the information you give it. AI will not substitute your clinical acumen and wisdom. If in that history I just write cough, 2 days, no night sweats, and move along, the likelihood of making an error and AI not being able to support your diagnosis is a challenge. So when AI can best support is when you as a clinician do your role in doing the appropriate history. Yes, it can prompt you on further history. Do the appropriate thorough physical examination. Document that in real time. And then, therefore, the information that AI can give you in support can be more holistic in terms of the differentials. So AI is not responsible for giving you every single differential that is possible. You as a clinician are responsible to show up as a clinician and do what's necessary, and then AI Consult will prompt any additional diagnosis you've missed following what you've given it.
Good. Let's get one more comment from our online audience, and then we're going to take the mic out into this audience and get questions from the floor.
Okay. Comment or question?
Yes.
Question. So there is another question, also goes to Penda Hospital. Where is the data hosted? Is it within the confines of Penda HMIS, or does it go to an external service provider who is hosting the data for you? Hence,
was that the end of the question?
No. Hence the possibility of training the AI tool with data beyond your institutional confines. It goes on. What risk does this pose to the institution?
Yeah, these are great questions about data privacy, and I'll try to just a bit of the facts on how all of this works. So the data in our EHR is stored on Penda servers. So that is like locally and totally protected for us as Penda. When you think about what goes to the API, and our system is technically, it's large language model agnostic, meaning we could connect it to DeepSeek or Gemini or OpenAI, any of them would work. We happen to be using the OpenAI GPT-4o API right now. And what we send is only de-identified data. So if you think about your patient record, we have lots of identifiers. We have the name, and we have the insurance number, and the phone number, and all of this personal stuff. And then we have a bunch of de-identified things. So things like, this is a 30-year-old with cough for 2 days, whose white blood cell count is 10. The only thing that we're sending through the API is the de-identified data. And so, at least within Kenya, according to our Data Protection Act, that de-identified data can go to the OpenAI API, and that is traveling to the OpenAI servers to do that. Anything that goes through those servers is not allowed to be trained on through, according to the OpenAI terms and conditions. So that data is not used for training, even though it doesn't contain patient identifiers. I think that there's an interesting question about to what extent should we be actually pushing for some of this de-identified data to be part of that training data set so that these models are actually more inclusive. That's not something that we've done as yet at Penda, but I think that's like a discussion we'd like to be a part of.
Can you comment a little further, Rob, on low and middle income country access to be feeding data into these training models?
You mean to what extent the models have been fed with data from low middle income countries?
Yes.
I mean, I'm not from the big tech companies, so I think it's hard for me to like really comment on that in a detailed way. One thing I would say is that we have used the OpenAI models for our Chat na Penda service on WhatsApp. And if you feed into that something in Swahili or even Shang, you'd be surprised at how well it does, how well it handles it, how well it responds in a way that not only understands it, but is able to produce a very similar type of language. So I think we've been really impressed with where the models have reached. We've also been impressed from a clinical standpoint because, of course, we prompt the model to say, hey, we're in an urgent care setting in urban Kenya. What do we think about a child with fever? And of course, malaria needs to be part of that differential, even though that wouldn't necessarily be part of the differential in another place.
Okay, well that sounds pretty good. I'd love to hear questions from the floor, and I see hands rising all over. Let me make sure we get a microphone out to these people. I'm going to start in the middle of the room.
Thank you so much for the full discussion. My question, again, Dr. Sarah, in terms of what frameworks are you currently using to evaluate the appropriateness and clinical relevance of the CDSS recommendations?
Yeah, let me get a couple more
maybe
questions.
get a couple more than...
Thank you, Penda Health team on AI. Mine have three-pronged. One is, how does the use of AI influence the cost of the client? Two is, how have you maybe looked at getting a second opinion from a specialist so that it helps in the issue of clinical support, but also getting a second opinion from a more superior colleague? And finally is, I know Penda Health has several branches. Is the data being able to be accessed by the client in a different branch, not in the same branch as usually where the initial clinical encounter occurred? Thank you.
Thank you so much. Professor Stephen, what happens if the patient prefers the AI opinion to the clinician's opinion, or if they insist to know what AI say? Have you experienced that, or is it something that we should think about, and what can we do about that? Then Dr. Sarah, thank you so much. How does Penda support the system that you have with AI, support individual practitioners, or what I would probably call mobile health practitioners, health on the go? I don't know whether the system is institutional based or it could be used around for mobile practitioners. And does it have an option to upload institutional based guidelines or SOPs to the ones they base on, to the institution can generate their own guidelines so that the AI can consider them for clinical decision making? And then lastly,
2 is good. We're going to move to our panelists to get those responses, then we'll collect some more. Go ahead.
Sorry, Peter started sneaking questions as well. Thank you for the questions. And yeah, let me start. So the first question I have is, have we built any frameworks to just support CDSS accuracy? And I think my response can also cover some of the other questions, even around second opinions and referrals. So with AI, we have prompt engineering. So one of the things at the back end, we did not just plug our clinical de-identified notes to the open source AI system and see what happens. You have to prompt engineer and tell the AI the context that it's working in, who it's serving, and therefore mold that prompt to what suits now Penda. So in our setting, it literally sounds like you are a consultant guiding clinical officers in Nairobi, Kenya, in the low to middle income setting. So it's that setting first. And then now and now we set the limitations of what can be accessed at primary healthcare. So things around even referrals and what level of investigations we have accessible are all built in that. And then now we can include certain specific guidelines. Once you have that prompt engineering, you do get feedback on just, because most of our guidelines are WHO based, so it's very clear. But as we continued to evaluate and check, because that's something that's very key, we did not just have AI go, we had to keep evaluating the prompts and testing even before we went live. We noticed that there's some small nuances that we had to add into the prompt around HIV treatment, around malaria being a key thing in our society. IMNCI guidelines is one of those that's not as clear, and we had to add more data around that. So those are the frameworks that we've included, and so I think that also addresses the element of, so can you add your SOPs when do you do a second opinion? Because of those limitations, we have made it clear when referrals happen. So we do not have AI advising our clinicians to start doing CT scans, for example, because we do not have a CT scan, but recommending referral for CT scan or referral to an ophthalmologist. And so that addresses that first question. In terms of cost, you can, I think Rob will take the cost question. Can data be accessed across all Penda MCs? That's actually not an AI question, that's just our EMR. Our EMR is a single EMR that across all 16 medical centers. So if you start in Penda Medical Center, Githurai 45, and you end up going to Penda Zimmerman, all your data is there. If you end up calling Chatna Penda, which is our call center, they'll still be able to access your data. Is the AI CDSS able to support mobile practitioners? So we built this AI consult solution to support our institution, our in-facility care. AI can support, you can do mobile-based, but we do not have community health workers or mobile practitioners working at Penda Health. And yeah, I think that is, yes.
Who wants to go to business school? We ready to go to healthcare business school today? I'll take you there. In a typical Penda visit, a patient pays 1,000 shillings. That's about $10 for those of you who are not from Kenya. So where does that 1,000 shillings go? About 200 of it, or 20%, goes to profit, because we're a for-profit company, we need to make a profit. About 300 shillings, or 30%, pays for the drugs and the lab. Another 30%, 300 shillings, pays the staff. 150 shillings, or about 15%, buys toilet paper, pays electricity, pays the rent, the cleaning of that facility, etc. 30 shillings goes to our EMR, okay? So the EMR is like not totally insignificant on a per patient visit level. The AI component adds about 3 to 5 shillings per patient visit. So that's about 0.3 to 0.5% of the total spend per visit. So it's not nothing. It's not nothing. When you add that up over 1,000 patients a day or more, it is a big cost every month. But the way we view it is, if you're paying us 1,000 shillings and we give you the wrong diagnosis and therefore the wrong treatment, it's like we're completely wasting your money, right? And so if we can spend 5 shillings per patient to make sure that you're getting the right tests and the right treatment for you, that's a really good use of your money, and it helps us build that long-term trust with patients, because ultimately what you want is to get better. And on the big picture of things, it's just not that much of a cost compared to all the other costs that it takes to run a facility.
There's a question for Professor Mahudia.
Yeah, thank you. And the question was that what do you do when a patient insists on the advice of the AI if it's different from the advice that the doctor is giving? Well, I think that even without AI in traditional healthcare, the doctor has the responsibility to make the decision on what he undertakes. However, decisions are shared with the patient. So there is shared decision making. The patient requires the treatment or the care. The doctor has the knowledge, but the patient also knows a lot about their illness and about their preferences and about their values. So the shared decision making takes into account what the opinion and the values and the desires of the patient. And so if that desire is related to the advice from the AI, then the doctor needs to take that into account. However, the doctor is responsible for the final decision or the final advice that he gives, whether it is following what the patient wants or following what the AI has advised. He takes final responsibility. So if the doctor feels that that advice or that course of action is wrong according to his knowledge, according to his training, and according to any research and consultations he may have made, he should not agree with that, but he should inform the patient that I've listened to you, this is in need, but I'm not able to proceed on with that care that you have suggested. So it is a shared decision making, but the doctor will, in the final action, he takes responsibility. So if I do, as a pediatrician, if I make a decision and give treatment that in my opinion I know is wrong, I do not agree with, but because the patient demands it, or because I've got that advice from an AI system, if something goes wrong, if there are complications, if the patient gets worse, I'm still answerable. And so while taking into account shared decision making, and the doctor must take into consideration the patient's desires, the patient and the information that the patient has. Currently, we have patients who will come with a diagnosis. They have done their research. They have consulted Dr. Google and other sources and other doctors. You take all that into consideration in making the decision. Thank you.
Thank you very much. I want to turn to our online community next. Museo, can you share several questions from the online group?
Hello, yeah, right. So in this age of AI, how safe are healthcare workers against cyber attacks? That's the first question. I think any panelist can take that. And then we also have another question. Is there a likelihood that the use of AI can create a dependency that tends to weaken the individual's ability to make clinical judgments without depending on the tool?
Let's start with how safe is our data?
Right. Well, I would say that it's not necessarily the AI that's causing one to be unsafe. I mean, it's practice in terms of use of resources on the internet, right? And unless we're talking about the increased use of internet resources or something like that, but I don't see exactly how one can peg issues around cyberbullying, etc., on AI, particularly because there are quite strict frameworks right now in development of AI tools, such that there are safeguards around how responses are generated or are constituted by AI algorithms. There's been some safeguards put in place. I think the older models, way long time ago, would probably have been susceptible to responding in probably vulgar language, etc. But I think that's something that has been very well curtailed in the past. There's a reduced chance, I would say. It's quite reduced. There's a higher likelihood of getting bullied on social media, I would assume. With regards to dependence, I think there's been some studies done around. Well, there's one paper I came across that was talking about mental function on exposure to I think ChatGPT or something like that. But I still would say that it really depends on the mode for which one is using these tools. There may be positives and negatives. I tend to see a lot of improvement in productivity, especially if you think of using these tools as tools, not as the master of your activity, but using these as tools to enhance your productivity. I think I would say that you could use certain medicines to allow you to work better, or you could use certain medicines to result in you working much less productive as you are, or like a bit more impaired. So I think it's all about, I don't know whether it's, is it the person or is it the tool that needs to be sort of shepherded? I'm not very sure, but that's a question that I would pose for the ethicists. Thanks.
Professor, go ahead if he's posing a question to the ethicist.
Yes, I think there was a question about dependency, that will these systems make us dependent on the system so that the doctors are no longer able to make decisions. I think as systems evolve and as these tools get tools to make our work easier, because in terms of the professionals continue to work, they also continue to adjust and to see how to work in the new systems. Many tools have come during our times. At the present time, many of us have mobile phones. A number of us here lived at the time when the mobile phones were there, and you could remember how you kept your phone numbers. Many of them, I could remember maybe even up to numbers off my head or more, and or I would write them down somewhere. Now I probably know, in off head, I may only know maybe 4 numbers, which are very essential to myself. Now the fact that I'm now dependent on my mobile phone or other systems to get phone numbers, has that made me less efficient? No, I have adjusted to that. I know how I will when I do not have the phone and I need the phone number. So people adjust, and I expect that as we move forward, the doctors, the healthcare professionals will be freed from certain routine tasks. as we said now, a doctor spends a lot of time writing reports, and that is going to be taken over by AI. It will free us to concentrate on the things that are most important for us to do. So the dependency, yes, but we'll also have system. You also develop systems on how to overcome that dependency, how to manage when you do not have them. And in terms of tools that we are having, there is always that question. Currently, it is said that the students that are now growing computers and keyboards, will they know how to write? If you give them a pen and paper, will they know how to write to write a message? And that is something that the learners have to find out how to overcome that. So it is a continuing, growing, learning on how to manage as professionals as you go ahead. So I know that there is that risk. That is a risk. But that is why, from an ethical point of view or from a risk point of view, you look at a system and you say, what are the risks? And you manage that risk. And one of that risk is that that of dependency, but there will be solutions to how to overcome that aspect of dependency on the tool that has been created. Thank you.
You know, it's been so interesting both hearing from our panelists and hearing the questions from our online and live audience. I think that the opportunities as well as some of the potential risks have been well identified today. And I want to say that AI is here to stay. It is not going to go away. And our challenge as healthcare practitioners, wherever we're interfacing with AI, is how do we use the tools to make healthcare kinder and co-produced? And that's what we've been here these last 2 days to work on. So give a great round of applause to our panelists. And we're going to ask, you can step down, and we're going to ask everybody in the audience to stand up. It's a chance to have a little stretch. Try a couple of your dance moves, okay? There you go. Okay, come on, guys. Let's get a little going. And some of you should be dancing up to the front.
Odwar, please come. Center. We are now transitioning to session 7.
It's good afternoon. Good afternoon. Thank you, Rob and Penda Health, for that wonderful session, and Dr. Mary Adams, Professor Stephen. Thank you. I think we are getting to the gist of the matter. So I'm just looking at us to settle so that we can get to the next and final session. Okay, so for this session, the two of us, and we are going to introduce our colleague who are going to Tekas, who's been part and parcel of this team. So my name is Oduro Tieno. Yes, I am a clinician. I live and work in Kenya, based in Kisumu, as a patient safety advisor, patient safety and quality improvement advisor at Systems Evaluation. Systems Evaluation is a healthcare business consulting firm. And I also serve the Kenyan private sector as the Vice Chair, Health Regulations, Quality and Standards Committee, where we sit with the wonderful team from Penda Health, yes, and the other members that we have here. And this year, I got the wonderful privilege to be part of the organizing committee for this wonderful leadership conference for the organization, courtesy of Acquire and the entire mass of quality improvers that we have within the country. Okay, I'll hand it over to my colleague, who we are going to run the session with here physically.
Good afternoon, colleagues. Dr. Tenza here. I'm very excited to be in Kenya for the second time and working with the Acquire team. Colleagues, my name is Dr. Tenza. You can see on the screen, I'm a senior lecturer and a patient safety and quality researcher from Northwest University. We're going to be handling a session on scientific posters where we showcase the work of the frontliners. We all know what's the agenda of Acquire. The big priority in Acquire is empowering the frontline healthcare providers. And today in this session, you're going to be hearing all that has been done by our frontliners. Odo is going to introduce, highlight an introduction about our co-facilitator who's not here today, Dr. Elom Ochi.
Yes, so we did have a part of us who is joining us virtually, Dr. Elom Ochi. He's a senior technical advisor at the African Institute of Quality Improvement, Quality and Safety within the African region. He's a FISQA fellow member and a lot of quality improvement and patient safety work for the WHO, ISQA within the African region and globally. So,
at this stage, colleagues, can we have all the first 7 of our presenters for posters?
Yes. So that is Dr. Elom. He's been part of us and enabled us to put this wonderful session. So as Dr. Tenza said, what we are doing with this session basically, we are showcasing the evidence of the impact of the quality improvement work. And for that evidence, basically, to build the learning system for the African region, we need to show some evidence, basically, also to get that buy-in from the organizations. So during this year's leadership conference, we sent out invitations for posters, and we were glad that we had response across Africa, Nigeria, Malawi, Cameroon, and Kenya, a total of 26 posters. So out of the 26 posters, we are going to have, we have 14 of us here present. We are going to share the stories, just in passing, in glance, and that is the posters that we had. So all these posters were spread across the themes of the session, of this year's Leadership Forum. We had 9 posters around patient safety. We had posters around 7 posters around co-production. We had posters around leadership, leadership for QI. So it was a wonderful mix of work that is going on across the continent. And that is what we are going to showcase. So I'll invite the first 7, and I'll invite the first 7. We've got Onalai from Nigeria. Kindly, sir, step up. And then we've got Newton from Nigeria also. Kindly step up. And we have Stephen Kizito from Lamu County Referral Hospital, Kenya. Kindly start. Joel Musyoki, Life Care Hospital. Joel Musyoki from Kenya, Joel Mumo. We've got Winnie Wambui Karuga from Mwai Kibaki from Nyeri. Cynthia Njeri Ikwa. Agwins Chagwira. Is Caroline Kindi. Esther Sankale. So we'll take this first and then so what Ron and the team are going to show us. Who is the first? So what we are going to have, we are going to run through the posters in that manner, and the authors are just going to tell us the why. We can see the what over there. So they just tell us, introducing their name and the why behind the work there. Yes.
All right. Good afternoon, everyone. Good afternoon, everyone. Onole from Lagos, Nigeria. Okay. We did the study on patient waiting time in the cardiology clinic. We did this because we noticed that our patients were spending several hours to access healthcare in the clinic. Eventually, we realized that on the average, we were spending about 4 hours. And we decided to work on reducing this by 25%. We achieved a 15% reduction in the waiting time over a period of a couple of weeks, and we plan to sustain this reduction and make it better through training, monitoring, and further engagement of stakeholders. Thank you.
Pass it to the Newton.
All right, good afternoon. I'm Newton from Nigeria. We walked around strengthening adherence to management protocol in pre-eclampsia and eclampsia management at Federal Medical Center, Ekpe in Nigeria. It is a work that is done in relation to a bigger project that was done around reducing maternal mortality and obstetric complication by 20% by about 4 consortium of partners. So our facility was one of the facility that was considered. So we worked on strengthening adherence to management protocol of pre-eclampsia and eclampsia. A baseline study was done as at the beginning of the study, we discovered adherence was around 55%, and we made use of a quality improvement model for improvement and came up looking at root causes, came up with significant change ideas that drastically impact on adherence, and by the end of the study period, which was for about 9 months, between the period of March to December 2024, there was significant improvement in adherence to management protocol of pre-eclampsia and eclampsia. Thank you.
Thank you so much. So, Kizito, just tell us, why was this important for the team that you know, for Kizito? As you can, just tell us, why was this particular project, intervention, was important? So as you introduce yourself and the why.
Good afternoon, everyone. My name is Steven Orondo Kizito. So I did a survey on patient-centeredness care, that is to assess their satisfaction levels and the experience across our outpatient, inpatient, and maternity settings. And this was to assess basically our objective, or my objective, was to know our strengths and also to know the service gaps that we are dealing with, and to have informed quality improvement initiatives. So we had this discussion with our former director, and we had some advocacy on patient-centeredness, and we did some CMEs, and the questionnaires that we did were structured based on the patient-centered. They were all around the patient-centeredness. So if you go through our questionnaires, some of the questions that we had were revolving about dignity, privacy, coordinated care. We had about effective communication, whereby we asked the patients how they were communicating with especially the doctors and the nurses. That is based on the inpatient. And again, we had an informed consent. We are asking the patients whether the doctors or the healthcare workers were getting their were asking for their consent before any procedure could have been done. So even from the feedback that we received, from the recommendation, you can see we had issues to do with abuse. And what we've done since we did this survey, we've initiated some posters that is based around on the patient.
That is sufficient. Yes. So you can pass it to the.
Thank you.
Can pass it to. Okay, you've got a mic. Just say we seeing your work here, the what you did, basically just the why. Why was it significant or important for the team at the facility of the health organization at the front line? Kindly, sir.
Yes. Okay, so my name is Joel Momo. I'm part of the QI team from Life Care Hospital. So as you can see, a 5-step root cause analysis model for test overutilization. It's the second of its kind. The first time it was applied in a medical facility in Thailand, but some of the members came to our hospital and we decided, why don't we just try it? So plasma transferrin for the MDs, the nurses, the doctors in the room, it's a test. Plasma transferrin, it had become like a vital sign as we saw at the continuum of the tests that were being ordered by the doctors and the nurses to be performed to the patients. So plasma transferrin came at the top alongside transferrin saturation, TIBD, UI, and some other tests, serum iron, serum ferritin. So why these tests? Why were we doing these tests? Yet we are still measuring plasma transferrin saturation. We are still measuring serum iron, serum ferritin. So we found out that our clinicians had insufficient knowledge based on the differences between either plasma transferrin or plasma transferrin saturation. And among others, what we did after that, we had posters, we had like lectures in the middle they didn't understand totally, apart from the knowledge they had gained at school, what's them ordering plasma transferrin for the patients. It's mainly on the knowledge they had heard either the doctor, their fellow doctor, or their fellow nurse speak about. So that's why we put posters at the nurses' lounge and the doctors' lounge for them maybe to understand the differences of the very many tests that you should order to a patient, because the financial implications were directed towards the patient and also towards us. And we wanted everybody to you be safe and also we be safe. And also part of the reviews we got from our patient is that there's this test that's taking around 3 days or 5 days, and yet when the results are out, it's not going to matter whether it was positive or negative or whatever the levels were. So,
thank you, Joel. Okay. Thank you, Joel. So kindly just tell us the why. Yes. We'll maybe invite more discussions, but just the why. So let's listen to Mwai Kibaki.
Okay. The use of early warning scores at Mwai Kibaki Referral Hospital came in as a response to feedback we received from our ICU team. They observed that there was delay in transfer of patients from the general wards to the ICU. They could pick up the clinical deterioration that had started like a few days ago, but the patient remained in the general wards. So they suggested that we change the vital signs documentation and start using the early warning scoring system. And that's how we started the journey last year, September.
Thank you, Winnie. Yes, Cynthia.
Good afternoon, everyone. So my name is Kuha, and our QI project focuses on has satisfaction through improved communication on treatment and aftercare instructions in the medical ward. So our main aim, we wanted to increase the percentage of our patients who fully understand their treatment and also their discharge instructions from 85.9 to 90% by 30th of June. So we did a current state analysis and we found out that there were unclear explanation in terms of their treatment and also their post-discharge instructions. And that's why our patients felt dissatisfied and confused at the time of them leaving the hospital. So we used process maps to identify the patient flow in the medical ward. We also used a fishbone analysis to determine what are the root causes, and we were able to do a Pareto chart to determine and break down these things into small parts. And also we did a run charts which help us to monitor our progress over time. And to address this, we were able to introduce patient education sessions whereby we were able to tell them how they get to know how they are going to be involved in their care. And also we did series on sensitization in terms of communication skills. So, and from there we were able to appreciate that our nurses and our doctors were able to engage our patient. Our patient was also involved in their care, and this also increased significantly the percentage of satisfaction in terms of communicating to our clients, in terms of their treatment and their aftercare instructions. And we applaud this project because it has really helped us, and it's still in line with the theme of co-production and in terms of safer care.
Thank you, Cynthia. Next, we'll listen to Marion.
Good afternoon.
Oh, sorry. Okay, as Marion is speaking, please allow me to interrupt session 7. The people in the room, we are giving you goodies. So somebody will come around and ask you a very awkward question. What size of shirt or hoodie did you wear? You will tell us whether you're a small, medium, large, XL, 2XL, 3XL, 4XL. Those are your options. Just to let you know, just a gentle reminder to session 7 that I will take over the mic at 3:30 p.m. Enjoy. Thank you for all the stories.
Yes.
4:30 p.m., sorry.
Okay, thank you. We've got Arguins. Just okay.
My name is Arguins, and I work in Kijabe. When I joined research in 2022, I was a part of a team doing a multi-country, multi-center surveillance for antimicrobial resistance. And while doing that for WHO priority pathogens, while we were doing that, we noticed that more than 70% for blood cultures grew, we had no yield, and less than 10% we had a positive true pathogen. And all of you who are pediatricians or even are doctors, you understand how frustrating it can be when you request for a blood culture and you grow a contaminant. And so that is why we thought that it would be important to do this, because then we do not want to overtreat our patients or undertreat them, or sometimes even contribute to antimicrobial resistance when we overtreat the patients with reserve antibiotics.
Thank you, Chagwira. And Marion. So this is what we are going to do. If you've got a question that you wish to ask our wonderful colleagues, just write it down. We will have a session because we want to have the next 7 coming on the stage.
Good afternoon. My name is Marion Jerry. I coordinate HIV program activities in Kiambaa Sub-County, and our project was on reducing hair seroconversion in Kehara Sub-County hospital by 50%. So why did we come up with this? Historically, Kiambaa Sub-County has always contributed to a very high number of hair seroconversion within the sub-county, within the county. And when we checked, we realized that Kehara Sub-County Hospital in Kiambaa Sub-County contributed to more than half of those positive haze. And that is when we started the CQI project in Kehara Sub-County. And after the project, 2-3 years down the line, we started the project in 2023 February. We only got a positive in February 2023. And from 2023 February to date, we've not had a positive hair since then. The CQI worked, and we are still monitoring monthly and hoping to reproduce the results to other facilities.
Okay.
Thank you.
Thank you, colleagues. I would request that you exit, but sit closer as we call the next set of wonderful colleagues who shared with us their work. Caroline Kendi, we've got Esther Sankale. Esther Sankale, Wambui Makobu, and then Susan Omondi. Kindly, colleagues, just step up so that we save on time. And you can clap for them as they come until they reach the stage so that they feel the energy in the room. Yes, you know, this is demonstrating impact. And we are showing evidence that some work is at least going on within the counties. Yes, and then we've got Sabina. Okay. So flip back, please. Yes, that on that one. That's the poster. That's your poster. Okay. Nicholas, I called you number 4. Come, you know, I'm looking at the numbers and they're not making sense. I'm looking at the numbers and they're not making sense. Yes, thank you, Nicholas. So we've got Caroline Kendi. So just tell us the why. Why was this particular project so close to the heart of the team? And pick it and say, this is what we want to see.
So my name is Kendi Caroline. I work at Halisi Family Hospital. Our why. So one of our strategic pillars as a hospital is quality improvement. So for us to be able to create a learning culture in the facility and improve, we needed data. So we realized we almost had 0 reporting of medical errors, which was a concern. So the project team sat down and agreed that we need to help our colleagues report errors without feeling the fear of blame culture. So our aim was to increase the reporting and everybody being comfortable to talk about the errors when they happen so that we can have good patient outcomes and ultimately create a learning culture. Thank you.
Thank you, Kendi. That's it?
No.
Okay. Yes, Wambui Makobu.
Thank you.
Yes.
My name is Wambui Makobu from Kijabi Hospital, and the title of our poster is Increasing the Number of ANC Attendants and Deliveries Through Maternal and Newborn Health Training. Why we did this was because there was a big number of women attending ANCs but the number was not reflecting in the maternity ward. So that is why we did this.
Thank you so much. Yes, Sankale? No.
For us, trying to do strengthening the primary healthcare systems using the Kaizen approach at Kampala Health Center, and the aim to streamline processes, efficiency, improve the quality. Yeah, I was saying the aim of our project was to improve efficiency and processes, and also improve on patients' flow. We use the Kaizen problem-solving methodologies like 5S and also various stream mapping to significantly reduce the turnaround time, which we were able to reduce from 120 minutes to around 45 minutes, and also enhance client satisfaction from 35 to 75%. And using the Kaizen approach, we were also able to embed the Kaizen culture in the facility, whereby the facility staff are able to use the data to improve the services as well as sustain the continuous improvement in the facility. Thank you.
Okay, thank you. My name is Susan Omondi from Nairobi County. Our success story is about transforming healthcare quality through health service delivery awards. Why we did this was just to encourage our healthcare facilities and inspire them to provide the highest standards of care to our Nairobi citizens. And with this, at the heart of this is the Kenya Quality Model for Health, which is a national tool. And over time, we have seen our participating facilities increasing from none in 2017 to over 100 in 2018. And with this is an ongoing process that we intend to continue with to nurture the culture of quality improvement across all our facilities. Thank you.
Thank you, Susan. That is leadership in action.
Good afternoon. I'm Sabina Nyaera. I work for Luala Community Alliance. And the idea behind our project was on one of the guiding principles that we have at Luala Community Hospital, that we wanted to promote holistic and dignified healthcare around primary healthcare and maternal and neonatal health. And in our why, one of our objectives was to ensure that the patient safety indicators and even quality of care indicators have been achieved, and these in return will help build trust and confidence from our communities, and by enabling them to receive dignified care at all levels at the facility. Yeah, thank you.
Thank you, Sabina. So, Rob, we have feedback number 4.
Yes, from Lamu County.
From Likoni.
From Likoni, yeah, okay. Yes, yes. Nicholas.
Good afternoon, everyone. I'm Nicholas Sogola. As a team, we are working on improving positive experience among clients who are receiving pre-exposure prophylaxis services of HIV at our facility, that is PrEP services. And we are aiming to at least achieve 90% from our baseline of 44 within a time span of 6 months. Having been convinced that when our clients are happy with our services, then their adherence will be good, and therefore the low rate of transmission of the infection. So we came up with an intervention whereby we had information, the knowledge sharing between client and also healthcare providers through the use of a pre-recorded audio megaphone and the pamphlets, the audio, we had also the chat, and through our WhatsApp. And within 4 months, we managed to achieve our target of 90%. We developed an SOP, that is a standard operating procedure, which we are following up to date. Thank you.
Okay, thank you, team. That was wonderful. Some work is going on, and we want to encourage the art of documentation. We want to document this work. So aside from this, within the mix, we had a wonderful experiential program that Acquire ran during the year. And some of these members were part of that. So we want to have them and delve a little bit and basically hold a conversation around their experience around that. So colleagues, so the Acquire experiential posters, the poster presenters, the authors, kindly remain on stage as the others leave. But my question now to the plenary, you've listened to them, you've seen their posters flash by, but we've got these posters on the Acquire website. Run through them as the session, as Dr. Tenza will be engaging them. If you've got a question, something has primed your mind, kindly bring it up. We'll give you an opportunity to have that conversation with them.
Let's give them a big hand of applause. I'm going to give you some reasons why you must give them a bigger hand of applause than what you've done earlier. It takes a lot of time to lead quality improvement teams. Most of work, some people, they do work that they actually didn't get to engage, but they presented. These teams, they really worked hard. And it takes a lot of work to have an ability to identify problems in the facility. We see growth at the front line, which is the vision for Acquire. There is an evidence of statement of leadership, and some of these presenters are presenting for the first time. Can I get a bigger hand of applause? Thank you very much. In this session, I would like to engage with our speakers. We know the history of Acquire. We've heard about it yesterday. Put it away. We know the history of Acquire. We've heard about it yesterday. And what is important is that we saw a bigger milestone last year where over 800 hospitals were engaged in the theoretical program. I'm correct, colleagues? So now, this year, for the first time, they had the experiential learning where they actually led teams in the hospitals, and these teams, they went through the work until they presented work to us today. We are so proud of you. So I'm going to ask you some questions as we engage. I really want you to start off with, you've already told us your names, and I just wanted to reflect on the experiential program which you've had. And tell us about your positive reflections. What stood out for you when you think back on this experiential learning program? Because somebody is seated here and is wondering, how is this program going? Please just give us some highlights. Thank you.
So thank you very much. First of all, I'll say Halisi Family Hospital had the QI team participate in the project. They're very happy because it was such a learning moment. So during our project on increasing reporting of medical errors, we realized that errors were actually happening. That was such a wow. happening, but people are not reporting. So what the team did and has continued to do, was have a mantra that reporting is valued, not punished. Even as the QI team go around the various departments, checking, they are telling our colleagues, we are doing this to learn, to improve, you're not going to be punished. So I think that was one of the greatest learnings, that errors happen, people are afraid to report, but with the project, we now have more champions, more people talking about errors. Actually, people being able to identify errors, which are the near misses, what are the really bad ones that can cause harm to patients. So the sentinel events, yeah. So that was, yeah.
For Mwai Kibaki Referral Hospital, we were part of the QI project that was championed by Acquire. And I would like to thank my mentor, who's here, who's Gerald, because he was the one, together with Dr. Samora, who guided us through the project. So our main focus, we wanted to enhance the patient satisfaction on how we communicate to our patients in terms of the treatment that they get and in terms of the discharge instructions. So the main goal, or the main thing that helped us that stood out, it was the use of the QI tools. We have already done the basic certification course. However, when we did it now practically by use of the QI tools, we were able to use the Pareto chart, which helped us to just identify this one, fix one issue at a time. And it also helped us to just appreciate how best can we address the issues concerning the communication methods. And from that, we were able to come up with the run charts. The run charts were able to help us even motivate our staffs, because they could be able to see real data at real time and be able to see this issue that you want to fix. Is it working for us? Is it applicable to us? And is it effective at the end of the day? So from the staff, we were able to monitor using the run charts, and the applicability of using the run charts. I'll request anyone who is in any QI project, please let's use these QI tools, because they are objective. And from our project, we are able to confirm that the QI tools are doable, they are simple, they are practical, and they'll be able to give you that evidence, that data evidence that you're looking for to help you improve your processes and your services. Thank you.
All right, thank you very much. In looking back over the project, the experiential learning and the poster presentation, so what really stood out for me is the intensity of the teamwork. The experiential training required that members of the team, there are 7 of us, it required our participation every week online for 16 weeks. That was intense, and then, so there was intense participation. Then there was, it forged us into a very strong team, and then we built very strong capacity, So it brought out things we didn't know we had in us and made us better persons. So we have built such capacity that we can take on almost any project within the hospital. So we now heard about the opportunity to present the poster. That was another level of the game entirely for us as a team. And I want to thank Coach Shagwin Aguirre, Coach BC Bubashe, and our MD, Dr. Sholak Mito, and all that participated in this program. It has made us a better person, and it has built local capacity in our hospital. Thank you.
Thank you very much. Thank you very much. I would like you to keep your comments online. Please do give some comments and questions from sisters. We will have some few minutes to take questions and comments. I'm just going to have the last activity with the 3 speakers at the front and hand over to Dr. Odo. Colleagues, now I would like you to help me, because there is someone somewhere in Africa whom now you, as the first cohort of the experiential learning, you are a role model. They look up to you, and they are wondering what was this about, what would it take, and I would like you to share a message, and imagine you are talking to the person who's looking forward to be in future cohorts of the experiential learning, and I would like you to share a heartfelt message that invites that person to be coming to that experiential learning. Thank you.
So I'd like to say that quality improvement, quality patient safety is our day-to-day. It is what we do every day when we go to work. Through doing the leadership course, the theory, and now the experiential projects, we were able to realize that the same concerns, increased turnaround time, patient experiences, incident reporting and errors, these are common across. They are not unique to one facility. They're not unique to private, to public. So our goal is the same, give quality care, ensure we do no harm to patients. So you participating in the leadership course, which Acquire is offering through IHI, will be a game changer. As I've said at Halisi, this has been a total culture shift for us. We now have improvement methodology we're using in our day-to-day. So now we have a funny thing we are saying, everything is PDSA. Even when you're doing your handover, it's a PDSA. So it is a good learning opportunity, and it is growth, and it enhances team collaboration. Thank you.
So for Mwai Kibaki Referral Hospital, first of all, we have started recruiting cohorts to join in the application currently that is open for people to now do the basic certification course so that they are able to get that knowledge for them to transit to the experiential course. So for me, I would like to encourage any QI team members in their various hospital that is important for us to build this quality improvement health system agenda, for us to have quality improvement projects in our facilities, because based on what we have learned, and if you do this in a structured way, by first identifying the problem, come up with determine your why, come up with your current analysis, get to know why is this problem there, focus on that one major thing, but do not focus on an entire process, just focus and fix that one thing, and you'll be able to intervene, and later you'll be able to see your results. Once you involve people, please involve people so that everyone can have a buy-in. So I request for any QI team out there in Africa, we need to build this conversation. We need to build an Africa that values quality improvement. And I believe we do not, in our cases, we don't miss any opportunities for improvement. Every day is a learning, and it's important for us to enroll in this course. So I beg you, please, for the next application, please apply, and you'll appreciate the project that you have already taken through, because you'll be able to see the results and everyone will be happy. So it's a win-win situation. Thank you.
All right, thank you very much. So that person watching this or listening to this all over Africa, first thing I want to say is that Africans have the responsibilities to solve the problems of Africa. Nobody is coming to the rescue. We are the players and the stakeholders in the health sector of Africa. The onus lies on us to solve the problem of Africa. Nobody's going to rescue us. Nobody's going to help us improve. So we have to take ownership and help our systems improve. So I want to encourage the person to take advantage of this platform provided by Acquire. Acquire is an Africa-focused platform for solving the problems of Africa in the area of healthcare, targeted at frontliners. So those who are the frontline. So take advantage of this opportunity. And then the other thing is, Acquire has provided a robust ecosystem of support. You are going to go through a robust training, and then you are going to have coaches who will handhold you. There are places you can't get to unless somebody takes you there. That's what we have experienced. Without the coaching we got from Acquire, we could not have done this. So Acquire has provided that robust ecosystem for learning and for capacity building. So connect to Acquire, submit yourself to the process. There is somebody there that will take you by the hands, and let's work together to make Africa a better continent. Thank you.
Very much. If you're online and you're listening to this session at the moment, please visit the Acquire page and you'll see how to register for the courses that we are talking about. I'm going to hand over to my colleague to take questions and that.
So you've seen the posters, you've seen the work, and maybe the thing that is burning inside that you'd really want to get clarity on. So quick ones from the online team and from the team that we have here. If you've got something that you'd really want to ask these wonderful people, including the first set that stepped down. So if you have something, kindly, can we see a hand or two? Yes, Dr. Rob. My wonderful presenters, authors, please take note of the question. If it touches on your poster, take a note and you'll rise up to give a response to it. Yes, kindly.
Yes, I was really impressed with so many of your posters. Thank you so much for all the work that you did. I think QI projects can be scary because they can uncover things that are uncomfortable. They can uncover errors. They can uncover, we had a case of abuse being found, low patient satisfaction, et cetera. I wanted to know what was it like engaging with the leadership of the health facility in some of those conversations where you might uncover some uncomfortable things?
Thank you, Dr. Rob. Any other burning one? Something that is close to your heart when it comes to QI? Okay, good. So, online team.
I have online.
Yes, kindly.
So, first is an expression, online participants are missing out on this. Well done. Then there's a question here. How is the PEC, survey information, validated? That's all.
How is the
PEC?
Oh. How is the PEC survey form validated? So that one I think came from Nicholas. Was that from for the patient experience, the one that the patient experience poster, the patient survey? There's a team that did a patient survey. Kindly just rise up where you are. I bring the microphone to where you are as the wonderful team here are going to share that.
All right. Thank you very much for that question on the attitude of leadership to uncovering uncomfortable truths in the system. So in our own hospital, the process was actually initiated by a former MDCU around February this year. She said, Dr. Mafe, she said we should do a survey on waiting time in the clinics. There are about 16 clinics. So we surveyed over 200 patients for a whole week, and I came out with some very unsettling truths. In some of our clinics, some patients were spending up to 6 hours to see the doctor. Some of the patients spent up to 8 hours in a day before they saw the doctor. So we did the survey, we took the result back to her, and she said, wow, we had to work on this. So in the middle of thinking of, okay, what do we do? How do we improve this? The Acquire stuff came up. You know, we started the training, and in the midst of the training, we were told to do a project. So naturally, we just gravitated towards the project, a project on the problem we had identified. So our own hospital was in full support. We had full support of hospital management. So it was scary that patients would spend up to 8 hours before they saw a doctor in the clinic, and the management was committed to whatever we could do to solve that problem. We took on 4 clinics to start with for the project, but eventually realized that it wasn't feasible because the dynamics in the clinics were different. So we settled for only the cardiology clinic. And our plan is that after this, we'll go back to implementing some of the change ideas in the other clinics. So management, it was a rude shock to management, but then we had the support of management to do whatever we could to make it better. Thank you.
In the context of Mwai Kibaki Referral Hospital, our CEO, who's Dr. Peter Mwiruri, is very passionate in terms of patient management. And this is in line with our vision whereby we want to optimize that customer experience in our facility. So when we had this project in place, we had already appraised him and he was in full support. And to back on this, we formed a QI team that was multidisciplinary, whereby we involved all cadres who were able to work on this project, and also our team leader was our immediate supervisor, who was the head of the Department of Healthcare Quality, who is Dr. Einstein Kibet. So from that, we were able to see buy-in from the leadership, and there was that accountability and commitment, and we used to appraise them on our progress, and they used to appreciate our run charts, because from the run charts, we were able to see the before interventions, how things used to go, and over time, we were able to even appreciate and also see the significant increase in terms of the percentage of our patients. Also from the customer feedback, we were able to see that patient demonstrated that now I'm able to understand what my illness is, and now I know what matters to me. And we were able to also get feedback from our staff, who are able to also demonstrate and see that this is a good thing. So yes, we had leadership backup, there was commitment, there was accountability, and also to sustain this, they still job to be done, and this still has the backup from our leadership. And I believe if the leadership has your back, then your quality improvement project will be a success. And for that, I thank the management of Mwai Kibaki Referral Hospital. Thank you.
So it is very true that without leadership, we won't be able to achieve quality. So at Halisi Family Hospital, one of the things we did was the entire senior leadership team, including our managing director, participated in the leadership training. So with each one of them understanding what is quality improvement, how is patient safety my concern, even the finance department is able to allocate resources. So with each of the leaders participating and understanding their role as leaders in enhancing quality and improving patient care outcomes, we realize that because of their championing, because of their role, we have more uptake of the initiatives. So that means even the other frontline staff and everybody in the facility is eager to learn, eager to participate in the QI project, because they see models from the leaders. Thank you.
Thank you, team. And Kizito is going to give us a feel of how they validated this survey tool.
No. Okay. Yes, good evening. So I want to respond about the validation of the questionnaires. So we developed the questionnaires with an aim of promoting patient-centeredness care, and these questions were based on selective themes. So we had to select some of the areas that we needed to see how we are performing, and this information was shared with our hostel administration, where we had the voices of the hostel matron, we had our medsup, and we even escalated this further to our county director so that they give us his input. So that is how the questions were validated, and we had to administer the questionnaires to our patients.
Thank you, colleagues. So as we wrap up, I'm inviting the wonderful colleagues to come back and we have our moment of a photo session. Kindly come up, the initial batch, so that we gather here. And as they come up, I want to give us a reflection on some of the key highlights from this session. So, generally, for buy-in, we always hear the questions, show us the impact. If you want us to get into this, show us the impact. So this is what demonstrating impact is about, and documenting. So from what colleagues have shared here, there are some highlights that I would wish that we take home. One, we've heard from Oga that the coaching experience was top-notch, okay? And coaching is key in the quality improvement and patient safety journey. We've heard from Mwai Kibaki, the team, they've said that yes, through the theoretical learning session, they were taught about the tools, but the know-how of utilizing the tools was missing. So the coaching session came in to plug the know-how. Yes, you taught about the tools, but how do we use it? So that is the other key takeaway too. The third takeaway that we need to not forget, the Acquire team. Oh. Okay. Good. So the other thing is that the wonderful work that is happening across the African continent, what we are doing here, we are demonstrating that work is going on, and we are documenting this. And that is what counts for evidence for impact. That is what we are demonstrating here. And we agree that whatever has happened throughout the sessions, we've got some elements of kindness, co-production, all infused into the process. And I would not want to wrap up this session without saying a wonderful thank you to the great coaches that Acquire had brought on board to work with the teams across the continent, hand in hand, and guiding them through. I think that was also marvelous. So we wrap it there. I think Dr. Tenza will say the last final sessions as we close out this session. Thank you so much.
Colleagues, but please give yourselves a biggest hand of applause for your attention.
And I want to thank Dr. Tenza, Dr. Odwar, and Dr. Elom Ochi in absentia. They reviewed everything, they came up with the criteria, they encouraged everyone. You see, they refused to fail anyone. They're like we are here as encouragers. We are here to encourage scientific writing. So thank you to the people who have taken their time to plan this. So we are now at the stage of closing. And this closing can be as long or as short as you want it to be. Online people, I'm assuming you want it to be short. I'm going to request Museo to take her seat in a couple of minutes because I will need her to set up breakout rooms to answer this question. So first of all, I want to make sure we are all on tables with multiple people. So you need to join a table, you're two. You need to go find the table behind you, join another table. Because this, I'm going to go around the room and hear your responses. But first, let me do that thing where I dial back. Many of us were here 2024, same hotel, right? Same month. And if you remember in the closing, we had a long list of short-term actions and long-term actions. Do we remember what some of those actions were? So in that, there were short-term actions and there were long-term actions. And I want us to hold ourselves accountable. You know, a part of improvement is being honest. So what did we do? The first thing we agreed is that we need a WhatsApp group, a community on WhatsApp where we can talk to each other. And immediately, all 700-800 of us, online and in person, joined a WhatsApp group. So why don't we give ourselves who's on the WhatsApp group? Who's on the WhatsApp group? Okay. Then, do you remember what then happened? We divided ourselves into 3 thematic areas. I want somebody who is on the WhatsApp group to tell me what those 3 thematic areas are. What are the 3 WhatsApp groups? Yes, I want someone to tell me. I wasn't alone. We are 800.
Okay. Training, we have patient safety, and we have general QI platform.
Which one is missing? There is patient safety. There is one that is missing. That's training and curriculum is one. Patient safety is the second. What is missing? No, the general group is for everyone. There is a third one. Hiya. I'm coming to Lydia. What is the third one? So which are the 3 groups?
Patient safety, then there is training, then there is quality improvement, patient experience.
So one of the things we'll ask ourselves was it a good idea to choose those 3? So I hope online you're keeping up. The WhatsApp group has 3 groups, 3 thematic areas. Quality improvement and patient experience, which is the one we are forgetting, patient safety, and then training and curriculum development. So we did well. At least we identified the 3 thematic areas we are going to work on, right? So let me do a thank you much to all of us. And then we decided to do something together. All 3 thematic areas had webinars. Who participated in those webinars? In September and October 2024, all 3 of those thematic areas held webinars. We had speakers, we had hundreds of people join us on those webinars. Wasn't that fantastic? So we at least achieved our short-term actions, didn't we? I think we give ourselves some yeah, we did. I mean, 3 different webinars. Fantastic. By then, those webinars are available on Acquire's YouTube channel. So we can always go back and check our records. So I want us to evaluate ourselves. That's the first thing we are doing in our groups. Did we do well? Did we meet our short-term and long-term plans? So I'm hoping that in every table there'll be someone who was here last year who can remind us. And then now I want to ask the next question. After those webinars, has there been anything else happening in those WhatsApp groups? And I'm going to walk over to Odor to hear.
Yes, other than the webinars, we put in some fuel, we lit some coal, and unfortunately, we couldn't keep the coals burning for long. And I think that is what happened in the WhatsApp groups, especially in the one that I was in. So we achieved our short-term goals. We got underway with our long-term goals, but somehow, I think we hit the road. I think if you can remember that road that Professor Bukusi presented, where the truck got stuck, I think that's the kind of road that we hit.
But we've had 2 days of perpetrating this fire. How do you say that in English? You all know the action I'm doing to the fire. Fanning the fire. Isn't that what these 2 days has been? We have fanned that fire. So now I want us to, as we evaluate ourselves next year, I'm going to go around each table and it will be bullet points. And I want 1 short-term action and 1 long-term action. And as you're saying, what is the action, who is going to do it, and what is the timeline? That will be her action. So make sure your table says that action. So I want us to agree. See, we have fanned the fire, and we don't want this fire to die. So what will be your role in this short-term and the long-term action? By the way, you should be happy to say, I will publish, I will be a writer on the white paper, whatever the good idea is. Make sure you are very clear who the actor is. And please don't assign someone else an action unless you know you will support them to carry it out, right? So it is now 4:35. Museo put people into WhatsApp groups in groups of 5, just the way we are. So just do the virtual breakout rooms. And the thing we are asking everyone to do, one short-term action, one long-term action, who is the actor and what is the timeline? Because God willing, we will get to do this again in 2026. And we don't want to have that evaluation where we know the fire fund. We've barely done anything since those webinars. But we're here. How do we keep that fire burning? So I'll give you 5 minutes, okay, up until 4:40. So 4 minutes. So talk quickly, agree quickly, each table, one short term, one long term. Thank you. I want to start with the online people, so maybe we close the online groups first. So this is me giving you a 30-second heads up that we are about to start going around the room, and I would appreciate whoever has the microphones to give me as many microphones as we can.
Good idea.
Somebody on the microphone. Does Museo have a microphone? Because I want us to start with the online people. She's closing the breakout rooms.
What is it?
So we have our one short-term action and one long-term action ready. Angie, where is Angie? Okay, so Phil, please help us take note of this one short-term action, one long-term action. Who is doing it and what the timeline is. So you put it on a table for us. Short-term, long-term, who's doing it, what is the timeline. Thanks, Phil. So I'm gonna, Musa, are we ready with the online groups? Should I start? Let me start with the ones in the room. And I feel like this group looks ready. Okay, who wants to go first? Maybe that's an easier way. Okay. Now, because we don't want to spend all time here, if somebody else says your short-term or long-term action, say, just tell me pass, don't repeat. We don't need to hear two different people say it, okay? We're adding to a joint list of an agreed action, right? So if someone has said it, just say pass, so that you don't have to repeat it. Go ahead.
Hi, everyone. Okay, for our short-term action, it's we are going to give immediate feedback to the facility on the 2-day training, the conference, on what we've learned, and it's immediately once we go back to our... Thank you.
Long-term? And we'll hold you accountable by you copying us, right? So you'll copy us when you share to the facility, because that's our way to know if you actually did. Great. Okay,
For the long term, we're going to do the co-production projects, different facilities, and then we are going to publish.
Wow, July 2026, here we come. Beatrice, you said you're going to publish. I heard you, loud and clear, so did the entire room. You have 100 accountability partners. Who wants to go next?
All right, thank you very much. So on this table, our short-term goal is to immediately recognize projects we are going to start working on, QI project in our hospitals. Long-term project is, by this time next year, there will be 6 posters to the Acquire July conference next year from this table.
6 posters from this table. Can the camera get their faces properly? Because I think we'll start the conference by showing faces. Long-term? Oh, that's long-term. Okay, anything else? Okay, I want to go table by table. Short term, long term?
I think they've said the short term. Long term, introduction of podcasts as a way of communicating the acquired.
Wow,
agenda.
so who's doing it and what timeline?
6 to 12 months, and I've been given that responsibility.
Bernard is starting a podcast, people. Short term?
Short term, they've said the
Okay,
posters.
thank you.
The posters.
Yeah, thank you.
Thank
Yes,
you, Ruth.
thank you as well. This is exciting. I hope you're getting excited as I'm getting excited too.
Okay, thank
Don't
you so
repeat.
much. Would like to actually promote Acquire. So we are suggesting that in the long term, all abstracts that come to the conference that have been accepted, the Acquire team incorporates a video so that the members who have done, they post also a video. It can run during the time breaks and also...
Are you aware that all the posters are on the website available for public viewing?
Yes.
So please don't, I hope you're promoting quality improvement and patient safety.
Yes.
Acquire doesn't need promotion.
Yes.
The issues need promotion.
Long term would like...
Oh, you want videos?
Yes, videos. So that there's more time to appreciate their story.
So the person's like next to their poster? Okay, talking about their work. Okay, that's an ad. Okay, I've understood.
Yes. Then the short term, during the short term, we are suggesting that we develop a webinar monthly. We shall always share maybe 2 stories a country, and we shall log on, we share the links in all our countries, and then we learn what other people are doing.
Okay.
And when we leave here, we go, like me, to my council and request them to accredit, acquire that platform so that members who attend can get CPD points.
Okay, so I have a question for us. Who has attended the ISQA, International Society for Quality, Africa Community of Practice webinars? They take place monthly. Do we need a new webinar platform, or do we join the one that is already there?
This one is for Africa.
So this one is for Africa. Is there a reason you're not in the monthly webinars? Okay, so when we do our takeaway email, we will make sure we put all the links there. Let's not generate new webinars when there's already a webinar platform that exists, right? The ISQA AFCOP community, Africa Community of Practice, is there. Many of us already are a part of it. I represent Acquire as the vice chair, and there's Dr. Lachman was the last speaker. Great speakers coming every single year. That's a platform that we can use. Good job, people. Let's keep getting excited. Okay, let's come here.
So our short-term plan is to get certified in quality improvement and become certified and become coaches in quality improvement.
Okay. Who's certifying you, and by when?
You Acquire is actually offering a course in quality improvement in theory. So we registered for that.
Okay.
In Malawi, there's also another platform that is offering a course. So either we go for...
Which one is that one? Let's let everyone know. We are putting the information out.
Okay, so this one is offered by Kamuzu University of Health Sciences in coordination with Learning Center for Quality Management in Malawi.
Are you able to avail that link? So email it to us so that we share it with everyone.
Yes,
we want to be those people who hold the information as if we...
I will share with everyone.
Okay, thank you very much.
As for the long-term plan, it's for us to... I think they already presented, our friends already presented. We said something about presenting a poster and publishing maybe in a journal soon.
Tell me your name.
My name is Punzo Rajab. I'm from Malawi.
So this gentleman flew all the way from where?
Malawi.
He brought himself.
Yes.
He brought himself because that is the level of his
commitment.
Can we just give him the ovation he deserves? It is my honor and pleasure to meet you. Thank you. Thank you. Welcome, Punziro. Okay. This is me trying to rush.
Thank you. I think the immediate one has been answered. The long term has also been answered, but we wanted to make an addition that we are going to encourage more facilities to join the Acquire platform and also to do their course.
Thank you for promoting quality improvement and patient safety. Acquire, secondary.
I'm Wilson from Kijabi, and our short-term action is to promote kindness in patient engagement.
Have you heard that?
Yes.
Promote what? I need you to say it loud enough so that the microphone hears you. Repeat, you're here to?
Promote kindness in
tell
patient engagement and care.
These 2 days were worth it?
Yep.
Okay.
Thank you.
Did you have a long time or it's a pass? Okay, thank you. No need to repeat.
Hello, everyone. Our short term was to include the new members who are not in the WhatsApp groups into the WhatsApp groups, and for the new members, as they join the WhatsApp groups, to share projects that they're doing. So the QI projects that we either completed or like in our team we didn't complete, we'll complete and share in the WhatsApp groups and make it like more active, lively.
So who is the doer of that action?
We will, we'd like to know who from Acquire would.
No.
Yes.
We said you won't assign someone else an action.
Okay.
If you decide an action is important, it means you are ready to do it, right?
Yes.
Okay. Who is the doer of that action?
Myself and Adija.
Well done.
And then
I like volunteers.
For the long term, it's been mentioned, but I think we had an idea where, imagine if we had one common problem in the whole of Africa and we decide that in our different areas we will do a QI improvement project for this one, let's say, common problem, and just see the differences in how it will be implemented in the different countries.
So like a peer, like multiple peers doing the same
thing throughout the country.
I love this
the
brilliance,
continent.
guys.
Yeah.
Now turn it into action. Lydia, I'm coming to you last. Do you have other things to say? Okay.
So Violet Makoha is my name. Okay, so most of our short term is already passed, but just to add, all presenters, poster presenters who have not done the basic theory training, this will ensure we reach out to all of them to register in the upcoming training. And then for the long term, we want to build long-term goal that we had in the previous year on patient safety action plan. So we want to continue with the webinars, and all of us.
Who is the we?
Okay. So all of us on this table will be presenters in the webinars.
So you're volunteering yourself as experts?
Yes.
Okay. Please, camera, note these people, because we are going to follow up on this. We are not going to be loose speakers. This year we are going to act, right? Okay. Thank you.
Good evening. So our short term is we are going to give feedback to our respective facilities and also to encourage our colleagues to register in a group of 6 for the coming, I believe that is the end of September, HI basic quality improvement and patient safety, and our long-term goal that the teams also will do their respective quality improvement projects, and that will be shared with the Acquire team, and everyone in the WhatsApp group will be able to celebrate our achievement.
I think we are about to have a lot of happenings in that WhatsApp group. Don't you agree? Good job, people. Awings, you have been volunteered. Have I heard your voice today? Yes. Okay.
On this table, we have actions for ourselves and Acquire leadership. So we are going to document patient safety and quality improvement, including co-production stories on our socials.
So these people around this table, they want to share stories.
Yeah, we want to share stories. And also we are committing to do mentorship of teams in our hospitals in quality improvement. And the long-term goal was for Acquire team to consider an African journal where we can write and publish.
Oh, Dr. Lachman has a journal ready for you. Maybe not an African one, but an African targeted one. ISCO Communications is available. I'm sure he'll tell us about it in a moment. Have I come to this table? Not yet. Who is the speaker? There, Nicholas, good job.
Yes, for the first short term has been mentioned, so we just passed it. And on the long term, we've decided that we are going to scale up the newborn in the house, that is a co-production, to ensure that we want to see at what extent are we formally establish it and monitor its progress in our facility for each and every member.
Wow. Okay. Yes, take the microphone because I can see you have something to say about that.
Yes, I just wanted to highlight that one of us from Kijabe has promised to invite us to go and see the good things that are happening in Kijabe.
There we go. Site visits, field visits about to happen. Document this. We want a photo of Wamboi when they come. Allow us to follow. Have we been here? You have been volunteering. Oh, it's Colleen, obviously. I know things about Colleen. I know she has a grandnephew. Is it a grandnephew?
A grandson.
Grandson.
Yeah. Yes. So our group short-term goal is to make sure that the webinars are happening at least on a quarterly basis, and we already have volunteers here to be speakers of the different topics that are captured in our theme. So starting August, the theme of co-production, of kindness, all those things that we're doing.
So we should just be asking who wants to speak and somebody will be ready.
Yes.
Okay.
Not the faces.
We are noting the you know you are on camera.
Oh Lord. Okay, and then long term, like another group has said, publication. But what we thought is that Acquire can help us to make sure that all the teams and the countries represented here are actually part of multiple sites so that we can gather information from all those countries and regions and hospitals about co-production. So the timeline is by next year, by the next forum, we should already actually have a landscape and a baseline for all those areas, and then we now move forward together.
Okay, the good thing is, Colleen, I know you, so when are you submitting the concept note so that we action it? We started with here. I think here is what we've not had. We have. Have we had here? Okay. Okay.
This table. Hello. So for this table, we have felt challenged, especially by the private facilities who have a quality and safety unit. And one of our short-term goals is to visit those departments and get to learn what they do. And for a long-term goal is to actually push for such units in the public sector, because in the counties we don't have it. They are there in the Act, but they are not activated.
So you don't have anyone in your hospital assigned as a quality improvement leader?
No.
Okay.
Yes, but we have CQIA focal people, so just to reactivate that. And to Acquire, we are requesting as a team that you also push for an accreditation board just like Ethiopia's. Now that's to you. You decide who gets to take it up.
Okay.
A request.
So now we are accreditors. We are hearing all of this. Who have I missed out on? Is there a table that has not spoken? Musa, are we ready with the online? Yes, I'm walking to her. After this, we are going to give Dr. Lachman a moment to say his final words, and then we'll do thank you, and then remember, be ready for a dancing photo. So, Mseo, online, what are their long-term and short-term actions?
So we have Christina Mlenga. She wrote and said her short-term action is to improve patient satisfaction with 70% positive feedback through survey in pediatric ward. And her long-term is to attain a certificate on the quality improvement from a recognized healthcare quality board within the year, and to also ensure high-quality care and clinical services.
Wow.
Oh, and she's also said attend physically 2026 Acquire Leadership Conference.
There you go. If Mr. Funziro can bring himself from Malawi, why are you not here? I agree. Keep going.
That's the only one.
Okay. Thank you very much, everybody who has participated. We are holding ourselves accountable in 2026. I want to invite Lydia and Mary to the front as I invite Dr. Lachman to give us his closing comments. What is his idea? Are we really going to sustain this? What does he think we should do next? Let's hear.
First of all,
I want to congratulate you because not many conferences, everyone's still sitting at 5 o'clock on a Friday. They're normally gone by now. So well done. A big round of applause to everyone for being here. And the posters, very good. So this is communications, okay? And the good thing is it's open access so that it's not behind the firewall. You usually have to pay for it, but I just checked. Even South Africa's free. On a different thing, Kenya, Nigeria, Ghana, because they are real LMIC. South Africa kind of is MIC. So they are on different level, but it's free to publish. That's very important. So if you scroll down, Ron, could you scroll a bit till we get to the instructions? All the way down, all the way down. Okay, back up. Back up. Where they get?
Here.
No, they've got to get to the down. Oh, there. Come up. Article types, go up till they get quality improvement reports. Where's there? Quality improvement reports, click on that. There's the quality improvement reports. They have to follow the Squire guidelines, which you can download. And some of your projects are short projects, some could be longer projects. But I think that's a good place for the journal. It's good for the journal if you start publishing in the journal. They're looking for papers, I know that. And there's a new editor, and he's keen to have papers. And what you have to do is start really showing the good work that's going on in Africa. Because one thing was really clear to me today, is that there's power in Africa. So the African power, that's what I saw today. And you should be very proud of yourselves, all of yourselves being here, because this is the way forward. It's really the way forward. I was saying to someone earlier, you know, it's a tragedy that USAID are out, but to me it's a big opportunity as well. It's a big opportunity to get off dependency into self-sufficiency. And the same happens in quality improvement. We've got to work ways that you solve Africa's problems by Africans. So that is what my big message is to you, and I want to thank the Acquire team, because I wouldn't be here if I hadn't met Lydia. I knew her from before from WHO, but then I met Mary, who asked those difficult questions at my session last year in Istanbul. And then they said to me, would I be on the board? And of course I said yes. So thank you very much. And thank you for everyone here. Thanks a lot.
Because of Dr. Lachman, we now are having to actually document and publish our work. We're just not doing it willy-nilly. He won't let us. So now some of us are now participating in a PhD program to document this work. So there's a lot of accountability in this room. So hopefully next year, there'll be things published, things said, things done as a result of these conversations.
And the podcasts, a wonderful idea, the podcasts. They're not too difficult to do because people always ask me to speak on their podcasts. And so I record a podcast now for Brazil last week and for WHO coming up.
So you're volunteering for Bernard's?
I'm not volunteering for the first one.
Yeah, there you go.
But for the podcast, all you need is a microphone and speaking and then editing. You do a bit of editing, and then you put it up onto one of the podcast platforms.
Yeah, and they basically are
you put it on. You can even put it on LinkedIn, on the Acquire LinkedIn.
Yep, that's easy.
And that's the easiest way. And then you've got your podcast going. A very good way to do it. Stories from Africa. There's the title.
Okay. So we don't want to take too long. We want to thank you for your time. I mean, the ideas have been amazing. The engagement has been amazing. Everything about you has been amazing. And so I want to thank you so much for your time. But there's something I usually say, ideas are 1 in a million. The action, the execution is how we really know whether the fire is burning. So I hope when you leave, you'll just see me doing this action. Are we putting the fire on or off? It's been very exciting being with you. Let me give my colleagues a chance to say thank you.
Mine is to say thank you, but before I say that, I think I have a grandmother role for quality and safety. So there's the technical working group for MOH. Are you here? Anybody in the technical working group for patient safety? Technical working group, Mary is here, Carol Mukuha, there is Dr. Rhoda Kalondu. Who else? Then there is Elizabeth Sankale. So, and then we have also Gerald and Peter Mutanda. So those are part of the technical working group at MOH. It was newly launched. They have a working, you have an action plan which they have developed. So just for our information for Kenyans. Then we have the people who are part of the framework for quality. They were developing the framework for quality and they are in this room. Is there any? We have Violet, Odwar. Yes, we have, how can I forget? Grace, yes, we have Grace. And so there are multiple people. So those are resources because when we, all those documents have the aspects of accreditation, of what to do. And then there's the technical, the quality of care bill, which SQHK had an opportunity to share with its members, and you have all done that in your various groups. So those are things that are on the pipeline that I thought I should not miss to acknowledge. Then there's a JCI patient safety initiative that will be starting soon. KUTRH, they're here? Yeah, they'll be getting the appointments, and then KNH, I think Dr. Kalondu is here, and MTRH. So that one is a good opportunity for them to share with us what they will do when it starts. They are still in the formative stages. So without much further ado, allow me also to come home and introduce the Society for Quality Healthcare that you are welcome to join. Acquire is great, but the professional fires. That's why we have Damlola here with us from Society of Quality Healthcare Nigeria. So kindly, if you're interested, there is a form, there is a link. I don't know how, maybe Carol will put it on the LinkedIn, and then we'll be able to go there. So just go for SQHK on LinkedIn. You are able to join Society for Quality Healthcare. If you realize the people who are easily being called to support Acquire are from society. So kindly take the opportunity to get your hands on the treadmill. So there's a fanfare of what we can do coming in here. So allow me now to go to really being grateful for you taking your time to come here to Movenpick, to the second Acquire Leadership Forum. Quality improvement is our business, patient safety is our business, and Africa is our business. The healthcare in Africa has to do better. We need to get better outcomes, and that can only happen if we have UHC infused with quality and safety. Even with the many things we do, we need to have quality improvement. So thank you for the participants from the countries that came. Thank you for those that came from the counties of Kenya. Thank you for our panelists, for our speakers. Dr. Peter Lackman was our great main speaker. So we are truly grateful for all of you taking your time to come. So may the good Lord bless you as you go back. In Africa, in Kenya, we say, Asante sana. Asanteni sana.
And I want to give a big Asanteni sana to the Acquire staff. Give them a clap as you're dancing up here to the front for a group picture.
So let everyone come. I hear, yes. And as they're coming, I know Mary has some thank yous too.
I also want to thank all of our planning committee members. They helped build the different sessions and bring them out. A great thanks to our speakers. We've seen people from many different walks and domains bringing us inspiration.
So just pause so that people come, otherwise we'll be able to do both. Yeah. They're waiting to listen. Kindly come over. We wanted to have you chew gum and walk, but now we have to, let's just come to the front. We want you out of this room by 5:15, so we are really sorry for taking 15 unplanned minutes of your time. So just come to the front. I guess some people need to go on the stage. Look at Tenza, well done. Let's go to the stage, some of us. Yes, we will bring some seats. Amos, should we do seats? Okay, no, actually, let's not do seats. He will get on a chair. You'll go up. It's okay, the cameraman will stand, yeah. That's okay. Okay, so, Mary, go ahead.
I wanted to make sure that I thanked all of our planning committee members, our planning committee members, the amazing speakers we've had. A special thanks one more time to all those who were brave enough to submit posters. And thanks to you for being here.
So Amos, we want to thank everyone. Sorry, everything is not working. The music has to go so that Amos takes it and then tells us whether he's seeing everyone's face. Yeah, I guess we go sideways. If we do sideways, we'll all Amos, you might need a microphone. We have 30 seconds. Can you see everybody? Is everybody coming on? Okay.
It's a celebration.
Thank you.
It's a celebration.
Ron, can you get us something that has a choir? Okay, we might not get it. It's okay, you'll Photoshop it. Let's go. You'll Photoshop it. Amos, time. Go. Okay, let's do a fun one. So can we do a fun one with a choir? 1, 2, 3. Let's all go a choir with our hands moving. A choir!
It's a celebration.
If you find yourselves doing that repeatedly online, we are thankful. Thank you so much for your time. Have a lovely evening, everybody. Please, I hope every foreigner has a Kenyan who's showing them around. Everybody who's not from Kenya, I hope you have someone showing you around. I hope you've made a friend. Funziro, I hope you're not alone. Douglas, I hope you have found some Kenyan friends that are not from MBF. Thank you, everybody. Thank you very much. Sorry, Mary. Just wouldn't work.
Let's celebrate. It's all right.
we will send the WhatsApp group link in the email. So if you're not in it, it will be a many links of things. So expect a Monday morning email with a lot of information. Click on it. Everybody will have access. It is free for all.